Dr. Puneet sir, Dr. Saunakpal sir, Dr. Rajesh sir, Amrinder sir, and Dr. Vimal sir. So we'll start with no delay. The first talk by Dr. Kabilan on acute PE, device versus lytics after peerless.
Check, yeah. Good morning, everyone. I'm Kabilan. I'm a consultant in interventional radiologist serving a government hospital in Singapore setup, serves the northern part of Singapore. I don't have any conflicts of interest. Acute PE, when it comes to public healthcare issue, it is still remaining to be the third most common cause of cardiovascular death, despite our advances in the treatment modalities. And the physiology behind us, most of us are well aware that a massive occlusive PE, when it blocks pulmonary vessels, there is increased RV afterload, after which there is possible dilatation of the right heart, which results in tricuspid regurgitation, which also reduces the RV output. Then the distension of the heart releases neurohormonal activation, and myocardial infarction and inflammation sets in. That's why we see increased levels of cardiac enzymes, right, which is an indirect marker of right heart strain. And then the last phase is when the LV preload also declines, and then low cardiac output sets, and that ensues in a systemic BP that goes down. So when the BP is low, it's already the later stage, the end stage of the presentation of massive PE. So the death is very imminent. So it is imperative to think that rapid removal of the clot burden will help to reduce the cardiac stress, and that thereby it increases the chances of living for the patient, right? This is the classic, typical risk stratification, how European Society of Cardiologists have divided, and this is the same stratification we also follow in terms of management, wherein high-risk patients, high-risk PE has systemic BP that is low, they are called unstable. They received RTPA, straight away thrombolysis if there is no major contraindications like intracranial bleed and stuff like that. And intermediate risk, again, they are divided into low and high risk, where there is no shock, but then there can be signs of right heart strain, plus the PESI score is high, and the cardiac enzymes may or may not be elevated. And low risk PE is when there is no systemic low BP and there is no signs of heart strain. So these patients are typically monitored and given anticoagulation. You can actually manage an OP and send back. So the intermediate risk, the high and low risk intermediate, they are the one they form a therapeutic dilemma, right? So the mortality also differs according to the risk, and the low risk is very less than 1%, and the high risk is in the range of 25 or more. So the intermediate risk is very heterogeneous. They can fall on either side. So their mortality risk is a little bit on a wider side, between 5 to 15%. So it is imperative for us to actually tailor the management according to the patient in this high risk as an intermediate risk group. So what the PLS study did was that this is the first randomized control trial that compared the interventional strategies for intermediate high risk pulmonary embolism. They didn't compare IR strategy versus anticoagulation, which is standard of care now, but it compared between large bore mechanical thrombectomy versus catheter directed thrombolysis in 550 randomized patients across USA and Europe. And then their endpoints is not single endpoint, it's a win ratio of composite 5 endpoints, including major mortality, major bleeding, clinical deterioration, bailout procedures, and ICU admission. And so they were monitored at 24 hours after discharge and also at 30 days. As you can see, in intermediate high risk pulmonary embolism patient population, the interventional with large bore mechanical thrombectomy reduces the likelihood of patients likelihood of clinical deterioration and escalation to bailout therapy, and also the hospital stay is significantly low in this large bore mechanical thrombectomy device arm when you compare it with the standard catheter directed thrombolysis. And the safety profile is comparatively similar. There is no wide difference in terms of safety profile. Both are demonstrating a reasonable safety profiles. So the key takeaways, I would say, is that it's the first RCT that compares two major interventional therapies between large bore mechanical thrombectomy and catheter directed thrombolysis in these intermediate high risk patients. And then a large bore mechanical thrombectomy significantly reduces the clinical deterioration and ICU utilizations. And both strategies demonstrate excellent safety profiles, very comparable, and faster symptom relief with mechanical thrombectomy, which is very, very significant. So this might form a strategy forming in terms of how we are going to see the societal protocols in intermediate high risk later. And I saw few limitations in this because it's an open label. All large bore mechanical devices used in RE, and it's open label one. So there is a chance for bias. There is no comparison between interventional procedures and a standard anticoagulation alone, which is the societal recommendation for intermediate risk PE as of now. And the CDT is not standardized. The group is not homogeneous. Half of them were like they used ECOS from Boston, and half of them used perfusion catheters like McNamara. So it is not homogeneous, and there is IC utilization of the catheter-directed thrombolysis. Because they use RTPA, it is high. So naturally, there is a bias there. So these are things that which I identified as a flaws. And if you compare the cost, this has to come into play when you decide between the interventional management. I'm talking about Singapore scenario, and I think worldwide it's going to represent the same, maybe the currency exchange rates. The flow retriever by Inari is costing about 10,000 Sing dollars. It's about 7 lakhs. Lightning Flash is similar to that, and ECOS Boston about 3,000 per catheter, but if you are putting like 2 catheters on each side, it's going to cost like 6,000 Sing dollars. And McNamara catheter is the cheapest one, but it also comes with reduced effectiveness because it doesn't use ultrasound assisted thrombolysis, right? The another study which has come recently in the last 2-3 months, like 3 months before, by Penumbra, is THOMPE. This is very important as well because it compared mechanical thrombectomy by Penumbra versus regular anticoagulation alone. This is something which we want to see. Though again, it's an open label one. We can see they had the endpoint of comparing RV-LV ratio at 48 hours. So why they saw this, took that as a primary endpoint is because the RV-LV ratio after 48 hours is something which is directly correlating with mortality. So increased RV-LV ratio of more than 1.1 is 3 times increased risk of mortality. So you can see the difference is significant. A large bore mechanical thrombectomy significantly reduces the chances of RV dilatation after 48 hours, and major adverse effects events are comparable. There is no significant difference, and pulmonary artery pressure reduction and clinical improvement is significantly more in MDT, large bore mechanical thrombectomy devices, compared to anticoagulation alone. This is very significant finding. So these are their norms. Like the technical success is about 100% for their studies, and 25 minutes is the time that they took for average time for thrombectomy. 56 minutes median procedure time, and their pulmonary artery pressure reduction is about 10 millimeters of mercury pre and post procedure. So I would like to show 1 or 2 cases. This is about 39-year-old patient who presented breathlessness, shortness of breath, reduced SpO2, slowly declining with mild tachycardia, very less symptoms. But then if you see, the cardiac enzymes are all elevated, and also the ECG is showing changes. And the imaging finding, X-ray was normal, but then you can see that there is saddle thrombus, a large occlusive thrombus bilaterally, and also there is right heart stain. You see that. Yeah, and you can see the diameter of the right heart, which is more than the left heart here, and there is also some reflux into the hepatic veins. Right. We typically do this. We have a teams which has inputs from ICU, cardiology, cardiothoracic surgeons, and hematologists, and we discuss. And PESI score was calculated, and decision to make mechanical thrombectomy was done. We used Inari device. Bilaterally, you can see extensive clot burden being released. The presentation to needle time was about 45 minutes, and actual procedure time was about 45 minutes as well. There's another very young national service man. He had ankle thrombus, after which he had to immobilize his arms, and then he developed DVT, and then it became like an occlusive thrombus on one side. Still, the patient had right heart stain. You can see it's only on one side and right heart stain, and you can see we used Penumbra, and there was a lot of clot that came out. What we also did is, the Penumbra is easy to actually cross. It has a catheter that is direct, you can steer it, go to the other side. And we went into the clot on the popliteal side, and then we sucked out the clot from the popliteal vein. And also we put a IVC filter on the way back. So these things are possible with only one device. and the procedure time is increasingly decreasing. So these are some key takeaways from PLS. For intermediate high-risk patients, for selected catheter-based intervention, large bore mechanical thrombectomy device demonstrated superiority over catheter-directed thrombolysis, including ECOS and McNamara in a composite endpoint-driven as directed by reduced clinical deterioration rates, ICU admission, and faster symptom recovery with similar safety profiles. And also the STORM-PE, which compared between the large bore mechanical thrombectomy and the anticoagulation, showed the large bore mechanical thrombectomy, they call it computer assisted vacuum thrombectomy, CAVT. It's much superior to AC in terms of reducing the RV-LV ratio in 48 hours, which is a significant mortality indicator in terms of intermediate high risk pulmonary thromboembolism. So how is it going to shift our practice? This last slide of mine. This is the data from our hospital. You can see that the number of cases that we are doing is increasing. Not that the incidence is increasing, but the cases that we are getting because of the buy-in from various clinical departments like hematology, ICU, vascular medicine. These people are increasingly getting interested because we are able to do it, perform it with a very less safety issues and much faster with a very quick clinical relief. So this is something where the patient is expected to be released into general ward and maybe discharged in a day or two, which is a very good scenario that we are trying to paint here. So this is what is happening. So with all these studies, STORM-PE and PLS, what I am trying to see happening is that even the intermediate low risk patients, which are now being regularly anticoagulated, there is more chance for us to consider large bore mechanical thrombectomy compared to anticoagulation. This is my end slide. Thank you for your patient listening. This is my hospital. Thanks.
No doubt that mechanical thrombectomy is the key and is a paradigm shift from the catheter-directed thrombolysis to large bore mechanical thrombectomy. But in our part of the world, in government setup, cost effectiveness is the issue. So you see, you himself showed the dollars, $10,000 for the Inari flow retriever, and it's very difficult for in our part of the world to get this type of stuff. But yes, this is the way to go. This is the need of the hour right now, and yes, this is good.
Yeah. So.
The CDTs we do catheter thrombolysis. Yes. And if the McNamara is also an issue for a patient to buy, we can do that pigtail. We can do multiple holes if the patient is so poor. But still, if we want to restore the antegrade flow, so we do multiple holes in the pigtail, and we can take it there, and then we'll put the RTPF and then.
So in these kind of patients, is there any age of the clot that comes into play?
So when we get these patients, we make sure that these patients are acute PE, significantly acute clot load.
So
because
less than 14 days, you would put it as acute or?
No, the patient present, we are talking in terms of hours, not days.
Hours, okay.
Yeah. So it's important that it is hours of presentation, ideally within an hour or two, and then the patient gets a CTPA done immediately, right? Heart strain is demonstrated. PESI score is done based on the clinical criteria as well as the cardiac markers, and then we combine every data available with everybody, including ICU, cardiologists and stuff. So that's how it goes.
Even sir, most of the these are industry-driven products. And the acute is, I think, no doubt about that. Acute is the best for mechanical thrombectomy because it is just jelly-like. The thrombus is just jelly-like. We can take it out. But for subacute and chronic, when the clot is recalcitrant, thrombosed, it is fibrosed, and we cannot take it out. That even there is a challenge for these devices also. For subacute also there is a challenge.
One way to look at the cost is that when you compare the patient's long hospitalization and stuff, when you use this, it's a one-time payment, but then the patients chances of living is higher, and also as we increasingly use it, we also get the quickness and stuff. So in a way, it is cost effective when you compare the overall hospital stay, ICU stay, and other stuff. We are actually clearing everything. The patient is also very happy that the next day he's getting discharged.
So, Vimal sir, actually what we are doing is, like as he said, CDT is okay. We do it with every case, like being arterial, venous. But we also take like a neuro large bore guiding catheter, like 7 French. And we have a Vaclox syringe, 50 ml cc. So that, I mean, you have to take out most of the chunks so that the thrombus load is decreased, and eventually that catheter CDT becomes more effective. And sir, I want to know what you are doing in your setup, like in Mumbai.
So, I'll tell you what, when we are using the 7 and 8 French guide catheters or neuro catheters, Neuron Max or whatever you get in, the amount of material that comes out is not good. Finally, is this large bore is what makes the difference, is what it
We
is.
are
Yes,
talking
it is
like
expensive.
a 24-16
Yeah.
French.
So these, obviously they are expensive, we know that, but they have definitely role to clear it up much faster. But yes, if the patient cannot afford, yes, we are going with thrombolytic and managing it with those patients, yeah. Okay.
Hi, Doctor. Doctor, thank you for that presentation. I have a small technical question.
Thank you.
I'm also a part of a PERT team. So when we use the Penumbra system, the thing is that Penumbra doesn't provide the sheet. So which sheet do you use? So you use the Gore dry seal in your practice?
They give a sheet to us. Generally, it comes. They give a cook sheet which is compatible.
Okay.
Yeah.
And for the 20 French above, how do you close it? You just
Penumbra
manually
is only
compress?
16 French.
No, for the Inari.
Inari, they give their own
Closure
own
device.
Yeah, it comes like a package for Inari.
Okay.
Everything that you use for the patient, as much as it's only one case they consider. Yeah.
Okay.
So you can use as many instruments in Inari.
Okay. I think next, thank you, that was really nice and good presentation. And
Thank you very much, sir. Next, we have presentation on nightmare IVC filter retrieval from Professor John Yu.
Okay, thank you. Thank you for kind introduction. And I'm Dr. Zhe from South Asian University Hospital, and it's my great honor to be here in this wonderful meeting. And today's my talk is about nightmare IVC filter retrieval. Well, there are so many different types of IVC filters on the market, and IVC filter is used to prevent pulmonary embolism in patients with venous thromboembolism when anticoagulation is contraindicated or ineffective. Then why do some IVC filters become a nightmare? The use of IVC filters has increased worldwide. FDA issued a safety communication recommending prompt removal once P risk resolves. But in reality, the retrieval rate is very low, around 20 to 30%. So many filters have been left in place for months and years. So this long dwell time is related with more complication and increased retrieval difficulty. So this is standard snare and sheath retrieval technique. So we usually use a large diameter snare, and we align it with the filter apex like this, and then we capture the apex and begin retraction with the control tension, and then we advance the sheath until the filter is collapsed and fully enclosed. Then we remove the filter with inner sheath together. This standard technique works in most straightforward cases. However, several factors can complicate removal, and then it requires advanced techniques. Well, why filter removal becomes complicated? The first one is filter tilt. When the apex contact the cable wall, it's somewhat difficult to capture the hook. Also, the second thing is embedded hook and apex, and it is caused by endocellularization and fibrosis, which makes snaring difficult or sometimes impossible. Also, filter perforation can happen, but it's very common, and just simple filter strap perforation is not a contraindication for retrieval. Also, filter fracture happens, and most concerning is when fragment migrate to the heart. Also, sometimes we can see filter-related iliocable thrombosis. Well, let me show you several advanced techniques for challenging filter removals. Well, this is the alignment technique. So we can use curved catheter to redirect the snare toward the filter apex. So just like this, with this curved catheter, we can redirect the snare toward the cable wall. Also, we can use sling technique. So we are using reverse curved catheter, and our guide wire is advanced, and the tip is captured from jugular access with the snare. Then now we can make a small loop snare like this, and then we can remove the hook. Also, this is tilted filter, and we are using Simmons catheter, and we are advancing guide wire, and the tip was captured from jugular access. Now we are making a loop, and then we can remove this filter successfully. Here, filter hook is about in cable wall with the fibrin cap formation, so it's sometimes very difficult. But here in this space, we advanced guide wire, and the tip was captured from jugular access. Now we have a large loop, retracting the wire, and then we are making a small loop. Then we could remove this filter like this. Well, also with loop snare technique, we can disrupt the fibrin cap. So we can do this procedure several times, and finally we can get the hook, and we can remove the filter. This steep wire displacement technique. So here we can advance a steep wire between the filter apex and the cable wall, and the wire pushes the apex away from the wall, straightening the filter and allowing snare capture like this. Also, we can position a balloon between cable wall and IBIS filter, and we can inflate the balloon to separate the filter away from the wall like this. Also, we can use dual access technique. One wire is going down from the jugular access, the tip is captured from femoral access, and then simultaneous cranial and caudal traction helps free the embedded apex like this. Well, here we have tilted filter, but snaring was failed, and we made the first loop snare like this, but it was not enough to capture this hook. So we made the second loop snare, but two snare was not enough too. And then we advanced third loop from femoral access, and we could disrupt a fibrin cap with third loop snare. And then finally, we could capture the hook from jugular access. We could remove this IBIS filter successfully. When wires or snare-based technique fails, we can use endobronchial or alligator forceps like this. We can disrupt the fibrin sheath, and then finally, we can get the hook. But the major risk of this technique is IBC wall injury, so we should be very careful about that. Here we have embedded hook. We are using loop snare technique. We made the loop, but it was not enough to retrieve this filter. So with this hook, we are centering the filter in the lumen, and then we advanced alligator forceps to capture the hook. And then finally, we could remove the filter, and no contrast leakage. But sometimes when we use this kind of hook system, this kind of alligator forceps, there might be some rupture or injury. So then the first line that we can use is semi-compressed balloon, just like CODA or lead balloon. So we can inflate for 5 minutes or 10 minutes at injury site, and then deflate and check the angiography. If bleeding occurs again, then we can apply a balloon one more time. But the definitive treatment for extravasation is stent graft. But if you don't have stent graft, you may use bare metal stent for just a focal intimal injury or limited dissection. But anyway, the definite treatment is stent graft whenever possible. Also, we can use laser sheath. It can deliver photothermal energy to ablate fiber tissue around the filter, lowering the risk of cable injury. This is IBIS filter inserted 6 months ago, but here we can see eccentric low attenuation inside the filter, which means intimal hyperplasia here. So we are using standard techniques, standard sheath, but the filter could not be advanced into the sheath due to bulky tissue ingrowth. So we changed the size of the sheath, upsize to 8 French sheaths. So then it allowed successful capture and collapse of the filter like this. This is the final case, left hemiparesis patient, IBS filter inserted 4 years ago, but non-healing chronic ulcer occurred at left shin. So we wanted to treat this patient, but CT shows IBS filter with distal IBS occlusion like this. We performed the venography. It shows occlusion of the infrarenal IBC with collateral vein formation like this. We could take the hook, but the IBS filter retrieval was not successful. Because of this severe tissue adhesion, it prevented the filter collapse, resulting in failure of retrieval. So our next plan was the canalization of occluded IBC with the stenting across an indwelling filter. So after crossing the lesion with bilateral wire, then we performed balloon angioplasty, but result is not good. And then we are deploying kissing stent. We use 2 90 stent with high radial force. And then we performed the kissing balloon like this. So this is before standing, this is after standing, and the pressure gradient was 8 mmHg across the lesion, but we could reduce it to 1 or 2 mmHg. And this is Cone-beam CT acquired immediately after stenting. It shows luminal gain of iliocaval stent. You can see the luminal gain here. And the IBS filter, the occluded filter, is placed anteriorly like this. And the stent has its luminal gain like this. And 5 follow-up ultrasound shows patent stent. This is meta-analysis about the success rate. Standard technique showed about 76% of success rate, but advanced technique showed 90% success rate and 4% of major adverse events. So it's within the acceptable range. So in conclusion, prolonged dwell time to tilt and embedded hooks increases retrieval risk, but we can use advanced retrieval technique with acceptable complication rates, and filter removal decisions to be individualized, balancing patient-specific risk and benefits. Thank you. Thank you for your attention.
Sir, any question?
Yeah, I mean, for me, the standard procedure was that same hook technique is a standard technique that I've been using. Obviously, we are not using any of these double filter kind of thing, you know, the Cordis filter, or even there is a LifeTech. We're not using those. We are either using Denali or we are using the Cook filter in our patients. So we felt that as and when we got stuck, just use the hook technique, and we have been successful. The only plus point is all our patients we retrieve within 3 months.
Yes.
There is a very tight, strong follow-up on those patients.
So how will you make sure that they will come back in exactly right time?
No, they may come 10, 15 days plus minus, but we take the telephone number, we actually document in our paper, in the discharge summary, that you have to come and tell the patient and the family before they are discharged that if this is not removed, you'll have more problems. So we have more than 95% patients come back in 3 months' time. We see to it that it is done, otherwise all these problems, you don't want to face them.
And
Yeah.
same question to you as well. So in your part of the world, how will you make sure that the patient will come exactly the same time when the indication is over?
Actually, he pointed the most important thing. Actually, we are keeping our own tracking system of IBS filter patients. So we have our own registry of IBS filters. So we check the list and we recommend them to remove the filter within 3 months. So that is the most important thing. But we are working in the tertiary hospital. So outpatient with long dwell time actually come to hospital. So my case is those patients.
Actually, most of the patients when they will came at 2 years, 3 years, 4 years, 8 years, 9 years. So at that particular time, it has got embedded in the wall. So it is very difficult to get the filter out. So it's very difficult. So that is the key. If the indication is over, get the patient. You have to track the patient. That's it. That is the main key. Sir. Thank you. Thank you.
Thank you, sir. And Next talk will be on PTS recanalization with IVUS guided stenting from Dr. Santosh.
Morning, all. So we'll see the recanalization process that we do for post-thrombotic syndrome with IVUS guidance. It's not a very common disease, but 50% of the patients who have DVT of the iliofemoral segment are having this problem. The sufferers experience chronic issues like limb edema, the skin changes, venous claudication, and above all venous ulcers which may not heal. And stenting often relieves these symptoms at the right time if you are doing it, improves quality of life and also enhances ulcer healing. The main problem here is patient selection. We do not actually select all the patients who have PTS for this procedure. We have to be careful because we are going to put permanent metallic implants for a long segment, maybe crossing the joints, and also they are prone for reocclusion. So we need to select these patients carefully and counsel them extensively, saying that this procedure will benefit you only if you have a very severe symptomatology in the form of at least a significant venous claudication to start with. So we start selecting patients C3 or above, and mostly these patients have C6 where they have non-healing ulcers most often. And we have to definitely weigh the benefits versus the risks we pose the patient to. The classification of the venous occlusion is very important here because we all are bothered about the inflow when we are dealing with venous stents. Unlike arterial stents where we are bothered about the outflow, the inflow is necessary to actually keep the stent patent for a long time. So the types of venous occlusion has been classified by Hermann July from Germany, and he has made a classification of NIVL as type 1, an iliac, common iliac and proximal external iliac occlusion as type 2, and an occlusion extending to common femoral vein as type 3. And these are the type 2 and 3 are the types which are best suited for venous stenting because they have a very good inflow from the femoral, superficial femoral and profunda. Whereas the type 4 and 5, which have involvement of the inflow veins as well, the type 5 particularly where both the veins are involved are poor candidates for venous stenting. Whereas type 4A and 4B, where the superficial femoral vein or the profunda vein, either one of them are involved and there is no adequate inflow, and there is only one of these veins which is providing inflow. These are patients who are touch and go because we have to make sure that we have a good inflow from at least one of the veins before we proceed. So I had the opportunity to interact with Dr. July in a couple of months back, and we had a very good interaction, getting some good insights about venous stenting. One important aspect of choosing these patients apart from the clinical scenario is the pre-procedural assessment of the venous system. So we do always an MR venogram. CT venogram is not satisfactory because of the inadequate contrast opacification and decreased spatial resolution. So we always prefer a non-contrast MR venogram in the form of TOF or TRUFI, and we assess the extent of occlusion as well as the inflow veins. Although Doppler ultrasound is done initially to map the system, we always go with a cross-sectional assessment to have an overall idea of how the venous system looks like. A short note on the procedure. So we start with an axis which is very important, and most of these patients you should access the mid-superficial femoral vein. So that is a vein which is in direct continuity with the iliofemoral venous system and also provides a very good site for venous compression after the procedure. After the vascular access, you perform the venogram, map the collaterals and obstruction, give the anticoagulation 50 units per kg. And an important aspect of venous, the crossing of the lesion, if particularly the in type 4A or 4B, is actually to go along the side of the profunda. So when profunda is involved and the superficial femoral vein is involved, this is a type 4A, which is the most common type among the type 4 and 5. This is the one which causes a problem because inflow veins are inadequate. So we have to save the profunda inflow. So we need to have pointed angulated catheters which point towards the profunda, and we make sure that the wire enters the profunda and then take along the lateral wall of the common femoral vein. So that is the idea of tracking, because there are various septations here, and if you by chance take the wire along the medial wall, what happens is the flap along the lateral wall may close the profunda inflow, which may be the only inflow to the stent. So this was one of the technical points I learned there. And once you have this crossing process, you take a straight wire, thermo hydrophilic wire along with an angle catheter like a multipurpose or a Bernstein, and then along with this you generally have a very maneuvered crossing. You torque the wire, keep torquing the wire, and make sure you follow the wire along the expected course of the deep veins, because there are various collaterals here. It is very easy to enter the collaterals and end up going into the spinal canal. So that is very common here. You should not misjudge the path of the vein and end up doing a disastrous complication. So once you finish the crossing, you have to predilate the system. Predilatation is usually done with optimal sized balloons according to the size of the veins. We'll come to what size veins we have, what are the sizes of veins we commonly face in the iliac and femoral system. And then we proceed with the stenting. Precise placement of the self-expanding stents is very important, both cranially and caudally. We'll see how to do that with the help of IVUS. And we need to post-dilate these stents most often, because these stents are constrained by the various synechia in the deep venous system in chronic occlusion. And then finally we have to confirm with the venogram about how good the inflow and the outflow are, and also with the IVUS to make sure that the stents are widely patent. Coming to intravascular ultrasound is one of the key players which has actually transformed the procedure of venous stenting, because it gives us various vital information which are not provided by a 2D venography investigation. So first and foremost, we identify the sites of the vascular compression in case of May-Turner syndrome, exact site, because otherwise we may overdo or underdo the stenting at the proximal compression site and may end up either crossing and caging the opposite vein or undercutting the May-Turner site. The next thing is to assess the length of the venous involvement, right, starting from the proximal to the distal. Even though the venography may not show the synechia, the IVUS will clearly show, because it's an endoluminal imaging, and we have to assess the ostium of the profunda as well when we are dealing with type 4 lesions. Stent sizing is also an important thing, that because of the cross-sectional diameter that we get along with an IVUS. And once we finish the stenting, we have to assess whether the stent has opened uniformly at all segments. That's the help of IVUS. It reduces the radiation. Also, it assesses the flaps across inflow vessels. So here you can see that the IVUS probe is in the vein in the IVC, and then this is the aorta, and this is the bifurcation of the aorta. And as the common iliac artery crosses the right common iliac artery crosses the left common iliac vein, you see the compression here, and this is the May-Turner site. So this is how we assess, and also we do the fluoroscopy at the same time. So choosing the ideal stent is important here. Precision is very important at the proximal landing zone, because that is the May-Turner site. We don't want to underdo or overdo it, avoid caging. And then we should have a very good radial force at the site of the compression. We should have a very flexible stent in the depths of the pelvis, because it is kind of an undulating course. And also we should have good crush resistance across the joint, across the inguinal ligament, because stent fracture is a common problem with the older generation stents. So with the advent of the latest venous stents, they have various properties which have all these desirable properties, and most of the current stents that are available with us are the Abre from Medtronic, Veenova from Bard, and Sinus Obliquus, which has an oblique kind of design at the proximal end to prevent caging. So it depends on the operator preference. So again, defining proximal and distal landing zones are quite important. Sizing of these stents, what we do is commonly we size 14 to 16 mm in the common iliac vein, 12 to 14 mm in the external iliac and femoral veins, and around 20 to 24 in the inferior vena cava if we need to stent to the IVC. So if you're dealing with a confluence involvement in case of a bilateral DVT, bilateral chronic venous occlusions, then there are various techniques to actually reconstruct, and the most common technique is a double barrel technique, where you extend the stents into the IVC from both iliac veins. You can also do a skip stent, where a single stent in the IVC is placed, that there is a skip segment, short skip segment, and both iliac veins are reconstructed with respective stents. You can also extend one of the stents into the other stent, telescoping it in case if you have jailed it and later the patient develops a DPT on the opposite side. And then there are other techniques as well. The potential risks of stenting here are stent fracture when the stent crosses the joint and you are having an excessive bending force there. The older generation stents used to fracture that. If you are undersizing the stent or if you are putting a short stent, generally we have the common iliac stent at least 10 to 12 centimeter long. Otherwise, they are prone to migration because there is no fixation. And if you are caging the opposite side, then it may cause a contralateral DVT and then you have to deal with it. So better not to cage it fully. Of course, you can go 2 to 3 millimeters into the confluence. And back pain is a very common problem. After the stenting, because of the expansion of the vein and compression of the adjacent neural structures, sometimes it may be a problem, but where the patient has a very resistant pain, you have to manage these patients very well. So post-procedure care, within 2 weeks we should do the first follow-up ultrasound, because that is a time when the stents are very prone to occlusion, and then if you detect it, you have to deal with it accordingly. So the next follow-up is at 1, 3 and 6 months, and then 1 year and yearly. Lifelong anticoagulation has to be given for these patients, as they are very prone to stent occlusion, and you manage the wound as required. If you detect the stent occlusion early, you have to lyse and you have to treat the problem, underlying issue, the inflow or the outflow. And if it is chronic, if it is asymptomatic, you have to leave them alone. If it is symptomatic, severe C3 and above, then you can recanalize by ballooning the stent. If it is a fractured stent, again you treat based on the symptoms. Asymptomatic, you don't treat them. If there are symptoms, then you may do balloon remodeling and put a stent to reinforce. So I think time is up. So thank you. Okay.
Sir, any question?
So I think I absolutely agree that these are one of the most challenging ones. We get patients who come after maybe 6, 8, are the longest that I've seen a patient was 18 years with large ulcers and all. But the stent diameters also, I would agree, put the largest possible that you can get, and IVUS does play a good role in these patients, and take long stents.
Yes, sir.
To prevent migration and things like that. So that would be a definite thing. Today I have kind of resorted only to 2 stents. Either I'm using a Venovo or an Abrase stent here. They have played much better, and they've done well in these patients. So 2 things: anticoagulation, how long? And number 2, do you give compressions?
So anticoagulation, we keep them lifelong in all these chronic patients at least, because we find that the inflow is often compromised, and if the patient ends up with a stent occlusion, it's much more problematic for them. Yes. So we keep them on lifelong anticoagulation, particularly the chronic ones. The acute ones, we don't keep them lifelong. We keep them for 6 months to 1 year and then switch over to aspirin. So, but for chronic ones, we definitely, because of the long stenting, you often need to come across the inguinal ligament into the common femoral vein. And they say we have to just place the stent at the inferior point of the common femoral vein, not into the either superficial femoral or profunda, because even though the synechia are there, there will be some inflow from one of the veins. So we should land it just at the origin of the, just above the origin of the profunda. That's where we have to land it.
Apart from May Thurner, in rest of the patients, you always put stent, Venovo or BART, or you just first do thrombolysis and then if there is any, you do ballooning and then you put stent in all the patients, or just May Thurner patients?
No. Any chronic occlusion has to be stented.
Every patient. You put all in all patients.
Yes.
Pressure gradient measurement?
Not really.
Not
we don't do pressure gradients.
So one last question. So in real world scenario, like in most of my cases, either it's type 4 and type 3, the whole femoral popliteal is also gone. So in those cases, like how do you take the popliteal access, because there's a chronic thrombus in the popliteal vein, and the flow from the vena comitatus is not good. In many cases, I burned my hands that the flow is not good. You have opened up the femoral vein, you have put stent in the iliac vein, and the next day it is thrombosed again. So,
This is for
like in many cases.
acute DVT
No,
patients.
chronic DVT. No, I'm not talking about
In
acute.
chronic, we just take the mid superficial femoral vein, sir. We don't go usually to the popliteal. We have the, in the frog-like position, we take the mid femoral vein. Usually we have some recanalization in the mid femoral vein. It will not be totally occluded. So we just puncture the recanalized channel and then take the device.
So probably acting the worst of the patients, because popliteal veins are in many cases it's blocked. Like you don't get the site to you know.
If the femoral vein is inadequate, it is very difficult to do the procedure, sir. Because we can't do the procedure from the profunda vein, it's very difficult. Only the
patient is very symptomatic. I mean, the surgeon has like given up and nobody is helping
These are
him.
probably type 5 lesions.
What he's saying is right.
So,
doesn't have inflow.
so
That
what?
There is one actually thing they are saying. The surgeons, basically the vascular surgeons say that in such cases, type 5 lesions where the femoral vein is extensively thrombosed, so they do an endophlebectomy. So they open the vein, they remove all the synechia, and then they do the recanalization so that the inflow is augmented. But nowadays they say it is not much of help because long-term outcome of such patients are not good. So better not to touch these patients who have a type 5 morphology. You have to have at least one good inflow vein. That is the difference.
And do you take tibial venous access also for any of your
No,
case? Like
not for chronic venous occlusions.
not for.
Yes. We need inflow, otherwise it's not.
Thank you very much.
Does only angioplasty help?
That is where we.
But
end up in
if
the-
he has a non-healing venous ulcer, at least to help him to heal the ulcer.
That is where we end up in the next topic, to stent or not stent in non-thrombotic iliac vein lesions or May-Turner syndrome, from Dr. Krishna. Please, sir.
Hi, good morning. My name is Dr. Krishna. I'm a senior consultant in Singapore. So today, I would be speaking on NIVL, May-Turner, to stent or not to stent. So what is NIVL? The term NIVL includes intrinsic lesions and lesions that are related to vascular or osseous compression syndromes. So these include webs or spurs and anatomical compression related changes that cause venous narrowing. So, but this does not include lesions with associated compressive mass lesions. Most of the NIVL lesions are often found incidentally, and we can see in 60% of the normal patients. And these are only clinically relevant when these are associated with symptoms. So coming to May-Turner syndrome, it's also known as iliac vein compression or Cockett syndrome. It's a clinically significant form of NIVL, wherein the left common iliac vein is compressed between right common iliac artery and vertebral body. May-Turner syndrome is reserved for symptomatic empty anatomy. Usually asymptomatic anatomy is seen in most of the patients in a normal population, and more than 60%. So that means anatomy is not equivalent to the disease, and we see in women more than the men. So coming to pathophysiogenesis, whenever there is a chronic compression on the vein, there is irritation and proliferation of the endothelium, leading to elastin and collagen deposition in the veins, leading to intimal fibrosis, and later leading to development of spurs and webs. So Gion et al. Came up with a morphological categorization into 3 forms. In the type 1, there is just a focal compression on the vein. In type 2, it's like a band-like narrowing of the vein, common iliac vein, and in the type 3, it's like a cord-like narrowing of the vein. So coming to the clinical presentation, so most of these patients present with chronic venous insufficiency with symptoms such as heaviness and swelling of left lower limb, venous claudication, varicose veins, leg pigmentation and venous ulcers, and sometimes they present with the DVT with painful left lower limb. So some women may present with a chronic pelvic pain. So the severity of the symptoms can be scored using the revised venous clinical severity score, that is RVCSS, which can be supplemented by CAP classification. So diagnosis, so I don't go much deeper into it. Duplex ultrasound is a preferred imaging modality. We can do MDCT venography, MRI venography, which have 95% sensitivity and specificity. we can do DSA catheter venography plus pressure gradient measurement, which is a gold standard. But recently, IVUS has got greater sensitivity for iliac vein compression, and it can characterize iliac vein lesions such as fibrosis, stenosis, and thrombus. So IVUS also helps us with incising and positioning of the stent, and as well as in assessing post-stent. So recently, there is a video trial which showed that IVUS identified 30% more stenotic lesions of 50% severity are greater compared to venography alone. So coming to management, so we have to know that anatomic compression alone does not equal to disease. So we only treat the symptoms. Symptoms not alone should guide us the intervention. So conservative management is the first line of the treatment and should be pursued first, including the regular use of compression stockings. In MTS with acute DVT, we should start first with anticoagulation. Prophylactic IVC filter is not recommended, but we can put in for a larger clot burden. The incidence of pulmonary embolism is very low in MTS due to the protective effect of the venous stenosis. So endovascular management is reserved for patients with CAP 3 to 6, as Dr. Santosh has told, and for those who are refractory to conservative management. So in women with NIVL and coexistent ovarian vein reflux, we may have to add ovarian vein embolization in addition to the stenting. So this is my first case. This is a 69-year-old male who presented with left lower limb swelling since 2 days. We can see in CT there is a May-Turner lesion, and patient presented with extensive iliofemoral DVT. So this is a venogram showing the iliac vein clot burden. We had to balloon it to advance our device. We used Inari Clot River. So with Inari Clot River, we fished away all the clots. So we balloon and we put in a sinus obliquus 16 mm stent. So this is a pre-IVUS image. We can see the May-Turner lesion, and the post-IVUS image where we can see the significant luminal improvement. So this is a patient 1 week later, he came to the clinic, he came with running shoes. So within 1 week, he was very good. So this is a case 2, 70-year-old female, we presented with left lower limb swelling and tightness since 1 day. CT, again, we can see the left iliac vein compressed between right common iliac artery and osteophyte, and patient had extensive iliofemoral DVT. So for this patient also, we did mechanical thrombectomy. We used Inari Clot River, took out all the clots, and we put in a Venovo 14 mm stent. The pre-IVUS image, we can see there is no lumen, and post-stent, we can see significant luminal improvement. So this is a patient before procedure, pre-intervention. We can see the swelling. This 1 day post-intervention, the swelling is gone. So this is a third patient, 43-year-old female with acute right lower limb pain and swelling for 1 day. So we see this NIVL lesion on the right side. So right CIV is compressed between right CIA and the vertebra. Angiogram showing the NIVL lesion and thrombus. We used a pulse plate angiojet thrombectomy for this patient, and we used a 14 mm balloon. We didn't stent the patient because patient didn't consent for the stenting. So we see the residual luminal narrowing still present there. So this is a fourth patient. This is a 58-year-old female, left lower limb swelling since 2 days. Again, left CIV is compressed by the right CIA. So we used a pulse plate angiojet thrombectomy and put in a Zilver stent, 16 mm, and post-dilated with 16 mm balloon, we can see significant luminal improvement. So coming, which patients to stent and which not to stent, when to stent and when not to stent. So we stent whenever there is symptomatic compression, IVUS stenosis more than 50 to 60%, and whenever there is a failed conservative therapy, and with women with the quality of life impacting chronic pelvic pain of venous origin. And we do not stent patients when there is asymptomatic compression and there is alternate cause of symptoms, and there is only minimal quality of life impact with stenting. So goal is to treat patients, not images. And where is the evidence? There are a lot of studies done recently on NIVL and May-Turner studies. So we have studies from 2007. We can see in Neckline 2007, turn to 9. So we can see most of them did on PTS and as well NIVLs. There is symptomatic relief in patients from 62% to more than 90%, and ulcer healing is seen from 58% to 100% in all these patients. So there is one study from Singapore where is a multi-center trial, 87 patients and 115 limbs analyzed. There is significant clinical improvement. Mean RVCSS and VAS improved from 11.5 to 5.7 and 6.6 to 2.9. So there is 95.3% venous ulcers healed over a median time of 169 days. And there is a large meta-analysis study done by the RAN Center of Venous and Lymphatic Disease, USA. This is a narrative review of meta-analysis of large sample studies of more than 100 limbs. So 6 studies were reviewed, total 1404 limbs that underwent stenting for NIVL. Quality of life was significantly improved and improved VCSS and functional status. So venous ulcer healing achieved in more than 63 to 82% of patients. So there are also stent-specific industry lead trials such as Vertus study, Vinova study, that is a vernacular study, and Vivo study. So all these studies showed increased quality of life as well as low device related failure. So there is a study which is done with all comparison between all stents and found out there is no difference between any stent. So these are some of the other available studies in literature which showed efficacy of stenting compared to medical treatment alone. So there is a consensus statement from Viva Foundation which says stenting is indicated for symptomatic patients with appropriate imaging confirmation and generally not for asymptomatic compression. There's a position statement from SIR which summarizes the available data for iliac vein stent placement in chronic iliofemoral obstruction, provides practice considerations. So summary, percutaneous stent placement is safe and effective treatment option for symptomatic NIVL and MTS compared to medical imaging alone. Thank you.
I think the stent definitely plays a role.
Yes.
Important is long term.
Yeah.
You know, we tend to lose the stent
Yeah.
occluded, and that's where the challenge comes in. And once it gets occluded, there is recurrence of symptoms. First time when you put a stent, obviously the ulcer heals, but after 3 or 4 years, when the stent is occluded, it comes back.
So yeah, there are these studies done by 3 to 5 year studies from industry trials like vernacular and all. So they showed like more than 90% patency. So
yes. Yeah. So yeah, some of these stents have done very well now. The specialized venous stents that have come in, which are adequate radial force.
Yeah.
At the same time, they have the configuration where they actually go. They have a spiral connections
flexibility
between the struts, and that helps the mobility of the
right.
because we know the vein goes from anterior to posterior to
medial to lateral.
And those curves have to be well maintained. So I think that becomes very important. The length of the stent, are you really look at it double?
Yeah, ideally at least more than 8 centimeter. So 6 centimeter will be small, and studies have shown that less than 6 centimeter they migrated. So ideally more than 8 centimeter, largest possible stents. Yes. We usually tend to put IVC filters, but many authors they don't recommend. But we put in IVC filters when there is a large clot burden, just to be on safer side. Yeah. It's controversial, but we still put in just to be on safer side. Yeah. Yeah. But we put in after doing a thrombectomy.
So Vimal, sir, have you got the opportunity to use that marine stent that Merrill has launched?
No, I have not yet used it. I would like to definitely.
Boss, Santosh Boss? No. Okay. So I've used in 2 cases. So let's see. I mean, the patients are in follow-up. It deploys beautifully, just like Covera. So let's see. Like it can be one of the cheaper available options if it performs well. I got it in a sample kind of thing. So let's see if you know.
Both these sorry.
You know what you were saying about the stent vacancy. We are finding the same, but we are finding that we have to surveil them, so we bring them back yearly for ultrasounds, and if we find the stenosis, even if they are not symptomatic, we balloon it. But
So do you put an anticoagulation?
So these specialized venous stents have definitely made a difference. The wall stent that we started off originally, Raju's presentation. Sorry?
Even with the new stents, I think.
Yeah, no.
Better with the radial force.
Yes.
I think the stent thrombosis will still occur.
Yes. So, and I was talking to these guys about, use of drug-coated balloons in venous. It's being probably discussed. I mean, in-stent occlusions, whether there is any role or something, or any of these atherectomy devices in future. But again, these are very small. The venous diameters are very big, so obviously all that will be a challenge in future. So veins are, I always tell my patient, once a venous problem, always a venous problem. You just can't just escape that. Great, very nice. Absolutely appreciate it.
Thank you all. We'll be moving ahead with the next subtopic, focusing on the upper chest and upper limbs. Thank you all the chairpersons for the previous session. I would like to invite the chairperson for the next session, Dr. Balaji Patel, Dr. CPS Chauhan, Dr. Vishal, Dr. Ganesh, Dr. Sikandar, and Dr. Kirati. Please take your seats. First talk on this session will be on the management of SVC syndrome by Dr. Damandeep Singh. It's over to you, sir.
Very good morning, respected seniors and my colleagues. I am Dr. Damandeep Singh. I will be speaking about the management of SVC syndrome. So to begin with, briefly I will be covering my slides in this following subheadings. First, we'll understand the pathophysiology and the etiologies. We'll understand about the risk stratification. Oh, sorry. Sorry about the glitch. So, good morning again. So, I am Dr. Damandeep Singh. I'll be speaking about the management of SVC syndrome. My slide will be discussed under the following subheadings. First, we'll understand the pathophysiology and briefly touch on the etiologies. We'll understand the risk stratification and the severity grading. We'll see briefly about the optimal imaging strategy, the management techniques and the literature review, and last but not the least, the role of intervention radiologists in managing SVC syndrome. So quickly touch upon what is the SVC syndrome. It is a constellation of clinical signs and symptoms which is caused by either SVC stenosis, obstruction or occlusion. Patients will present with facial puffiness, redness, swelling, and it can be both benign as well as malignant in etiology. And in more than 3/4 of patients, it is malignant. The anatomy, it is the primarily draining vein which drains the both upper limbs and head and neck, and it is formed by the confluence of right as well as left brachiocephalic vein. It is a cylindrical vein which courses in the mediastinum and drains into the right atrium. There are few anatomical variations. We can have bilateral SVC and we can have a isolated left-sided SVC. So it is also important to understand the variations. The variations are quite common. So I've already discussed that it can be malignant as well as benign. So these are the common listed causes. Among the malignant, the non-small cell cancer being most common. Due to the ongoing use of central venous catheters, the pacemakers, defibrillators, there is increasing incidence of benign causes of SVC syndrome. I will be showing certain cases also. And classically, traditionally, infections, namely syphilis and TB, were the most common causes long time back. But now the malignant causes are more. And some rare causes can be mediastinal fibrosis, aortic aneurysm, mediastinal hematoma, sarcoidosis. So this is a case which I'd like to show. A patient was operated for a cardiac issue, for a valve replacement, and there was an indwelling catheter in place, and the patient presented with facial puffiness, and we can see there is a thrombus at the SVC-RA junction, and this we can see the extent of thrombus. This is just to highlight the benign cause of SVC syndrome, and in this image I'd like to show a child who had a large mediastinal mass, and this is how it can affect the SVC. We can see the chinked SVC, extrinsic compression, severe stenosis, and the patient again presented with the upper limb symptoms. Now it is also important to understand whether it is an acute or a chronic presentation. acute, patients can present with a life-threatening cerebral, laryngeal, or pharyngeal edema. However, the mortality is uncommon, but median life expectancy is approximately 6 months owing to the underlying malignancy. Whereas chronic cases, the patients have progressive luminal compromise, but they also have lot amount of collateral pathways. We have already discussed about the clinical presentation. This is just to show the stats. Now, there are certain grading systems which are used. So this is one of the system which grades into 0 to 5, starting from the asymptomatic patients, mild, moderate, and severe. And there are grade 4 and 5 where the patients present with life-threatening obstruction, manifesting as cerebral edema, laryngeal edema, and hemodynamic compromise. There is a scoring system which is more comprehensive called as Kishi score, which encompasses 4 main categories: the neurological signs, thoracic or laryngeal signs, facial signs, and vessel dilatation. So generally a score of 4 is considered as a threshold to perform any intervention. And this is the most helpful system which should be used. This divides the obstruction on the basis of the anatomy of the SVC, the brachiocephalic veins, and the azygous veins. So the obstruction can be either infraazygous or at the level of azygous, or it can be supraazygous, may or may not involve the brachiocephalic veins. And then it is also divided into A, B, and C. So this is just a proposed classification system. Imaging strategies I will not discuss in detail. It has already been covered by my colleagues. So CT venography is generally helpful to also do the sizes, and the excess vessels can be seen by Doppler. DS, digital subtraction venography, actually tells us about the length of lesion, the stenosis, and IVUS is not very commonly used, but it is just to cover, I have mentioned it. So when we have a patient, the initial role is to manage the edema. So a reverse standard limbic position reduces hydrostatic pressure and edema, and these patients can have, as I said, airway compromise. So initial is to airway breathing and circulation. The role of steroids and diuretics are discretionary. The radiation therapy was the traditional treatment strategy, but it is now coming down because after the radiation therapy, histological diagnosis is impossible in around half cases, and it provides relief only in around 80% patients, and 20% patients still remain refractory and high recurrence rates. So that comes to endovascular treatment and where we stand currently. So endovascular treatment is a minimal invasive technique, often using single or dual approach. We can perform diagnostic angiograms to demonstrate stenosis, occlusion length, flow direction, thrombus, and collaterals. Briefly touching about the hardwares, we can cross the lesion with the guide wires or CTO wires, and there are some less preferred techniques such as sharp recanalization, which are not routinely used as they carry high risk of tamponade. So we can use a stiff end of guide wire, Colapinto needle, or a Chiba needle. These are other hardwares. So for the balloons, we generally start with a small balloon and go up to 16 mm. We should not go more than 16, that it carries high risk of rupture. Stents, I will discuss more in detail, and these are some other hardwares which should be kept in handy when, depending on the etiology of syndrome, whether it is a thrombotic or a malignant cause. So IS strategy, POBA alone is generally not helpful because of significant recoil, early restenosis, and occlusion. Stent placement is required in majority of cases, and selection is tailored to the situation. The self-expansile stents, long lengths available, they conform better to the vessel wall and are resistant to 2-point compression. Whereas the balloon expanded stent, limited length is available, but they give a precise deployment, and there is low risk of migration. But the disadvantage is there is rigid and less flexible. The covered stents give a better 12-month patency and generally used as a bailout in SVC rupture, but they knock out the collaterals. So briefly, I'll tell the literature. It has a technical rate of around 90%. There's stenting in SVC syndrome in both benign and malignant cases. The restenosis rate is low as 10%, and complication rate is around 8%. Primary patency up to 1 year, 81%. Primary patency after 12 to 24 months is 63%, and the assisted patency rate goes up to 72%. This is a case 67-year-old female with a malignancy, and she has a significant SVC stenosis. We can demonstrate in the CT. There is a thin streak of contrast. And subsequently, she was in this cross-section which we can see how severe the stenosis is. And this is a diagnostic angio in which we can see the brachiocephalic veins are not involved, but there is a tight stenosis at the SVC-RA junction. The lesion was dilated with the undersized balloon gradually going up to 12 mm, and subsequently a self-expanding stent was placed, so which shows good antegrade flow into the right atrium. If there is a thrombotic occlusion, we should encourage removing the thrombus burden, and ideally thrombolysis or thrombectomy should be initiated within 2 to 5 days for the treatment to be effective. And if CDT should also be considered, and if it's contraindicated, mechanical thrombectomy can be preferred, and anticoagulation is advised in such patients. Now there is a scenario if the SVC stenosis also involve brachiocephalic vein, what to do? So in such cases, opening of one brachiocephalic vein is generally helpful, because opening up two veins carries high risk of complications and associated stent thrombosis. And I will be also discussing about the stenting techniques very soon. So operators avoid bilateral stenting. So this is a case in which we did a double barrel technique, one self-expanding stent to the SVC extending into the bilateral brachiocephalic veins. And the other option is Y-shaped stenting, which is very risky because one stent is deployed to the other stent, so it carries a risk of stent rupture. Post-procedure care, repeat venography and follow-up patients, anticoagulation is not standardized. Generally DAPT for 3 months followed by SAPT, and levodoxaban may be added in high-risk cases. I will briefly show one complication which happened in our case. Patient was a case of fibrosing mediastinitis, and we had deployed a self-expanding stent. This is the initial runs. This shows the deployment of stent, and immediately in the next week, patient developed acute in-stent thrombosis. Subsequently, CDT was done. We can see the filling defects after the CDT. Balloon angioplasty was done, and patient was put on anticoagulation. And this is the follow-up CT. So take-home points, it is a safe and effective technique in both benign and malignant cases. It offers rapid resolution and does not limit surgical options in the future. And if it does not work, always we can report the surgical team. Thank you so much.
Because the inflow, which we have discussed in the previous session, for the upper limbs, it's not that.
Yes. Yeah.
Have you had any cases of reocclusion, the stent? Either malignant or thrombus?
I've tried the.
So in the previous session, as we have discussed, for venous stents, the inflow is important.
Yes.
In the SVC, the inflow is not that much.
Not that much, right.
Compared to the lower limbs.
Yes.
So have you encountered any instant rethrombosis?
Like the case which I was showing, this was not related to the reduced flow, but there have been some cases in which we had not corrected the inflow of the brachiocephalic veins and have performed stenting of the SVC. So in that case, there is definitely thrombosis due to the reduced inflow. So that's why now we always treat one brachiocephalic vein and establish the continuity.
And secondly, in case of malignancy, due to the ingrowth of the tumors.
Yes. Yeah. So generally they say that in malignancy, covered stent, putting a covered stent is a better option. So there are ongoing trials, but there are no standardized recommendations. So, but definitely the covered stents, they give a better patency, especially in malignant cases. But they come with more cost and limited size options available. Thank you.
Thank you.
So I will prefer covered stent because it will give theoretical advantage and a better primary patency. But sometimes due to limited availability of the covered stent of that exact size, then we may end up putting a self-expanding stent.
Mostly lymphomas, in other types of mostly they goes for it goes away. But if not, then in others we go for.
Do you call them for again check angios like after some time?
Sir, our protocol is to follow them after 3 months. We do a CECT. We do not do a DSA. So a CECT is done at 3 months. If that's okay, then we change them to a single antiplatelet, and we then follow up to 1 year.
See, as Vimal sir said, like, venous disease is always venous disease. It's always better to keep these patients in surveillance rather than treating them after, occlusion.
Right.
Yeah, for me, I would like to share from my center. So mostly for the malignant SVC obstruction. So we usually patient is an advanced stage, right? Mainly it's a objective, it's a palliative. So our center is we dedicated bare metal stent rather than cover stent, because so also is expensive, and also we avoid about the micro as well.
Thank you so much.
Thank you, sir. Next talk is from Dr. Shamin Mehta on salvage of AV fistulas.
Hi, good morning, and thank you for the invitation. I'm Shamin. I'm one of the consultants at Liverpool in the UK. I'm going to be talking about a pretty familiar topic, salvage of the thrombosed dialysis access. We do a lot of fistula salvage at Liverpool, and so we use different techniques depending on patient presentation on the anatomy. So I'll try and share the tips and tricks that we use. These are my disclosures, some of which are relevant. Before going into the more technical aspects, I wanted to just review the anatomy very briefly. So this is the primary kind of access that you will come across tends to be the distal radiocephalic, the entoside fistula, followed by proximal radiocephalic or the brachiocephalic access at the elbow. Less commonly, we see the brachiobasilic with the transposition, and then following that, patients will progress to a loop graft in the arm, and then rarely a loop graft in the groin, which is actually quite traumatic for most patients. Terminology-wise, you all know the anastomosis is obviously the junction of the artery and the vein. This curved part of the vein then is called the swing point or the swing segment, beyond which you have the superficial part of the vein, that's the needling zone. If it is a cephalic vein, so brachiocephalic or radiocephalic, then the terminal arch or the cephalic arch, that's the last part of the vein where it dips down and joins the axillary vein, beyond which we go to the central veins. So dialysis access thrombosis occurs about 0.5 to 2 times per year for a graft, and less commonly about 0.5 times a year for a native fistula. So thankfully it's not that common in each individual patient, but because of the general number of patients, it is a very common pathology that we come across. Important to note that about half of these patients have actually been found to have some form of underlying thrombophilia. And so this is something that we start to get tested now more often, particularly in patients who are presenting with recurrent thrombosis, that there may be something underlying and they might need additional investigations and medication. There are no papers that directly quantify the effect of access loss on mortality. And this is a really important thing to realize, because while there's no direct correlation, loss of access exposes these patients to long-term dialysis with prolonged catheter use. And that in itself leads to a higher mortality. So this paper from Mexico looked at 2-year survival, about 400 plus patients, and they compared 2-year and 7-year survival rates for patients with native dialysis access versus tunnel lines. And you can see a significant difference, so 94% compared to 70% at 2 years, but starkly different, 65% compared to 26%. So just over a quarter of these patients were still alive at 7 years, and that's a really important number. Apart from that, obviously there's other factors that get involved. So prolonged catheter use has a 20-fold higher risk of access-related bacteremia. And this is again important because about 9% of these will die within 30 days of that first episode of bacteremia. And that's where that mortality factor comes in. Repeated prolonged catheter use also leads to symptomatic central vein stenosis occlusion. We've already talked about that. So if the catheter is in place for about 6 months, then a quarter of these will have symptomatic central vein stenosis. Of course, asymptomatic stenosis is much more common, but then that will present once they have a fistula created on the same side. And so that will then subsequently cause problems in these patients. So there's several devices that are available for fistula salvage. There is no real evidence that one is better than the other. You can use whatever you prefer. Our preferred technique at Liverpool, so this is what we end up doing. I prefer to use a jugular access to start with. You can use a distal optional access if required to help cross the lesion, but my primary work is from the jugular side. Once you've established your access and you cross into the artery, establish a deep, stable wire. So I would put my wire tip as deep as possible, almost to the axilla. I tend to start with some thrombolysis, so we'll lace the entire circuit with a lytic. and then wait. This is important. You have to give the lytic time to act. So there's no point doing all of this if you're then immediately going to start doing your balloon maceration or whatever other technique you want to use. So we tend to give about half an hour for the lytic to actually do its job. And then thrombectomy with whatever device or technique you want to use, followed by balloon maceration, trawling from the arterial to the venous end, and then finally stent or stent graft as required. And you might need to repeat a lot of these steps before the fistula is running satisfactorily. So this is the setup that we use. So you can see the patient is lying with the head at the head end, the arm is extended, and the exposure is from the neck all the way to the arm. We use this device, we call it a snake. There are various other things you can use, but basically this keeps your drape away from the patient's face. You'll find when you talk to patients that because these are long procedures, very often the patients will give you feedback that they were just really uncomfortable, very claustrophobic. So it's just important from a patient perspective to try and keep them as comfortable as possible, because what you don't want is halfway through they start to get very agitated and irritable. So once draping is complete, this is your exposure, as I said, from the neck all the way to the entire length of the circuit. In this patient, it was brachiocephalic. And I'll always try and keep sterile ultrasound available. So you can see the probe and, in fact, the controls as well, if you can keep them sterile, so that you have ultrasound available throughout the procedure. And this is really important because your endpoint is decided not by the venography, but by your clinical palpation and by the ultrasound. Lastly, a word on the access. So as I said, jugular access is my preferred route. But you can see this access is quite high up. So I'll take the jugular access as high as possible. This gives you a nice long stable sheath in the jugular vein, well above the confluence with the subclavian. So whenever you're doing your balloon trawling and everything, then your sheath remains stable. You're not kind of fighting the sheath tip all the time. So this is the first case, 40-year-old gentleman, multiple comorbidities. This guy was a frequent flyer, or is still a frequent flyer with us. Multiple failed accesses. He's already got CLI. He's had a MI. He's had a stroke. Very, very poorly compliant. All of this at 40 years of age. In this instance, we were treating a right brachioaxillary graft that he had. This was placed back in September of 2019. He presented in May 2020 with graft thrombosis. And incidentally, he was also known to have an occluded right IJV from previous imaging. I mean, it was occluded, but it clearly wasn't that bad, so managed to get through with a wire from the jugular access. And in this particular case, I used a reverse curve catheter, so that's a SIM1. I've gotten it into the subclavian vein. And then eventually, wire and catheter were used to cross. So this is the venogram now just demonstrating the entire length of the graft is occluded. In this particular case, we used a 6 French angiojet device. So the angiojet was introduced from the jugular, and you can see, as I said, the wire is very, very deep into the arterial end, so nice and stable. We used a power pulse using 10 milligrams of TPA, 30 minutes of dwell time, followed by thrombectomy in both directions, followed by a 6 millimeter angioplasty, balloon plasty and trawling. So this was the initial result. Fistula is flowing rapidly, but obviously there's still underlying lesions to treat. We knew that we had that central vein disease, so this was dilated up to 12 millimeters, and that was opened up nicely. And then finally, the underlying lesion at the upper arm, this was plastied to 9 millimeters, and this was the final venogram. So the primary patency of this was 18 months, which was actually quite good for this patient. And the graft remained running for a little over 3 years. Eventually, we weren't able to get it open again, but he's still with us on another kind of access. The second patient, 33-year-old, so again, very young patient, type 1 diabetic, hypertensive, obese, learning difficulties. Again, a very, very difficult patient, poorly compliant on medications. He had a left distal radiocephalic fistula created in mid of 2017. And November of 2018, he presented with fistula thrombosis. Now, in this particular case, the thrombosis was a very, very short segment, just a few centimeters in the distal forearm, beyond which the vein was patent. So given the age and given the short segment of occlusion, I felt that angiojet was probably not the right device in this particular situation. So we did the venogram. You can see there's no flow into the vein at all. So used a penumbra aspiration device in this case. This was a 6 French. And once that was done, there is a cleared channel. And obviously the venogram is not as impressive. So a channel has been cleared, but there is still residual disease. A 6 millimeter plasty across the anastomosis, 8 millimeters into the vein. And then this was the initial venogram after plasty and balloon trawling. So I tried this a couple of times, still not running satisfactorily. And you can see that big blob of clot is still sitting there. And this was quite chronic. It refused to move at all. So after a lot of further attempts, finally I decided we're just going to place a stent graft. So this was a Viaban with a good result after that. And this had a primary patency for this access of about 6 years. He occluded just a few months ago, and this time, despite trying again and again, we just couldn't get it open. But again, this single access has lasted for that long. The third case, 51-year-old, polycystic kidney disease, heart failure, hypertensive, previous peritoneal dialysis, failed transplant, had a transplant nephrectomy, also had a tunnel line infection in the past. He had a left radiocephalic fistula created in 2010. And in December of 2018, he presented with thrombosis of the access. In this particular case, the clot was extending all the way into the radial artery, quite far up into the radial artery, in fact. So this was, again, quite tricky, and I felt that angiojet might not be the best option. So we thought, well, let's see what we find. This was the initial venogram. You can see that clot into the radial artery. As I said, quite a long length of arterial thrombosis in this case. Given the extent of this, I felt that probably lysis was the best option for this guy. The distal venogram, the distal angiogram was actually quite good because the hand was basically fed by the ulnar artery, and on top of that, the radial artery distally you can see is essentially occluded. So it gives us a lot of safety margin in terms of what we're doing as far as the hand is concerned. So placed a Cragg McNamara across, and this was his check gram the next day. So the fistula is running well. There is some residual stenosis in the distal segment of the vein. There is some clot in that in the dilated segment, in the aneurysmal segment. But that, again, was not really causing a lot of problem, and that's a fairly stable chronic clot, so we decided to leave that alone. The underlying lesion is the one at the elbow. So that was treated with a 9 millimeter plasty, and this was the final venogram. And this is his follow-up venogram. So he came back with the restenosis, again, more in that distal forearm at 2 years. Primary assisted patency of this access was 2.5 years. But the access itself has continued to keep running. So his secondary patency, it's still running at this point in time. So a few words on technical aspects. So as I said, my preferred access is the jugular access, but classical teaching for fistula salvage is a dual access. This works quite well for radiocephalic fistulas where you've got lots of space basically to work with. You can use it for a brachiocephalic. It's a little tighter, but you can still manage. That becomes quite difficult when it's a brachiobasilic, and that's, again, where jugular access actually makes life much, much easier. Some workers have described using a femoral access. I personally have never had the need to use it, but theoretically, yes, you could do it. And jugular, as I said, is what I tend to prefer. As far as your dual access is concerned, it's really important to make sure your sheets are placed as far apart as possible. What you don't want is any overlap at all of the sheets, because that little segment, even if it's a centimeter, that segment, if you haven't opened, you haven't done anything. Finally, just about some of the technical bits. So I mentioned the angiojet thrombectomy. This is kind of the technique. This is the rate at which you want to go, about 1 centimeter a second. And this is the same thing for the power pulse, for the thrombectomy, forward and backward. This is how you're going to do it. And then we talked about balloon maceration and trawling. So this is where you partially deflate your balloon and then you pull it back. You basically are breaking up the clot and pulling all of those broken fragments into the central venous circulation. This tends to be a little bit easier if you have someone working with you, if you have a reg or a colleague who's scrubbed with you. It makes life a little bit simpler. Usually after an angioplasty balloon, you might still have some residue, and in that situation, you might need to use an embolectomy balloon. Again, a similar technique with a balloon trawl. It doesn't really help with maceration, but just pulls any residual bits through. Also very useful to identify any residual lesions, by the way. So this was a publication from Liverpool. You can see about 16 years ago now. So this is the technique that we have been using for a very long time. We are very happy with this technique. This is what works for us. But as I mentioned earlier, there are lots and lots and lots of devices out there. There is no head-to-head comparison. So whatever you are happy with, whatever you are comfortable with, is what you should go for. Yeah, there's my take-home points. I would say aggressive fistula salvage helps to prolong the life of each individual access and therefore helps to prolong the life of each individual patient. So it's really important. That's why we are so aggressive with our fistula salvage. Consider the most suitable access for each fistula type and consider different techniques and devices based on the extent of occlusion and your own experience. Thank you.
So the best thing is like a complete circuit analysis is the most important thing. Yeah. And early referral, like, if you train your dialysis technicians to tell that, they have to recognize before the fistula fails. So it gives the most success.
We have an active surveillance program.
Yeah.
So we have, they are on ultrasound surveillance and clinical surveillance. And anything that is found, if it is, there are certain criteria based on the drop in flow rate, the extent of stenosis, in which case they are just directly referred for a plasty. If it falls in the gray zone, then it goes to our weekly MDT.
And it's also necessary to educate the patient also.
The patients, yeah, but it's quite variable. Like you saw the first couple of those patients, they're just a nightmare even to get them onto the table. They just like refuse everything, but yeah. So some of the patients can be quite difficult.
Yes. Thank you. It was a good talk.
Hi, Tar.
Thanks, Shamim. Your second case, which had a resistant thrombus near the anastomosis, how do you predict that on repeated dilatation doesn't go down the radial ulnar artery then? Because those are the ones that, you always get called when the fellow is doing it and they say something's gone down the arm.
I think that's where, occasionally it does happen, obviously. But the getting kind of, not being afraid to make sure your balloon is well into the artery before you inflate it. So you get your dog boning, then you plasty it and you pull it back. Because, even in that was a radial artery, which I did to 6 millimeters. So, you kind of, as you do them more and more, you start with doing a 4 millimeter at the radial artery and being a little worried, and then it's actually fine. They're high flow vessels. They're already running a fistula, so they're running much more than they're supposed to. And they're quite resilient. So I think that's kind of what I would say. The other thing is if you have someone assisting you again, then not just fluoroscopy, but ultrasound guidance when you're doing that is really, really helpful. So we've done some of these where at the anastomosis you'll have someone with live ultrasound, and I use that to actually guide exactly where I'm doing my balloon or stent placement.
And then the second comment was, the thrombolysis. So we've seen over the last, 10, 12 years or more, 2 cases where there was fatal bleeding. So these patients, for prolonged thrombolysis with chronic renal failure have to be tapered well to their TPA regime compared to others with close follow-up. We've seen some.
I think, that was a rare one. I don't think we've done a lot of lysis cases at all.
No.
It was just because of the arterial component.
But I think that's a message just for others, if they're doing it, to be very careful. It's not the same regime.
Yeah. Thank you.
What's the protocol for starting the tissue? That's not very tissue after using. So how much time you start dialysis on the tissue?
So normally we would have the initial scan at about 4 weeks and then 6 weeks. At that point, if the fistula is imaging-wise is satisfactory and clinically satisfactory, that's when they get started.
I have a question, Shiv. While coming from up, it's a very good idea to come from a jugular, particularly here. But in the cases where there is a tight cephalic arch, there is tight stenosis in the cephalic arch. What special precautions you take, because there are many collaterals because of that stenosis, and to cross that stricture itself are challenging.
So basically, it's there's a couple of things here. One is the more you do it, it just becomes easier and quicker. But I have a set sort of algorithm, and I will time myself. So I'll start with a cobra, then move to a reverse curve, and I tell them to put on a timer, let me know when it's like 2 minutes or so. You can get stuck in just, obsessively trying to cross with whatever you've got. So make sure you're just moving down the steps very quickly. Once I've tried those 2 or 3 techniques, if it's not working, then micropuncture, 018 wire, snare, and move on. So that's the important thing, that make sure you run down that algorithm quickly, because the procedure itself is going to be about 1.5 to 2 hours. You don't want to spend half an hour just doing your access, and you haven't even started the case.
So
Thank
you wait for 4 weeks in all the cases after plasty, or in certain specific circumstances?
I thought you were talking about primary creation. Post-procedure, no. They're
That's
ready to
right.
go.
1 to 2 days, yeah.
No,
That's what I was saying.
they're ready to go. For post-salvage, they're ready to go that day or the next day.
Next day, yeah.
Absolutely.
So let's move to the next talk.
Next talk is about difficult central venous stenosis management from Dr. Dheeraj Shah.
Good morning, everyone. My fellow colleagues have spoken extensively about the anatomy. I'll just skip the anatomy part. So how do we assess these patients who come with central venous stenosis? The most common patients which we look are the patients who come up after dialysis with prolonged bleeding at the dialysis access sites, or dialysis which have not been completed because of high pressures. So these are the most common patients which we encounter. Other common symptoms with which they present are, face, neck swelling, and breast swelling in women, and this is how we commonly see our patients. So if it's very severe, that's when they present with respiratory distress, neurological symptoms of confabulation, dizziness, and all that. So diagnostic methods, usually when they come from dialysis, we do an ultrasound to assess if there is high resistance waveforms. The ideal thing would be to do a CT venogram or an MR venogram to assess. The other way to strategize this is to do a venography, either through the dialysis access or through a basilic vein, so that it is both diagnostic and therapeutic for the patient. Though SR has a bit of guidelines and classification system for the type of central venous stenosis, it has an extensive system. I think I just mentioned it. Coming to the pathomechanisms, one thing I would like to describe here is the presence of the venous wall intimal hyperplasia, which happens in patients with CKD on dialysis. The presence of perm cats and long-term dialysis catheters creates a kind of inflammation around the intimal layer, which leads to these central venous stenosis. The other ones, like the extensive compression because of malignancies and tumor compressions, they are the other more common causes of it. This is a study comparing, the prevalence of central venous stenosis in patients with CKD and patients who presented with severe symptoms without CKD on dialysis. It showed a very high prevalence of patients on dialysis with these kind of central venous stenosis issues. And the most common area of CVS issues were in the right brachiocephalic vein. Again, I would like to stress the most common area where the perm cats are placed are from the IJV, which could be the predominant cause factor for this. Next, I would like to talk a few things about the KDOQI guidelines on central venous stenosis management. The KDOQI states that around 5 to 50% of the patients on long-term dialysis, they tend to present with some kind of central venous issues in about 5 to 50% of the cases. It remains the Achilles heel of managing the patients with on dialysis. So if a patient is completely asymptomatic and then you happen to coincidentally pick up features of on imaging, do we actually go and treat them? The KDOQI guideline says that there is no necessity to go and actively do any intervention for these patients because the rate of restenosis is high among them, and you really don't know what is the patho mechanism which is causing this kind of stenosis in these patients. So a study done which mentioned in KDOQI guidelines says that in symptomatic patients it shows a really good patency rate compared to patients who are completely asymptomatic. Again, KDOQI guidelines gives recommendations for stenting in these same patients. It says that whenever there's an acute elastic recoil of more than 50%, or when the stenosis has recurred within 3 months, that's when you can consider stenting in these patients. Coming to the management strategies for central venous stenosis, balloon venoplasty remains to be the cornerstone for the management of this. A good recanalization can be achieved with just balloon venoplasty itself. You need to have a good idea about the hardware which you're using, and in general, we tend to use high-pressure balloons, with atmospheric pressures of 8 to 40 millimeters, and even more in some cases. The accesses which commonly, it depends upon the site and the place of the stenosis. The IJV being the most common area of access, and along with the femoral vein together. And sometimes whenever we're doing these cases, we try to take another access from the fistula itself or from the basilic vein. One is it gives an access for doing repeated venograms, and also whenever to do check venograms, it becomes easy with them. Again, the key factors determining the access is, again, which area gives a better, easier way to cross the stenotic lesion. Sometimes it's, if the complete brachiocephalic is extended and you're not able to see the nipple, at that time you can try to cross over from the femoral and do the access from there. Hardware selection, you need to have an array of hardware with them. One, the extra stiff wires, the usual extra stiff Amplatz wire, and sometimes when the balloons are not crossing, when the catheters are not crossing, you need the Landrequist wires to cross them. Snares are helpful when you want to do the snaring and body flossing techniques. And coming to the balloons, one of the go-to balloons would be Atlas Gold balloons, which come with an atmospheric pressure of about 14 to 16 mm RBPs, and the CallQuest balloons, which comes up to 28 to 30 mm RBP pressures. They happen to make an enormous difference when tackling the central venous stenosis issues. This is one of my cases where we tried to do a balloon venoplasty of the cavoatrial junction and the SVC. Again, we took a 14 millimeter balloon, and then we saw that there was a high residual wasting there. And then whenever you do a central venous stenosis, you have to remember that you need to tackle the waste. The fibrotic phase is the reason for which the central venous stenosis issue is happening. And if it is completely not taken care of, the rate of recurrences and restenosis are very high among them. The same patients, on pre-procedural, he had facial swelling, arm issues, and difficult issues on dialysis. This is the post-procedure in about 2 to 3 days. The most satisfying thing among this is you see results very quickly within a day or two. You see almost complete decompression of the neck veins, the collaterals, and the face. And this is one of the good cases which we had. So what if the planar balloon venoplasty fails when you're not able to cross the lesions? That's why you think about alternative techniques like snaring out and body flossing techniques. So what exactly we do in snaring is, when we're not able to when we're able to cross with our regular thermo wires, we try to cross with our 014 wires, try with microcatheters. And when if an 014 wire passes, we try to snare out with the other end from that of the femoral axis. And then once we have even a thin wire in place, then we can use our hydrophilic wires to cross over. With our hydrophilic wires in and the catheters in, we can take a stiff wire, a Landrequist wire, or an extra stiff Amplatz wire. With that intact and with the body flossing technique then we can literally pass over any kind of balloons over it, and we'll be able to plasty over there. Some of the things which you need to keep in mind when doing this is you need to make sure that you're in the main vein itself and not going through the collaterals, because when you try to do balloon venoplasty of these collaterals with this body flossing technique, there may be chances of rupture. So again, you're not able to open up when there is a chronic stenosis, when there's a complete vein obstruction. How do we negotiate? The most common thing we go to is with sharp recanalization. So when I say sharp recanalization, initially we start off with the stiff end of the 014 wire. We poke a few times, and then we get back with a soft end. We try negotiating it, and sometimes even the back end of a thermo also helps wonderfully in these cases. Even in spite of these cases, if it's not happening, that's when we go to our other things such as a long Chiba needle, an 18 gauge, even a Roop set needle tends to help sometimes when trying to cross these lesions. The sharp recanalization, it gives wonderful results. One of the JVIR studies showed that the results were around 92% while crossing this stenosis. The Chiba needle was mentioned in it, which gives almost around 90 to 100% success. And depending upon the type and the site of where we can use this, the type 2B and the type 3 blockages, they give the best results when using with sharp recanalization. This is one of our case when we did a sharp recanalization in the right brachiocephalic. The important thing when you're doing a sharp recanalization is to have some sort of a guide. You keep another catheter from the femoral side and you have a guide where to sharp recanalize from the above or the below end, so that you don't lose idea where you're trying to poke around. Again, when you're trying to do sharp recanalize, you have to make sure that you have both the sides in alignment. This is the case when you're trying to do when we really didn't get inside the proper channels and there was extravasation around the mediastinum. So whenever you're trying to sharp recanalize, few things you had to keep in mind are the complications which can happen, which is the mediastinal hematoma, hemothorax, hemopericardium in very rare instances, and other kinds of vascular injury. There's again a JVI study which showed, which is the most common complication among. So when to actually consider central venous stenting, along with KDIQI guidelines, I think in general, we don't necessarily go for primary vein stenting in most of the cases. We try to give a trial with balloon venoplasty alone. We see the recoil of the patient, we recoil of the vein. When the recoil is only more than 50% and no matter in trying all the kinds of high pressure balloon, even in there is persistence of such high recoil, that's when we can consider of primary vein stenting. Again, you give a trial of about 3 months and to see if the patient is symptomatic again, and that's when you can consider central vein stenting in these patients. The other example exclusion would be a tumor compression from an extrinsic area which is causing the stenosis. At that time, you can consider for a primary stenting alone for these patients. Because the patency rates post in malignant SVC obstruction is very high, the endovascular success is more than 95% in these cases. Some contraindications exist for central venous stenting. One is the thoracic outlet syndrome and the Paget-Schroeder syndrome. That's when surgical options becomes the first mainstay while doing this. So coming to the results of central venous stenting, unless there's a previous fistula, which is causing some occlusion, it tends to give really good results. And unless there's a thoracic outlet syndrome, other things like that, they tend to give great results as well. Some of the complications which I discussed, like the bleeding and getting into the wrong plane, would be the reasons behind it. Just a few seconds about the kind of stents which we use. The difference would be between other stents and kind of a venous stents is the chronic radial force and the higher, chances of preventing migration within these stents. We have the Venovo, we have the wall stents, and we have the sinus venosus and the Abre stents. And even though the venous stents are slightly more expensive than the regular stents which are used, around 40 to 50K more than the regular bare metal stents which we use, they tend to give better efficiency in the long term. Just some take-home points would be whenever you're trying to create an AV fistula, just make sure that there is no features of any central venous stenosis in the patient. Because the previous case which I discussed was a fistula was already created, and then post they realized that swelling has been increased after the fistula creation, and that's when the patient was sent for central venous stenosis management. Again, when you're trying to, patient needs a pacemaker and they want any other kind of cardiac interventions, make sure that multidisciplinary team is involved in it so that you can try to prevent the accesses which are being used for dialysis creation in the next times. Thank you everyone for your patient listening, and it's my privilege to present this topic in front of my mentor, Dr. Dheeraj Tiwari sir, and I owe entirely to him with regard to fistula and central venous stenosis management, and I learned everything from him and learned seeing his skills, and still I'm aspiring to match up to his skills one day. Thank you, sir. Thank you.
Great talk, Dr. Dheeraj. Question to both Dheeraj. When do you stop reconnection, like when you decide to stop?
I think when Dheeraj sir, when I was working, he had plan A and plan B. Plan A is you keep working until you open the stenosis. And plan B is if you're tired, then go to plan A again. So I think unless you end up with some kind of complications, or I think time is not the duration, where you keep like 30 minutes or 1 hour or anything like that.
Extravasation or something like where you stop.
Unless the patient is stable, unless there is no contrast extravasation anywhere, any other complication, I think you can keep trying. But only when there is a very chronic occlusion where you're not able to see any nipple or even not making any progress after hours of trying, that's when probably you might end up.
Because it's not always technical success, like patient safety is also very important.
That's the only thing which we...
There are two questions. to everybody. One is like after trying everything many a time, things don't happen. Like it becomes chronically occluded. So even cancer is there. So like we have tried doing some surgical bypasses and all, but they also fail. What is your experiences about how to tackle that situation? Patient has a big like all symptoms, problems, everything is there.
Dheeraj, you would like to answer? Or should I?
In dialysis, we try to close the fistula. That is one solution. But otherwise, central vein, so like, what's your take, sir?
So, see what, as he said, that usually we do not leave until like we open them. But at times you have to stop. The patient is worsening. You have administered a lot of contrast. At times the patient will develop some pulmonary edema on table. They are already very much compromised. Extravasation, yes, to some extent at times we stop, but usually we keep on working if the patient is clinically fit. As you said that when you are not able to cross, then I totally agree with you that the surgical bypasses, they do not work so well. Usually they do not work. So fistula closure is the only solution if nothing is working. Necklace bypass they make at times. So necklace bypass, I have not ever seen any patient surviving on a necklace bypass. If anybody has some different experience, maybe Kirati can say something about it.
Yeah, I agree. Usually, it's, if we perform sharp decanalization, right, and it's a fail, also you send patient to do the surgical option. Also, usually it's a short patency, and also it's occlusion again. So my experience in Vital Chair is now it's my routinely for the refractory CVO. So maybe you can use this like a transeptal needle. Also, is another option for the device because also it's quite effective from my experience. And another one you can use is like the RF wire, radio frequency guide wire. Usually in US or in Canada they use this O3 flies system. It's for the vessel, but in my center we quite luckily because we also use this smaller one. It's a 016 from the cardiologist as well. It can use, yeah, it can use. Also, it's insert in the vessel. Also, it's another option.
That's not available here, so that's the problem.
And Dr. Dheeraj, both Dheeraj, like, how prepared are you for the complications? You know, any CTO you're attempting, are you keeping the stent graft by the side?
Yes, sir. Usually when we are attempting a CTO, we keep a covered stent graft, and we also keep the anesthetist to manage because pulmonary edema again is one of the most common things which we encounter because a lot of access is taken, a lot of venograms done, so and also have a dialysis done on the day or previous day of the procedure. I think we need a lot of preparation when you're trying to attempt a proper CTO.
Maybe one more thing, like usually the first plasty, if the patient has not undergone many plasties, if it's a new fistula, new occlusion, then we usually do not go beyond 12 in the initial new fistulas and all. If it's an old one, patient was the brachiopelvic vein was patent, it was working, then we can go up to 14, 16, whatever we want. But initially, if the fistula is not matured, patient after creation of fistula only patient started developing stenosis. In the first initial instances, we do not go beyond 12 to avoid the rupture.
Underinflating is the most important.
Initially, but if it's a long-standing fistula, then occluded, then you can go up to any pressure, any size, 12, 14, 16 also at times.
Maybe adding IVUS to the sharp recanalization, dikh jayega. But many times you have a question.
Not a question, just a comment. We talked about what you need to be prepared for. One important thing is also always prepare the entire chest and make sure that you're ready to do a pericardial drain if needed, because that is one of the most severe, and that one the patient will just
I think that's one of the biggest scares when we're trying to do sharp recanalization. So always prepare for that.
Thank you. It was a great talk.
Thank you, sir. Next, we have presentation from Dr. Girish Kumar on pulmonary arteriovenous malformations. Good
morning, everybody. All right, so my talk is on the pulmonary arteriovenous malformations. So we'll go very briefly through the anatomy. So the normal anatomy is pulmonary artery divides into the arterioles, further divides into capillaries, and then they come together, form the venules, and then the pulmonary vein.
Now, in the pulmonary AVMs, there is this abnormal communication or connection between the artery and the vein, bypassing that the capillary bed where the gas exchange happens, and a lot of other activities happen in the lungs. So now again, these could be simple AVMs, wherein there's just one arterial branch, which is abnormally dilated, and then it leads into the vein. Or there could be a complex AVM where they have multiple branches feeding this dilated segment or this convoluted segment. The prevalence is about 0.04% of all the people born. It's heavily associated with the HST. 65% of the AVMs are associated with the HST patients, and 90% of the HST patients have the AVMs. Now, they may have AVMs in the other areas like liver and brain, but almost 90% of them will have the pulmonary AVMs. And of course, size and number will vary from patient to patient. They're usually present at birth, but usually manifest at different ages. They will completely develop by the adult age. Any condition that will cause increased vascular volume, such as pregnancy or any other altered hemodynamic status, will cause these to grow very rapidly. The physiological effects of these AVMs is either by the lack of the gaseous exchange causing hypoxia, which will lead to dyspnea on exertion or rest. That will cause anemia and other problems down the line. Or it's either lack of filtration, which is causing paradoxical embolization, leading to CVA or systemic embolization, abscess, and things like that. Very rarely, because of the fragility of the walls of these AVMs, they can rupture spontaneously, causing hemoptysis or hemorrhagic pleural effusions. And again, these are bypassing the capillary bed, so they are hyperdynamic, and they can cause high output cardiac failure, usually affecting the right side, causing cor pulmonale. For the diagnostic purposes, either it's by screening of the asymptomatic patients with family history or patients with known symptoms or complications of the AVMs in the past. So you start with bubble echo. If that is positive, then you proceed to chest CT angiogram. In chest CT, you're looking for the location of these AVMs, number of the AVM, size of the nodules, but more importantly, the size of the feeding arteries, the number of the arterial feeders. For the management, the transcatheter embolization is the primary mode of treatment for these lesions. Surgery can be done by usually reserved for diffuse lobar or segmental AVMs. And the goal is to treat all the AVMs in adults. For the children, only the symptomatic AVMs. And we don't treat the asymptomatic AVMs because of the increased radiation exposure. And as they grow, they tend to have more recanalization of these AVMs. So just the symptomatic ones in them. Briefly on the technique, so you can have the right common femoral or the IJ access. We prefer the common femoral access, reduce the dose to ourselves, radiation dose. We typically tend to start with 8 French short sheath, but some providers start with a longer sheath. And then we connect the side arm port with the saline pressure bag through an air filter. We use the angle pictal catheter to get into the pulmonary artery and then get the runs in different projections, usually AP and then 45 degrees LAO and RAO. After we identify the lesion, we exchange that for a longer catheter, either a guiding catheter or a guiding sheath, from which we use a 5 French angle tip catheter, such as MPA or WERT. With or without microcatheter to get close to the AVM. The goal of embolization is to embolize these within 5 millimeters of the nidus. There are several studies that have been published recently where they compare the distance of the embolization from the nidus. And there are so many small branches which are typically not seen on these angiogram studies. If you embolize further from 5 millimeters, there's a high risk of recurrence. Embolic materials over the years, we have moved from, I would say like 15 years ago, we only had the coils for embolization. Then we went on to use the amp laser plugs, and then more recently we're using the microvascular plugs. We have also used them in combination. So this is just a schematic showing the A, which is showing just the embolization with the plugs, B is showing the amp as a plug, C is showing the microvascular plug. The microvascular plug has a PTFE coating, so it is actually occlusive. And then you can use the combination of the amp laser plug with the coils or the microvascular plug with the coils. This case here showing the angiogram. You have the pigtail catheter showing this non-selective run, showing this large AVM. Then you have the angle tip catheter leading to the malformation itself, and which was subsequently embolized with an amp laser plug. Another case showing similar findings. You have the you have the catheter. The key thing here is to recognize your catheter is very, very close to the nidus. As I was emphasizing earlier, you have to be within 5 millimeters or so of the nidus to have a successful result and to prevent recurrence in future. Here, this is a case. Sorry, video didn't run. Again, here we are using a angle tip catheter through which we have a micro catheter leading up to the AVM, and we were able to get very close to the nidus and deployed a microvascular plug to embolize that. Here we have 3D rendering showing another lesion in the right lung where we were able to use the microvascular plug. And this is a patient with tandem lesions. We were able to get close to that, and with just one microvascular plug, we were able to embolize both the AVMs. And this was the final result after the treatment. So for the outcomes, more recent data shows there is technical success rate. If we are using appropriate devices, the technical success is almost 99%, and there is a durable occlusion of about 86%. Again, the data that has come out more recently is new compared to the data that was on the coils, which we have now for like 15 years. The data on the microvascular plugs is more recent, only 7 to 8 years. So we don't know in the long run if that will show more failures, but for now we have almost 86% success rate using the microvascular plugs. Again, plugs are have better outcomes than the coils in the prolonged occlusion. There is significant reduction in the neurological events post-treatment. Procedural complications, not so many. Again, it depends on how much of radiation you're using during the procedure, how many AVMs you're going to embolize in that session. We try to limit to not more than 3 to 4 in one session to decrease the dose of the contrast and the radiation in any given session. 15 to 20% of these patients may complain of protic chest pain because you're also embolizing some of the normal tissue. And if it is very peripheral lesion, you're also embolizing and causing pleurisy by irritating the pleura. Most of these will be self-limited. You can use NSAIDs at times. The other feared complication, but fortunately it's very rare, is the risk of stroke or systemic embolization during these procedures. Again, that happens if you accidentally introduce air during the procedure, so that's why I emphasize use air filters or vascular lines on the vascular lines and or use the heparinized saline. That will decrease the risk of that. Follow-up, typically we do a 6 to 12 months follow-up with bubble echocardiogram. If that is negative, we follow up every 3 years with bubble echo. If that is positive, then we'll proceed to CT angiogram and again, try to identify the lesion and if needed, do the repeat angio and embolizations. And of course, use antibiotic prophylaxis and air filters even after treatment of these lesions. The persistence or recurrence, it's usually because of the either recalculation of the coils, which we have seen. These patients who have been embolized 15, 20 years ago, they typically come to us with recans, or they were collateral channels. That's why you need to embolize within 5 millimeters of that, because there may be collateral branches which will be skipped if you embolize further down. And or like as in bronchial artery embolizations, they can also develop systemic collateral flow, or there may be retrograde flow from the veins. If you see those lesions, again, this is a case showing a flow through the recanalized embolic coil pack. We were able to get back in and use a microvascular plug to close that. And this was another patient who had a collateral flow from the inferior phrenic artery, and we were able to embolize that with coils. So take-home points, there's high morbidity of untreated pulmonary AVMs. Treat all the AVMs in the adults and only symptomatic AVMs in the children. Consider appropriate embolic device based on your expertise and availability. And then surveillance is the key. Thank you. Any questions?
Yeah. So as you said, like you'll only treat 2 or 3 AVMs at once. Like if there are multiple, when do you take the patient again?
After 4 weeks.
After 4 weeks.
As you know, the biology of radiation protection, you need at least four weeks for them to recover from the radiation effect. So at least 4 weeks also gives the kidneys to recover from the contrast dose.
Any other question?
What's your take on using glue for pulmonary AVM?
Never.
You never used.
There's liquid embolics, you never know how far they can travel.
Nowadays, people are using in Korea, they are using with the assistance of a balloon.
Yeah, if you stop the flow in that, again, these are experiments. I have considered that at times when I have even used stents, in these AVMs when I was not able to occlude them with the, with the coils or plugs. But then those are very unusual circumstances, and there's no other option for the patient, and the patient agrees that, there's a real risk that the patient can, develop stroke. If they are agreeable to all those risks and there's no other option left, then we will try that. But outside of that, we'll not.
Yeah,
Unless
depends upon high flow and low flow. Like, even in high flow, you use balloon-assisted coiling or anything.
Yeah. Oh, sorry, I should have. I just assumed that probably everybody's using that. So air filters, they are just filters of different sizes. They will filter out. Again, it's very easy for me to say those things, but unless you have seen it, it's very hard to comprehend that. But these are just very simple devices. You connect it to the line. So you have the IV line. It has this filter has an inflow and outflow port. You just hook it up to the sidearm of the shield, and then the other end you'll have the the saline bag, pressurized heparin saline bag connected to it. So it will just trap any air bubbles that are in the line.
Which company makes them?
Well, I'm not sure. I always tell my nurse, like, okay, this needs to be air filtered, so they know what to use. But again, I assume that it is very standard. So.
Thank you. Let us conclude this session. Thank you for the great discussion.
I thank all the chairpersons for the previous session. We are going ahead with the lymphatic talks, and I would like to invite chairpersons Dr. Prashant Sharda, Dr. Harish Bujade, Dr. Amol Nagwekar, and Dr. Abhishek Bansal to come ahead. And first talk in this session will be by Dr. Ajit Yadav on post-echophagectomy chylothorax. Please, sir.
Good morning, everyone. I'm Dr. Ajit Yadav, and I'm Vice Chair, Department of IR, Sir Gangaram Hospital, New Delhi. And topic is basically it's a lymphatic intervention chylothorax, but the specific is post-echophagectomy. I have nothing to disclose. So chylothorax is basically caused by the thoracic duct or lymphatic injury during the echophagectomy, and incidence is approximately 0.4 to 4%. It may be in other groups influenced by the extent of mediastinal lymphadenopathy and lymphadenectomy, surgical approach, prophylactic thoracic duct ligation, or tumor location. If we say disease burden is approximately 2,000 to 10,000 cases per year, and in India it's around 100 to 1,200, so it's underreported. So we have a lot of patients that we can treat, but it's underreported, and the specialty is not properly tell to the surgeon that we can do it. What is the management algorithm? If we take the patient, the diagnosis is by the milky chest drain, pleural TG is more than 110, and step 2 is initial conservative management. It's always the low fat diet and injection octreotide. But if it is high output fistula, we can take patient directly for intervention, and that is the lymphangiography, MR or conventional, and then thoracic duct embolization. And if that failed, then patient should go surgical management. That not directly to the exploration and do the thoracic duct ligation. How to do the lymphangiography? We take 20 to 25 gauge spinal needle, tubings, lipidol, syringes, pressure pumps, Chiba needle and microcatheters. So we do the puncture of the inguinal lymph node and then we inject the lipidol at the rate of 0.2 ml per minute. Maximum dose we can give is 0.4 ml per kg body weight, and then we check the fluoroscopy every minute, like initially for few minutes and then every 5 minutes. So when we do the injection, it should not balloon out. You make sure that it goes in a beaded fashion, then only you can opacify all the lymph nodes and then it goes into the cisterna calli and thoracic duct. So when we did the lymphangiography and found the leak, then how to enter into the thoracic duct? So there are two methods. One is the transabdominal percutaneous puncture of cisterna calli. Like in this case, directly we puncture the cisterna calli, and if it is within the 10 centimeter, like in this case, already the thoracic duct ligation was done, and so glue was injected from the cisterna calli only. Sometimes you can enter into it and then take a microcatheter and then embolize. The other way is retrograde, direct percutaneous transvenous cannulation of the thoracic duct. So you take a catheter, go into the subclavian vein, and then hook your thoracic duct. It's a difficult one. If you do the lymphangiography and you can see the contrast, that will be easier. But if you can't, that you just take a catheter and go inside it and poke it into the different veins, and ultimately you are going to find, you can take the help of ultrasound also. And take your catheter inside, then take microcatheter, and with the rotatory movement, you can take your microcatheter inside the thoracic duct. I'm going to show you one case, how I do the case of the chylothorax treatment. So, a 52-year-old male, known case of carcinoma esophagus, thoracoscopic esophagectomy was done, and he developed the chylothorax on post-operative day 3. Conservative treatment was failed. This patient, the lymphangiography was attempted outside, but they didn't find any leak and the contrast was not seen in the thoracic duct. So that's why the patient was referred to our hospital. So we did MR lymphangio first. So how we did the case? Like in this case, we did the MR lymphangiography because initially the lymphangiography is already done outside. So we planned that we should do the MR lymphangio. We take the contrast 50-50 and then made a local into it. And we found there is a leak in the mid part of the thoracic duct. So it's a complete dissection of the thoracic duct was seen. So we did the conventional lymphangiography. As I told you, we took the puncture into the inguinal lymph node by the 25 gauge spinal needle, then take the lipidol into pressure inflator, the balloon inflator pumps, and then increase the pressure up to 3 atmospheric pressure, and it goes smoothly. So you don't need multiple working hand with you. Leak is seen at D8 level. Now, how to enter into thoracic duct? Take a Chiba needle, go directly from the anterior abdominal wall into the cisterna calli, and then take a wire. Wire, maybe you can just take the help of AP and lateral view. Wire can be seen, maybe it can go beyond the thoracic duct, so you have to just little bit pull the needle and take the wire inside. Sometimes you need maybe the DynaCT for this. So DynaCT can help you, maybe academically sometimes it help to see the leak. So in these cases, we always go for the DynaCT to see the leak is directly from thoracic duct or from any tributary. After checking that a leak is from the main thoracic duct, we take a microcatheter over the wire. Make sure your microcatheter should reach up to the level of the leak, because if it is a continuation of the leak and we find there is a proximal duct also, then we have to block it from the anterior and posterior side, both sides. But if you find it's a completely dissection, like in this case, the complete rupture of the thoracic duct, so we take a microcatheter, put a coil first, and then take a 50% glue, and we block whole of the thoracic duct. After removing your catheter, you just have to compress it for 1 or 2 minutes. So in this case, the drain output the next day decreased to 200 ml from 2 liter. So this was the one of the case that we treated like within a day, and we discharged the patient on next day. So the take-home message is, we always start these cases with a conservative management. We reassess the patient after 3-5 days. MR lymphangiography is not usually indicated in the iatrogenic cases, but if there is some malformation and you find it is like a failed case, like in our case, then we should go for the MR lymphangiography first. If it is high output leak or failed conservative therapy, patient should directly go for the lymphangiography and thoracic duct embolization. Early escalation of IR-guided therapy delay and reduce morbidity and limit the need for the surgical re-exploration. This is my team at my hospital, and these are my social media handle. If you want to connect with me, and if any question, you just connect on those social media handle. Thank you.
And I think we'll take the questions at the end of the session, sir.
Yeah, thank you.
Thank you, sir. Next talk is by Dr. Ilango on refractory chylosositis.
Hi, I'm Dr. Ilango. Half of my work is done by Ajit sir, so I'll be rushing a little fast. So chylosositis is just a leak of chyle from any of the lymphatic ducts. It may be from the intestine, it may be from the pelvic retroperitoneal. So classification, its most common cause in our setup is mostly traumatic because we diagnose that very fast. Other causes may be infection, malignancy, inflammatory causes, etc. And one more common cause is CLD. In those patients, doing a TIPS will solve the chylothorax also, chylosositis also. Presentation, usually they present with ascites, but they may be complicated, particularly in post-op patients by dehydration, electrolyte imbalance, etc. They are more prone for infection as well. So the basic anatomy. And variations, we may have duplicated thoracic duct or the right-sided thoracic duct. These are common. In right-sided thoracic ducts, it's difficult to do the transvenous puncture, or we have to do from the right side, right basilic vein. Diagnosis, ascitic fluid evaluation is diagnostic. Presence of chylomicrons in the ascitic fluid is diagnostic. In lymphangiogram, conventional T2 lymphangiogram, it's very hard to see the leak because most of the ascites and everything will overlap. If you do a lymphangiogram, MR lymphangiogram, we can pick up the leaks. Once the leak is picked up, the cure rate is very high. Treatment options, as sir already said, low volume, it's conservative always. High volume, intervention is the first choice. If you fail intervention, you go for surgery. Conservative diet is high protein, medium chain triglycerides like coconut oil, and we say strict no to long chain triglycerides. Drugs, octreotide, somatostatins, and these reduce the portal flow and they reduce the chylous leak also, chylosositis also. So, just a video of transpedal lymphangiogram. Transpedal lymphangiogram is almost very rarely done nowadays. Maybe for inguinal leaks we can do transpedal lymphangiogram. Other than that, everything is replaced by node puncture. And after transpedal, some people puncture the inguinal nodes and then continue the lymphangiogram. Intranodal is the gold standard nowadays, and some cases it's diagnostic as well as therapeutic. So, sir has already explained the procedure, and the main thing I want to stress is we have to puncture the medial aspect of the nodes on the medial aspect of vein, femoral vein. So, because lateral aspect, the veins may, the nodes may drain into the lateral part. No, it may not go to the abdomen. It will drain into the superficial lymphatics. So you have to puncture the medial aspect of femoral vein. Nodes on the medial aspect of femoral vein. So what to expect? You can see obstruction, you can see reflex, we can see leakage, we can see the normal finding also sometimes. We may not see the leakage at all times. So the leakage may be at many levels, at the post-op field particularly. This was a case where just doing a lymphangiogram cured the pelvic leak. And in some cases we can directly embolize, particularly in pelvic leaks. You can directly, once we find the leak, we can just do a dilute glue inside the node. It will embolize the leak. And the transabdominal access, we use a Chibon needle, 20 centimeter Chibon needle, and we use a 300 centimeter wire to access the leakage site. We have to access proximal to the leakage site. At least we need a 5 centimeters so that we can advance the micro catheter, and then we can embolize that. And this is a video of the puncture. Once the wire goes, we can use a micropuncture wire also, but then we have to put a sheath, micropuncture sheath. So better to use a 300 centimeter wire. And sometimes we use a roll of multiple planes as well as cone beam CT to puncture, to locate the leak as well as to puncture. Embolic agents, glue coils, or sometimes Cetrol also can be used. Mechanical disruption also can be used, but we have to do mechanical disruption on multiple places. Just puncture the duct. If you are seeing the duct, just puncture with the needle at multiple places. Sometimes it causes sclerosis. This was one case where we had an obstruction, and there was a reflex. The blood flow was coming back. So direct puncture of the node, and we were able to see a leak. So follow is very safe, and there are some cases of pulmonary complication, particularly pulmonary thromboembolism reported, and allergy to lipidol, and sometimes if pedal access we are using the methylene blue, there is a high chance of allergy also. And post follow, usually within few days the chylous ascites reduces, and then we give a oily food and check if there is a good response. Retrograde transvenous approach, sir already told. So this is usually if you are not able to see the thoracic duct after the occlusion, and if you are not able to puncture the thoracic duct, we can use the retrograde access. We use the SIM catheter, form the SIM catheter, and try to hook the junction of IVC and IJV and subclavian vein, and we may be able to enter the thoracic duct. It's very difficult because we won't be able to see the contrast, but once we have entered, the procedure is simple. Sometimes we can puncture directly the node, and then we can pass a wire. Once the wire goes, you can snare the wire and take the catheter in the backside also. Ultrasound also, sometimes if it's visible, it's easy to puncture. It's seen at the junction of IJV and the subclavian vein. Abdominal leaks also can be cured via thoracic duct cannulation, transvenous approach, and you can just embolize. And some cases you can use CT to do direct abdominal node puncture and then proceed with embolization. So direct puncture, faint filling was seen going upwards after the node was punctured, and from there the leak was sealed with glue. Dilute glue just goes inside the thoracic duct and embolizes. And the chylous ascites was completely stopped. So peritoneovenous shunts, these are palliative. It's just like a perm cath. We just drain the ascites into the venous system. It has complications like hypokalemia and all, but this is used for palliative, but particularly in post-op patients. And it can be done percutaneous also. Surgical ligation is also a treatment, and particularly if they are able to detect the leak intra-op, the chance of surgical ligation, success of surgical ligation is very high. Otherwise, we may have to do a lymphangiogram and show them the spot where to ligate, and they can ligate it. If they are not able to ligate, they can wrap around the soft tissues and just tie the lymphatic duct, thoracic duct. IMRT is also reported to be useful in chylous ascites. They just give some divided doses, and it is seen to be useful. So this is a flow chart. So take home message is do lymphangiogram. And mesenteric lymphangiogram, hepatic lymphangiogram also can be done. There are some articles regarding that. And thoracic duct stent placement and angioplasty is also reported. And these are the references. Thank you.
Thank you, sir. Next talk is on management of venolymphatic malformation from Dr. Ashish Balla.
So I know we are in a predominantly lymphatic session, but my topic is on venolymphatic malformation, so I am going to talk about venous malformations also. I'm not covering the basics here. I will cover 3-4 challenging case scenarios which we usually encounter. My practice in this regard is predominantly in craniofacial vascular malformation, so I will share challenging scenarios from there. just in the beginning, the ISWA classification, which I think was discussed a lot in the pediatric. From a publication perspective, I just want to discuss, that it's a very interesting way the way ISWA handles this publication. The first time I have seen something, it's called a live document, which means that this is indexed on PubMed. It shows up as an index publication, but it is a live document, which I assume means that the ISWA reserves the right to upgrade it constantly on the website, and yet it is an index publication. So it's a very interesting format in that. The terminology broadly is now slow flow rather than low flow. And we will talk about venous and lymphatic. The venous basically is classified into isolated multifocal syndromic. So we'll first dive into our first case scenario. This is a 15-year-old boy. His only presentation is a supraclavicular swelling, and which he does notice that after exercise or gym, this tends to increase and becomes painful for him. You can see some dilated venous channels in the ultrasound. Patient was already carrying a MR with him. On the T2 weighted, you can see some intraluminal filling defects within these dilated spaces, which tend to suggest that the substantial component is venous rather than lymphatic, because these represent thrombolytics before they become phlebolytics. And following the ISWA, what would it get classified as from a theoretical point of view? So this is an isolated form. When you call it an isolated form, we have to label it as phlegectatic or spongiform, and this one will get labeled more as spongiform form. Now, should we treat this patient? Are there any guidelines? Because you know that sometimes in slow flow, the symptoms are so minor that you really don't achieve much by treating. So this is an article which lays out that the presence of at least one absolute and two relative indications are required. Broadly, we took up the patient based on the two relative indications, that apart from swelling, he said that after heavy exercise, there is a distension and a warmness, which he finds uncomfortable. In terms of management options, we all know, and we will see as we go along. What is the next step when you have decided already on your basic ultrasound and the MR that it looks more venous? Well, your treatment strategy is going to depend on what is called the Pew classification, which means that you want to classify the nature and speed of the draining vein. So it depends on whether peripheral drainage is present or not, whether those draining veins are dysplastic by themselves, and whether it is classified as early or late, that before 5 frames in your DSA or after 5 frames. So this Pew will basically decide how you proceed with your treatment. In our instance, what happened is that I showed you part of the ultrasound earlier, and we tend to do what we ourselves call like a sonophlebogram and do inject saline before we go into the procedure to try and judge how the flow is. And what we found was that there was a huge communication with the subclavian vein. So herein it was not like a small draining vein. So was it like more like a venous aneurysm and not a vascular malformation? We weren't sure, but we had a huge communication, wide neck aneurysm. Do we send him up front for surgery? Patient had minor symptoms. Can we go for stenting? It's behind the clavicle. It's a functional area. So anyway, we proceed with our phlebogram. In the phlebogram, as you can see, that there is a distinct lateral component and a medial component. In the lateral component, there is stasis, but the medial component washes out. That's the one which is like freely communicating with the subclavian, which we already saw in. So what do we need to deploy? We need to deploy something which is referred to as stase. Stase means that obviously some form of stasis of efflux has to be achieved. Whether you want to do it only by manual compression, you want to use a permanent system like coils, or you want to use a temporary system like balloon occlusion. If we use balloon occlusion, we have a wide neck aneurysm here, and the moment we deflate the balloon, we might just lose all the sclerosant that we have put. So we anyway go into the subclavian, and as you can see in the run, that there is a wide neck aneurysm. But this is not entirely covering the entire lesion. We saw it tends to stay in the lateral one, but washes out of the medial one. Our plan was that we will still attempt sclerotherapy for balloon because it's 15 functional area. We didn't think that with these symptoms a stent was justified, and so we did want to give Interesting thing is that we had access through subclavian, but I would like you to go through this article, which is very nice on the nuances of doing venous malformation, which also suggests going through the lesion and placing a sheath to achieve balloon occlusion in the efflux vein. So we can place a sheath within the venous malformation and then achieve the balloon occlusion from there. In our case, the route was available. So we did a balloon occlusion, and after the balloon, as you can see, that there is stasis. So if I have achieved stasis after the balloon, can we go ahead and proceed with the sclerotherapy, or is there a problem there? There is a problem. When you occlude all the veins and then you start to put the sclerosant inside, what are you going to do? You're going to create a high pressure system and it's going to burst. And even if it doesn't burst and there is some extra, you know, that sclerosant glue are very nice when everything is inside the vessels. The moment it goes out, that inflammation and everything is going to make it very embarrassing for you, apart from the vessel and nerve injury. What do? You do something known as the double puncture technique, which means that whenever there is a situation where the pressure within the venous malformation can go in, you place a second needle, which is like a pressure cooker. It lets off the steam. So you simply put in the second needle and keep the cap of that scalp vein or the needle open to give a pressure ejection, something to let out, a vent to let out. So we used a double needle system. So one, we were occluding the outflow, yet we were giving one channel for outflow so that we don't increase the intravascular pressure. This is after we did our initial injection of the polidocanol. We are happy with the stasis side, but there are these mobile echos which are dancing in that area, which is, I know the moment I deflate the balloon, this is going to all go into the systemic. What do? Do I put glue? I'm in the main subclavian vein with the balloon. If I put the glue, it's going to get stuck over there because I obviously need to use a high concentration of glue. I may not get a safe exit out. So going by, pseudoaneurysms of femoral artery experience into a venous situation, we said, let's just use thrombin and be patient with it. Dwell times are the key in venous malformations and lymphatics. So achieving a good dwell time of it. So we added on the thrombin and we stayed in with the balloon slightly deflated for another 20-25 minutes, and a couple of weeks later, at the moment we are still good, but we are into December. We've done this procedure only about a few weeks back, and hopefully this will hold. If it doesn't, it goes for surgery as you. Let's look at a second case scenario. This is a patient who has a malformation which is substantially going into the airway. So this is a very common situation with us. The standard teaching is you can use bleomycin when lesions go into delicate areas. How much of bleomycin can you use? Especially when you're dealing with kids, there is a dose limitation on bleomycin. So what do we go in for? An elective tracheostomy. I'll deal with this later, maybe in Q. It's a big leap of faith for the patient who is walking around without stridor to get an elective tracheostomy done because you said so. And when you get an elective tracheostomy done, it becomes your responsibility to get it out, what is known as decannulation in time. In our index patient, as you can see, over a period of time, the airway is cleared and we decannulated. A very good knowledge of airway ultrasound is required. A constant, we keep in touch with the ENT who sends us videos and makes diagrams of what they find on FOL. You cannot on MR knock out every millimeter of that vascular malformation, but they tell us that there is some malformation still remaining in the valvula. Okay, valvula on ultrasound, hit valvula, take out that malformation. Average 2-3 FOLs are required before the entire lesions get in. We don't knock out the whole lesion, we knock out the whole airway component and decannulate the patient. Without decannulation, intubation, etc. is a lot of trouble. Last case scenario, lymphatic malformation, dealing with it. How is it different from dealing with a venous malformation? That you always empty it out before you put the sclerosant. What is the problem in lymphatic? Looks very simple, reaccumulation. You do the lesion today, send out the patient, it looks the same the next day. So a lot of our referrals are what was earlier called cystic hygroma, which is neonates and infants who have airway obstruction, and you take the patient under GA, you deflate, you put in the sclerosant, last case, I'm just coming to, and next day it looks the same. So what is the strategy we do in these neonates and infants? We place a catheter on day 1. That procedure is done under GA. We do the first sclerotherapy under GA and then call in the baby every day for the next 3-4 days, and whatever component reaccumulates, we go on aspirating and go on again resclerosing till we achieve a complete sclerosis, and we find that the outcomes in neonates are way better and reaccumulation does not happen. Briefly, something I don't do as yet, part of this I do. We use a lot of adjuvant drugs, and nowadays we are supposed to all biopsy these, see the mutations, use the drugs. Apart from sirolimus and thalidomide, limitation is cost. Whole West is talking now about BEST. I don't know if any of you have this gadget. It's costly, haven't been able to convince the hospital to get us a BEST as yet for delivering bleomycin. Ablation, we are trying to switch from sclerotherapy to ablation for slow flow. Maybe we will have results to share next time. It's very early for us right now, but again, most of the literature now is coming out on cryo and RFA in venous malformation. So take home times, I just shared some tips and tricks in craniofacial vascular malformations with you. Thank you.
Thank you, ma'am. And I would like to call Dr. Ajay Alex to present on Fontan-related PLE, hepatic lymphatic embolization.
A very good morning to all of you. It's a privilege to be actually speaking after all the stalwart experts beautifully describing the lymphatics. So my mandate in the next 10 minutes or so is basically to deal with one of the relatively rarer spectrum of lymphatic abnormalities pertaining to protein-losing enteropathy, especially in patients who are single ventricle or basically cardiac congenital heart surgery, post-surgery Fontan patients, something that can be extrapolated to protein-losing enteropathy secondary to mainly all cardiac failure patients in general. So I start with a case of a 14-year-old child who had congenital cyanotic heart disease, for which he had only a single ventricle to pump blood both into the pulmonary circulation as well as the aorta. Now for the same, the patient underwent something called as a Fontan in 2022 along with MAPCA embolization. Now the patient presented 3 years later with recurrent admissions for cardiac failure with diarrhea and hypoalbuminemia requiring recurrent albumin infusion. The CT shows the patent Fontan circulation with very minimal pleural effusion and ascites, but mildly edematous duodenum and few of the jejunal loops are seen. Now, examination-wise, saturation was maintained, pedal edema and hepatomegaly as is evident in the CT because of cardiac failure, with an albumin that at the time of admission was 0.7, with no other primary renal or hepatic disease was the status of the child at admission. So basically in a normal heart, we know that there is a right ventricle that pumps blood into the pulmonary artery. There is a left ventricle that pumps blood into the aorta and its branches. Now, because of the congenital morphology, there is only one ventricle that may be the right or the left that pumps blood into the aorta. The surgeons will bypass the blood from the SVC and the IVC into the pulmonary artery, meaning that it will be the systemic pressures that takes the blood into the pulmonary circulation. That essentially means that when there was a good drainage of the lymphatics into the SVC, which was at a lower pressure, this has been transformed to a high pressure systemic circulation. And because when the ventricle starts failing, there will be back pressure venous congestion that's transmitted along the lymphatics that will cause lymphatic leak at various sites, one spectrum of which is protein-losing enteropathy. Now you need both clinical as well as the laboratory parameters with reduction in serum albumin to make a diagnosis of protein-losing enteropathy. Additionally, you can look at the elevated levels of alpha-1 antitrypsin in stool. Unfortunately, this test in stool samples are not available in majority of the cities here in India. Now, once you have made a diagnosis of protein-losing enteropathy, you need to look at any of the other treatable causes, especially with medical therapy to treat the inflammation as well as the cardiac failure and few of the surgical conditions as well, with the last resort being heart transplant. Now, lymphatic intervention is something that comes before that. Now, before we go into that, the hepatic lymphatic starts with lymphatic capillaries, which are seen in the periportal area in the space of Moll. Now, normally, this will drain along the portal vein into the hepatic hilum and then via lymphatics into the cisterna chyli and into the thoracic duct, as is evident in the MRN conventional lymphangiogram. Now, when you have a back pressure or venous congestion in the lymphatics, there are abnormal 4 patterns that can happen. One is that there can be along the hepatic lymphatics from the hilum, it can leak into the peritoneum, causing chylous ascites. There can be an abnormal connection via the falciform ligament along the diaphragm into the peribronchial lymphatics, wherein it presents with plastic bronchitis. There can be back pressure into the mesenteric lymphatics to the jejunal loops, which will be seen opacified to the left of the vertebra in the hepatomesenteric pattern. And the most commonest pattern that you get in protein-losing enteropathy is the hepatoduodenal pattern, wherein via the hepatic hilum, the lymphatics in the periduodenal peripancreatic will fill and it will leak into the duodenum, causing the protein-losing enteropathy. So how do you perform this? This is relatively easy. The target is basically the hyperechoic tissue that you see either in the central or the peripheral portal vein branches. So you just put a needle here. Now generally we recommend, what we use generally is a 26 gauge LP needle, and for support what we do is we use the 21 gauge Cook's micropuncture needle first, and inside of that we place this 26 gauge before we target the lymphatics. Now under ultrasound guidance you just put a needle into this hyperechoic area, and then you take your contrast, and under fluoroscopy you start your injection, slowly withdrawing the needle. So you see these linear strand-like structures that come along the periportal network towards the hepatic hilum and the peripancreatic region. If you have a zoomed out view, this is the view that shows the filling of the periportal lymphatics and coming to the dilated periduodenal lymphatics with leakage into the duodenum. Now once this is done, your procedure is also relatively simple. Through the same needle, you start injecting. In our center we use glue at about 20 to 25% till you percolate it till the duodenal, periduodenal lymphatics to embolize the leak. Now many centers where there is the option of doing an endoscopy, you have the option of confirming that leakage in the duodenum if you inject ICG dye through the needle that is placed under endoscopy. Now people have tried with various embolic agents. Just with Lipidol, glue is the most widely used. Prosomaxamycin has also tried with Onyx 18 in this particular description. Now post-procedure clinical monitoring is only for infections primarily. We give perioperative antibiotic because we are playing around the biliary tree in general, and the albumin levels we follow it up every week till about 4 to 6 weeks. Generally imaging follow-up in these particular subset is not needed. Now the protein-losing enteropathy patients, more than 80% is associated with this pattern of hepatoduodenal, and therefore more than 80% of these patients would actually have good recovery and good result with this procedure, which is translated to better survival in these patients with post-Fontan. Now how long does it take for a response in your albumin to come back to normal? It varies from about 9 to 33 days. So anywhere on an average of 1 month, it will come back to normal, as in our patient who had an elevation to 3 in about 3.5 weeks. Bleeding is a minor complication. Non-target embolization into portal vein is relatively can be managed conservatively. Incomplete response recurrence, you can always go ahead and repeat the procedure along when you target another area of the periportal network. So basically, to sum it up, this basically addresses the direct location where the exact leakage of proteins happen when you are targeting the hepatic lymphatic embolization, and this should be always considered as a minimally invasive alternative, especially in refractory cases post your medical therapy. And it's always worthwhile to keep in mind that not only the general lymphatics, the thoracic duct is likely to be abnormal, the hepatic lymphatics may also be abnormal in patients in whom you have a thoracic duct lymphangiogram to be normal, and they may still be having a systemic lymphatic disease. So always make sure that you can do a liver lymphatic to actually get it evaluated and relieve the patient of his or her symptoms. Thank you.
The lymph node is going to be enlarged, and then we can do the lymphangiography. When we enter into the system, Dr. Abhay Srinivasan is going to have a talk on that. We can still enter into the system in the small kids also, but you need some catheters, maybe 1.7 catheter to enter into the thoracic duct and go super selectively into the smaller branches. Post-Fontaine, we have so many patients that are having. So if the same funda apply, if it is low fistula, low output fistula, just do the lymphangiography and wait for 1 to 2 weeks. And if it is high output fistula, then definitely we'll directly go ahead with the embolization. But the concept is same as adult. It's a relatively very short period of time because it's in hardly 10 minutes we can do the lymphangiography in kids.
I think in spontaneous cases, if you only do with the lipidol, just the diagnostic lymphangiography.
So in
then
spontaneous
analysis
case,
sometimes
you plan your case, always do the MR lymphangiography first. Never ever take the patient for conventional lymphangiography. Do an MR lymphangiography, then plan your case accordingly, because most of the time you don't see any leak. If patient is having ascites and effusion both, treat that patient like an ascites, because effusion is because of a negative intrathoracic pressure, the ascites goes into the pleura. So never treat that patient कि prophylactically embolize कर दें thoracic duct को हो जाएगा. That is going to worse the situation.
And I think Dr. Jeet and I were part of that Circe lymphatic discussion. I think Ilango had a very important topic of chylous ascites, and I think the last slide that you showed was the most important slide, the mesenteric lymphangiography. Because normally if you're approaching from retroperitoneal structures, you're going to miss the mesenteric leakage points many of the times. And Dr. Jeet has done a few cases as well, and Dr. Har, when he showed those first things. So he has a very good article, I think, this last year's JVIR, that he's shown multiple ways of approaching how to do a refractory ascites, chylous ascites. So, sir, your take on that, sir?
So I think whenever you have a chylous ascites patient and the spontaneous one, so that is the most difficult. You do an MR lymphangiography. If there is no leak, don't directly go ahead with conventional. Try to do the hepatic lymphangiography. If that is also negative, try to see the mesenteric lymph node and do the mesenteric lymphangiography. If we find, but there are multiple lymph nodes in different sectors, so we have to take multiple punctures. The problem with mesenteric lymphangiography is when you press with the ultrasound and put the needle, when you release the pressure, the needle is going to come out. That's why we needle IMAX needle, that Dr. Max Itkin has that particular needle that you can put in the lymph node and then you press it and one sturt is coming out and that's stuck into the lymph node. So that kind of needle we need for the mesenteric lymphangiography. Or you can just take the patient in CT scan and then do the lymphangiography, then you enter into the lymph node and then inject the dye. Because ultrasound guided injection is difficult. When we release the pressure, it comes out.
And that's what some of the data was from intraoperative mesenteric. Yeah.
Yes, sir.
No, so mine was a comment for the venous malformations, the slow flow, and we do best. I come from London, so we have the experience. We've done over 50 cases. It's really a change of our
I
practice.
believe so. I believe. The only thing I understood is that as of now, it is like a patent technology in that only one vendor, no?
Yes.
It is.
They are here.
They're here.
Telling me that they're going to be in
Yeah.
India in
Launching
the
it.
next 6 months. But it's really changed my practice.
And so when I was in Dr. Murthy's SPIR also, everybody was showing mostly their best results. And Rajashek was showing his cryo results. And but I don't know how much it's going to cost in India, and in high volume centers it will work, but we will need them desperately. For us on a busy day, it's like 20 a day, you know, and if you can reduce the number of sessions for them.
It reduces the number of sessions considerably. The results are quicker. The bleomycin dose is less. So there's a lot of benefit.
In our context, in government spending, if only one person makes it, the government is suspicious that why do you want to buy it? Like, that's what I'm worried that if there are two competitors, anything is easy to buy. When it's single vendor, we are under lens
L1,
that why are we buying a single vendor? But I don't know how, has he said how much he's going to price it here?
I think they're going to launch in ISVRM. They haven't really come up with the
He
pricing
said
as yet.
2-3 CR when I was in Australia. He was saying 2-3 CR. That's equivalent to a good ablation. Like if you buy a
Actually,
cryo also.
ablation is also a very good thing. The simple ablative techniques, if we can get the linear things,
RFA
and
we
it's
have
a real,
started trying with
we have done
effective
quite a number of
and
cases with the
this
microwave ablation also. The same fiber that comes with venous malformation, and ablation actually closes it completely. Like you can just get
so
the
in
good
my
result.
craniofacial practice, I tend to experiment only on the neck. I don't do these things on the face. Before I've seen on the neck that it's working, because if somebody's skin gets discolored or ulcerated more than what you started with, then your battle is lost, because whatever is on face, we can't play with the...
We haven't seen a big pigmentation yet with the face.
With the
we do
breast.
a lot of tongue lesions. It works really well for the tongue lesions.
Yeah, tongue is a huge number also. We are using sirolimus in almost all the tongue ones in addition to the...
So these work very quick, 6 weeks, and you see such a big change.
I think if it's a high volume center, it's going to be a must-have thing to get.
So I think in the interest of time, we'll close the session. And great talk, Ajay, as always, how IR should really help the cardiac surgeons.
So, in your case, you planned for the hepatic lymphangiography. So, how would you suggest that anything else before going for hepatic lymphangiography? Means any endoscopy, any biopsy from the duodenum or?
No, actually, endoscopy is a good thing to go ahead with. But problem is plain endoscopy will only show you edematous duodenal folds, which is an indirect marker that the patient is having protein-losing enteropathy. But hypoalbuminemia in a patient with cardiac failure, it's almost always secondary to leak from the bowel. Along with diarrhea, it should clinch the diagnosis. If you want a good diagnosis, the best thing to do is always the ICG injection in the periportal lymphatics if you do, because that is something that's available with all gastrosurgeons. They left and right use it with all their anastomosis, especially in the biliary tree, to see for patency when they are doing their laparoscopic anastomosis. So that's something that's readily available. So if you have the option of a gastroenterologist in your institute, you just need to keep the endoscope in the duodenum. Once you have targeted the periportal lymphatics, just put ICG, automatically that leak will be detected visually, and then you can go ahead.
So we did in a similar patient of the PLE. So we injected the dye and it came out, and by the ERCP we take a needle and we enter into that and injected the glue by the ERCP, by the endoscopic probe. So we injected glue there, but that is problem is it's going to spread in one area only. So you have to take multiple punctures in that area. What is the role of MR lymphangiography in these cases?
MR lymphangiography also will show the same thing. Actually, you can delineate the anatomy, one thing. Second, you will see the gadolinium contrast leaking into the duodenum as well. So if you take your delayed, there will be gadolinium in hyperintensity within the duodenum. That will also give you a confirmation that yes, it's leaking in the duodenum. If
So
there is
we
leakage
should
in the
do
mesentery-
MR lymphangio first.
Yeah. In this case, we have not done because it was almost ready, and under GA we thought we'll directly take it up. That's it. Thank you.
Yes.
I thank all the chairpersons for this session. And next session will be chaired by Dr. Kunal Gala, Dr. Manish Shah, and Dr. Abhishek Chauhan. Please occupy the front seats, sir. And the first talk will be on difficult cannulation of IVC and hepatic veins.
Talking on difficult hepatic vein and IVC recanalization, little tips and tricks. Mainly I'll be talking on cannula assisted. I will not talk on basics or percutaneous approach. So I'll be giving a small introduction on BCS because all these cases are BCS. I'll be mainly describing the technique facilitating the recanalization of hepatic veins and IVC. What is the importance of ultrasound on these cases? I'll show some cases and I'll conclude with some take-home messages. So BCS is basically an obstruction of hepatic venous outflow anyways from liver to heart. Basically it starts with thrombosis of the hepatic vein or IVC. Later it goes into partial recanalization, formation of fibrosis, and then segmental occlusion or stenosis. So it might be either IVC occlusion isolated, or it might be an isolated hepatic venous occlusion, or it can be both hepatic vein and IVC. So Indian population are going towards this hepatic vein and IVC combination. So most commonly we try to restore the physiology in these cases just to do a plasty or stenting of the hepatic vein or the IVC which is occluded. If the physiological restoration doesn't work, or if the veins are very, very small, then we go to physiological modification where we do some tips or dips creation. So I'll be talking mainly on this cannula assisted technique, how we cannulate this occluded hepatic veins or IVC. So it's already published from CMC Vellore and how to do this by using both fluoroscopy and ultrasound guided. So ideal candidate are the ones which is close to around 1 to 3 centimeters occlusion, segmental occlusions, because most of the time there will be a part of occlusion and some thrombus formation there. If it's close to this, more than this, we cannot attempt because chances of recanalization are very, very less. And these patients should be having normal bleeding parameters because we are very close to the cave-atrial junction. When there is abnormal bleeding parameters, there can be, if there is an injury to the pericardium, then it will be very, very challenging. And you have to have a good orientation of these IVCs and the hepatic veins on ultrasound before starting the case. Most of these cases are done under sedation. Some cases are done even under general anesthesia if the patients are very small kids. Usually take a right IJV access and place a 9F short sheath, and we cannulate the hepatic vein, IVC, using a glide wire and a catheter combination. After that, when the wire goes into the IVC, we take up a 9 French TGLB or TIPS cannula and go into the intrahepatic segment of IVC. You have to be very, very careful in this when placing this cannula, because you should not go beyond that. While pulling it back, you can tear the IVC if you are not in the intrahepatic segment. And make sure that the tip of the cannula is nicely curved. If the tip, usually the TIPS and TGLB cannula, it's like a vertebral glide type of shape. If you're keeping that, that will be nicely dangling in the IVC. It will not be hitting the wall of the IVC. So you have to nicely curve it such that it's like a cobra, such that it indents the wall of the IVC. Then only when you are close to the hepatic vein, easily it'll hit the ostium, and then you can manipulate your catheter and wire. If it's like a vertebral guide shape, usually it comes with it, it's not going to work. So one of the team should be available, readily available to show you on ultrasound. So once the cannula is near the ostium of this hepatic veins or IVC, we use a MPA catheter with a stiff glide wire combination. It's a stiff glide wire combination. We try to manipulate this, and once this crosses the stenosis or occlusion, we take up the catheter, and then we do a venogram, and then we do a plasty or stenting, whichever is required. So this is how we work in tandem with the colleagues. So the operator who's doing will be on the cranial end, and both the jugular as well as the abdomen, both are draped and clinched, such that we usually take an ultrasound guidance all the time, because we are close to the cavital junction, and when the cannula is sitting, we have to very, very be sure that we are below the cavital junction. Otherwise, inadvertently when you puncture, it can be devastating, and even we can lose the patient on table. So this is how we do. We clean both the jugular as well as the abdomen. And this ultrasound should be facing both towards the person who's doing the ultrasound and the person who's there at the jugular side. So here you can see my colleague is showing the patient on ultrasound, and and we are standing on the jugular side. So this is the one. You have to even orient the patient before doing this. You have to on ultrasound. You have to be very sure which clock position the hepatic vein ostium is, whether it is towards the 10 o'clock position, or it's a 2 o'clock position, or it's a 12 o'clock position. So accordingly, once the cannula goes in, you on the ultrasound you gently pull back the cannula. Always your cannula should be beyond the hepatic venous ostium, and gently you pull back with that C-shaped curve. So when it comes cranially, you have to know which angle the hepatic vein ostium is. So you gently rotate towards that angulation and make sure already the catheter and the wire is already inside the cannula, and then you start rotating the wire. So that is the TGLB cannula which we regularly use. So I'll be showing some cases. This is a young girl who came with complaints of pain abdomen for the past 8 to 9 months. It's a diagnosed case of BCS. Here you can see the right hepatic vein is already occluded. Middle and left hepatic vein has a common ostium. So left and middle hepatic vein has a common ostium here, and this is what I'm saying. So you have to always see this suprahepatic segment of IVC very nicely, and you have to know at which clock position. Here exactly it is almost near the 12 o'clock position or slightly towards the left. If the wire is going towards the left, it will be at 1 o'clock position. If it's going to the middle hepatic vein, it will slightly towards the right. Either it is at the 11 or 12. So once again, this is MR, and we always recanalize a vein which is at least more than 6 millimeters. Less than 6 millimeters, we don't usually do it, because the chances of patient recovering even after plasty or stenting is not going to be there. So just a small video. Once we are going in, this is then IVC venogram. So here also you can clearly see the suprahepatic segment of IVC. Once that is done, you make sure the cannula is beyond that pouch. You should never keep it just above the pouch. Suddenly when you're doing, there will be a kickback. If it's a kickback into the right atrium, then it will be devastating. So here you can, once again I'll play the video. So that's how. So, and there will be a gentle rotation. It's not be a push. If you're pushing, the cannula is going to kick back. It will be a gentle rotation. If it's not working, you change the wire from the floppy end, go to the stiff end of the wire. Just give a gentle angulation and gently rotationally. No ever pushing this way, because that it will going to kick back and it will come to the right atrium. Once the wire has gone in, you do a venogram and see. So already we are in the left hepatic vein. Anyways, it's a common ostium between the left and the middle. So here there is significant collaterals not draining much into the right atrium. So this is very important point. You have to gently push the cannula once on the stiff glide wire, on the stiff amplance wire. Already the amplance wire is gone. So you break that stenosis. So there will be a giveaway. Yes, it's just gone in. So that once it breaks, so the taking the balloon will be very easy. Otherwise, once again, there will be challenge there also. Because once the cannula goes in, you can get out the cannula and then take the balloon. Sometimes over the tip sheath, we usually take a 7F or a 6F long sheath as well as to make that coaxial such that the balloon goes easily. Otherwise, once there is a resistance, once again, you have to take the cannula back and give another more support there. So usually we take that cannula such that that stenosis is broken, you do some daughtering and then take the balloon over, if required, you put a coaxial sheath as well. So post-plastic, there is a good antegrade flow maintained there. So the pressures also has significantly decreased. Initially the right atrium was 5 and hepatic vein 30, so the difference is 25. Later it is just 6. So this is the pre-procedure and that's the post-procedure. You can see in the, there's an occlusion there, there's an occlusion, this is the wire. When we are manipulating, it's gone into the left hepatic vein. So always we take help of ultrasound. It's nicely opened up. Patient is doing well. All these patients of BCS is worked off for any prothrombotic state. This patient came up negative. Next is a 40 years old male, once again case of BCS. Here you can see nicely there's a short segment occlusion of the right hepatic vein ostium. Once again, this now if you're seeing which clock position, you have to already see that it's at a 10 o'clock position or 11 o'clock position, mostly at a 10 o'clock position. So, and this once again, how nicely we are able to see the suprahepatic segment of IVC, such that when you're putting the cannula, when you're pulling the cannula, it should not suddenly slip into the right atrium. You know where you are. So we have gone into the IVC, taken a venogram. So once again, you can see it is pointing towards the right side and it's way below the heart. This is very, very important. This can be done only under ultrasound. Once the ultrasound is done, then everything is under fluoro. Once the wire is gone, we do a venogram. There is no flow into the right atrium. There is no flow from the hepatic vein, lots of stasis, lots of collaterals. So once again, you can see a gentle push on the cannula. It has to go in. Once the cannula goes in, the daughtering is done. You take the balloon plasty it. This is the post-balloon plasty. Nice, all collaterals are gone. Even the pressures have significantly come down. So now I'll show some companion case. There will be some 5, 6 cases. Once again, see, you have to make sure that the right hepatic vein is gone. Now it's almost in the midline. So the cannula should be in the midline. So you can see after the cannula has gone, there's a long sheath. You can see clearly it's in the midline. So you have to basically see on ultrasound or in the CT where exactly the hepatic vein ostium is. So accordingly you manipulate. First the cannula has to go significantly down and you have to make sure your cannula is in intrahepatic. It should not be beyond the intrahepatic segment. When you're pulling, otherwise there will be a tear in the IVC. So once again it is the wire has gone into the left hepatic vein. So once again, very, very important. This is the suprahepatic pouch you see, such that you cannulate it. This patient underwent a plasty, didn't work, then we are centered. Patient is under good follow-up. So there's one more case. This is what is the importance of ultrasound, such that you know where this collateral is opening. It is just above the intrahepatic segment of IVC. Just below that is a free part of the IVC. If you go beyond this, then it's gone. So there will be a tear in IVC. So you have to know exactly where you are. So see how below the cannula is. But still you know that you are in the intrahepatic segment. We went in, we plasted significant collaterals, we plasted, then we stented this case. So not just the where we are, or this ultrasound helps us even to know which approach we chosen. Most of the cases I showed on the transjugular approach, but now in this case is a transfemoral approach because this collateral vein is opening below towards the IVC rather than opening into the rather than opening cranially, this is opening caudally. So we came from a TGLP cannula, the transfemoral approach. We plastered it just with the plastics, worked well. So I'll go with the IVC case. So this is what I was talking about. You can clearly see how the cannula is nicely wedging the anterior wall of the IVC. It should not be freely floating. If it's freely floating, then there is no way you can cannulate these hepatic veins. It should nicely wedge. This is the cannula which is nicely indenting the wall of the IVC. It is just baking there. So this, for IVC, it's very, very important. You have to know this suprahepatic pouch of IVC. Otherwise, it's not going to work because usually we recanalize most of the IVC from above only. Below, if there is a small lumen, we try to go in. But from below, most of the time, we don't do sharp recanalization. We do all from above itself. Because chances from below, there's a risk. We always come from above, make sure we are in the suprahepatic IVC, and then we do whatever we want. So this is what is importance of ultrasound. You can clearly see how nicely the wire has crossed from above, even if there is a short segment of occlusion. How many minutes more? We are done. So this one case I like to show. See, even we have used a back end of the stiff glide wire because we are very, very sure that we are way below the cave-vitral junction. So finally, so this line diagram I want to show, make sure you see this segment of IVC nicely, and this clock portion, and this is the angulation we usually give for the hepatic veins, and on IVC it will be a straight part of. So key is ultrasound guidance. Good visualization of the superiority IVC is very, very important. Plan an ultrasound, the view where we can get the IVC and hepatic vein ostium together. So keep the cannula in the intrahepatic segment, never ever go beyond that. So MP and stiff guide wire combination works well all the way. If that doesn't work, make sure you use a back end of the stiff guide wire. Angulate from the right atrium. Give the angulation in the right atrium, from the right atrium itself. Don't give a very acute curve. It's not going to work. You give a little bit like a C-shaped rather than giving very, very acute. Thank you.
Good afternoon, everyone. So I think we are running late. So anyway, I'll try to sum up as early as possible. So I'm Alok Mittal. I'm working in Muscat University Hospital. And today I will be talking about the venous embolization, particularly in erectile dysfunction. So how can we help these group of the special subset of the patient? So I have no disclosures. I have taken the written consent of all videos and pictures which I have taken. And the erectile dysfunction causes significant, profound impact on physiological and social well-being of a man. And it is defined as inability to attain and inability to maintain the penile erection. So there are two components in erectile dysfunction. So the first is the arteriogenic component, in which there is a difficulty in attaining the erection. So basically it is an inflow problem. So in this group of the cases, we have to revascularize or you have to do the angioplasty. Well, in the second subset, there is a problem in maintaining. So there is an outflow problem. So we have to do venous embolization. So this is what we are going to discuss today. And these two groups comprises of approximately 40% of the cases of ED. And if you look at the prevalence increases by age in arteriogenic, but in cases of venogenic, you see all age groups are involved. So now look at the global disease burden. In 2021, one study says approximately 50% men over 40 age are involved with ED. My gosh, so how big is the problem? So, so after that, 2024, another study also says 320 million ED patients are there, and most of these patients are our diabetic patients. So just to give a perspective of ED, like different disease processes like CVD, malignancy, trauma. So if you see the all disease, global disease pattern, so I think ED is underrated and under penetrated, or you can say underrated vascular entity. So what we have, so we have PDE5 inhibitor, which is easily available nowadays. But problem with this drug is that there is a efficacy problem, there is adverse effects are there, and eventually patient will become refractory to erectile dysfunction. So this is what we call potency pill. So how can we select the patient? How can we recruit these patients? So first of all, you have to give the chance to patient to read this questionnaire. It is easily available on internet. And basically it is a 15-question questionnaire. So out of these, question number 1 to 5 and 15, 6 question carries approximately 30 score. And it represents the erectile dysfunction domain, So out of these 30 marks, if patient gets 14 or less, then probably patient has underlying ED, erectile dysfunction. So these patients qualify for PDE5 inhibitor treatment. You treat them with a low dose. If patient do well, fine. If patient doesn't do well, then you have to increase the dose, okay? And you have to keep on increasing the dose with the maximum dose up to at least 6 months. If patient doesn't respond, then these are the group of the patient, then you have to do penile Doppler. So these group of patients is called refractory to PDE5 inhibitors. So this is our main basic criteria to recruit the patient. So this is some basic characteristic of penile Doppler. You can see there is a normal cavernosal artery Doppler here. This is the high resistive flow pattern. PSV is high, more than 30 centimeter, while in case of the arterial insufficiency, PSV remains low. But in case of the venogenic ED, you see the EDV and PSV is high always. So basically it is a continuous forward diastolic flow. So this is what we have, this is how we diagnose. So this is basically patient selection and imaging pathway looks like. So after ruling out the penile calcification, peroneal disease, etc., then you have to classify the patient arteriogenic or venogenic. In arteriogenic, probably you have to do CT angiography. In cases of venogenic, you might have to do conventional or CT cavernosography. So just to understand the penile venous anatomy, this is the superficial dorsal vein which runs under the skin, which drains into anterior abdominal wall veins or profunda femoris veins. I'll show you some cases. And then this is the major vein, deep dorsal vein, which runs under the tunica albuginea. Okay? And then it drains into the periprostatic venous plexuses, and later on they drain into external and internal pudendal veins. So this is like simple and easy anatomy. So classification has also been described for venous leak, but I don't think it is important. So as we have discussed that you might have to do the CT cavernosography, to confirm the patient which are, accessible, whether these are accessible for embolization or not. So this is my routine practice, this, how I do it. The patient is comfortably lying in the CT gantry, and after giving the papaverine injection, 60 milligram, I inject the diluted contrast, approximately 50 to 100 ml, under local anesthesia. And this is how you get the image. You can see there is a contrast leakage in common iliac, internal iliac, and later on you will see there is a contrast is leaking into external and internal pudendal veins. And you can see the cavernosa is nicely opacified with the contrast. And basically, and you can also make the 3D images nicely. You can see here, this is a deep dorsal vein, superficial dorsal vein, and these are the internal pudendal veins. So the same thing you can do under the fluoroscopy. It is called conventional cavernosography. This is the conventional cavernosography images. Here you can see there is a leakage into the external and internal pudendal vein. So external pudendal vein just run under the pubic rami, while internal runs over the pubic rami. This is how we can identify these veins. So how do we treat them? So I think there are 3 steps. So first of all, we'll see how to puncture the deep dorsal vein, because this is the main route here where we can do the embolization. After that, you have to do the protective coil embolization, and then finally glue embolization. So this is the deep dorsal vein access. Here you can see this is a Doppler image. You can see this is a deep dorsal vein, nice, thick, collapsible vein. You can easily access under ultrasound guidance. You can place a guide wire. You can use micro sheath or 5 French micro puncher set, and you can place the sheath over here, and you can do venogram. So this is the case, 62-year-old male. You can see there is external pudendal vein venous leakage, and these are draining into common femoral vein. So these are high flow venous systems, so I have to do coil embolization. So I went through the common femoral vein to the left common femoral vein. So I was lucky to cross from left side to right side. Okay, so then I put the coils, protective coil embolization on the both side, followed by venogram was taken. So venogram shows there is a venous contrast opacification in periprostatic vein and internal pudendal vein. So previously it was not seen, but now these are seen now. So after that, the glue was injected, and you can see the glue is nicely penetrating the venous nidus. So this venous periprostatic nidus should be well taken care of. So the learning point with this case is that protective coil embolization should be done for high flow draining veins only, not for the slow flow vein. And you should use 1:4 dilution glue, and venous nidus like here should be well taken care of. This is another case in 2022. We did, DDV vein access, and embolization was performed using STS foam that time. So it failed miserably, of course, and then this patient came back to us in last year, and then we did the conventional cavernosography. And conventional cavernosography shows there is a venous leakage. You can see most of it is on the right side. And then deep dorsal vein was accessed. Protective coil embolization was done, and then the last image you can see there is a post-embolization conventional cavernosography. There is no residual venous leakage. So recurrence rate and venous embolization is quite low. There is a recent study published in CVIR which says range is approximately 10% of the patient you may have recurrence. So this is another case. Here you can see there is a huge amount of venous leakage in the right, left, external and pudendal veins. All veins are significant. So we managed to do protective coil embolization for all 4 veins, and followed by glue embolization. So I have follow-up of this patient, 12-month follow-up. You can see the previous embolization IF score was 9, and then post-embolization it improved to 2022. So, and you see the very sharp, high resistive flow pattern. So how do I follow up these patients? So I follow up after 3 and 12 months with papaverine injection, penile Doppler. If it becomes normal, then I call it clinical success. And at the same time, you can also obtain IIF score. If it improves by 4, then This is also a parameter of clinical success. So this is a very interesting case. Here you can see this is a penile Doppler at 5 minutes, 10 minutes, 15 minutes, 20 minutes. None of the images shows that it is normal. And probably by looking at it, you may call it, this is arterial insufficiency or arteriogenic ED. But if you see look at the age of the patient, he's just 28 and he doesn't have any comorbidities. So, and this patient was giving me typical history of maintaining erection. So I was quite sure that this is probably having underlying venous leak. So I did the CT cavernosography. You can see there is a venous leak in the superficial and internal pudendal veins. So I access the deep dorsal vein, significant venous leakage is seen, protective coil embolization followed by glue embolization. So I remember this patient came back to urology OPD, and my urologist was calling me and then saying that, Alok, your patient is very happy and he wants to see you. I said, sir, let him go home. I'll call him some time later. So I called him back after 3 months and I did his penile Doppler. And you see here, IF score has improved from 13 to 24. So it was again a clinical success in a young male who just got married. And the learning point is here, the CT cavernosography could be a problem-solving tool. I'll just finish in 1 minute. So another case, again, you see there is a significant tortuous dilated vein here. So in this case, I changed my strategy and I just put the microcatheter through the deep dorsal vein and just put the coil. So by this thing, you can just reduce the number of coil and the time also. So instead of puncturing the common femoral vein, you can just directly go through. So this is basically single puncture technique. Last case, you see there is a significant venous leakage on the right side. After protective coil embolization, you see there is another vein has popped up. So basically it is a superficial dorsal vein. I punctured it under ultrasound item over the dorsum of the penis, and you see the deep dorsal vein is duplicated. So many of time you may see the duplication also. So I'll just show you the results. So this is the meta-analysis which shows very quite homogeneous invariable results, 22 to 100% success rate. But recent studies are showing the better results, 68% in this study. The recent study published last year only. So it is showing like 60% clinical success rate, and recurrence is 10%, and non-targeted embolization is less than 2%. So by which I conclude that we have to look for the patient who are PD5 non-responder. CT cavernosography could be a problem-solving tool. Venous embolization appears to be safe and effective, and clinical success rates are still variable but promising. So, but we need to have long-term follow-up for best outcomes. Thank you very, very much, and I would like to have your questions. Thank you.
Thank you, Aman sir. I think the questions will take after the session.
Next talk is on Abernathy malformations, a case series by Dr. Dheeraj Tiwari.
It will show up there. Hi. Good afternoon, everyone. So the other name for Abernathy, or like the commonly used name, is congenital portosystemic shunts. I'll be talking broadly about congenital portosystemic shunts. Also, we'll cover Abernathy in this. So basically, CPSS can be divided into intrahepatic and extrahepatic. So whenever we are seeing a connection between the portal vein and the systemic draining veins outside the extrahepatic, within the liver, then it's intrahepatic. So this was first described by John Abernathy in 1793, where he demonstrated extrahepatic malformation joining into systemic circulation that he labeled as Abernathy malformation. So the extrahepatic malformation, the Abernathy malformation can be divided into two parts. One is type 1, other is type 2. Type 2 is when we can see a hypoplastic portal vein, and type 1 is when we don't see the portal vein. And type 1 is again divided into two parts. If both the veins are joining, SMV and splenic vein are joining and then joining IVC, then it's type 1A, sorry, type 1B. And if they are joining separately IVC, then it is called as type 1A. So the clinical relevance is that if we don't see a portal vein, hypoplastic portal vein, then we should not be treating it. Then the patient straight away goes for transplant. If we see a hypoplastic vein, then only we should treat it. So this is like the classification of intrahepatic shunts. There are 5 types of shunts. If there is a communication with the portal vein, that is labeled as 1. If there is a communication with the segmental vein, then it is 2. If there is an aneurysmal dilatation between portal vein and IVC, then it is labeled as 3. If there are multiple communications, then type 4. And if we see a patent ductus venosus, it's type 5. So clinical presentation, the patient can be asymptomatic. They can present with hyperammonemia, nodular liver disease can be there. encephalopathy can be seen, or hepatopulmonary syndrome. So the clinical approach is to assess everything. Like we have to scan the patient from head to toe. We have to look for the liver. We have to look for the lungs. We have to look for the various parameters like encephalopathy and ammonia levels, and then we have to perform the occlusion test to check whether the portal pressure is rising beyond a certain level, and then only we should proceed for the treatment. So this is the pre-procedure planning. We have to determine the shunt anatomy. On CT scan, we have to carefully look where the vein is arising from, where it is joining, Doppler to assess the IVC flow and also the liver flow. This is shunt ratio. This is very important. This actually helps in planning whether we should treat or not. If the shunt ratio, that means the flow volume in the shunt vessel and flow volume in the portal vein, if it is more than 60% the ratio, then we should definitely be treating it. So balloon occlusion test, I'll be telling the details about the balloon occlusion in the subsequent slides. So that ascertains the feasibility of closure, optimum closure method, and requires number of closure stages, like whether we should be treating in 1 stage or 2 stages depending upon the pressures. So biopsy, yes, it should be performed to look for the fibrosis of the liver. If the liver is very much bad, then of course we have to occlude the shunt, because otherwise the portal vein will not be prepared for the transplant, and to rule out other causes of liver disease also. So shunt closure can be done by surgery and also by the endovascular means. 2-stage closure is considered when we are seeing a lot of pressure gradient. If the pressure gradient is more than 20 after balloon occlusion, then only we go for 2-stage procedure. Or if the portal pressure is more than 30 millimeter, then also we should go for a stage procedure. That means in the first stage we'll reduce the shunt, and the subsequent phase we'll close the shunt. The predictors of acute portal hypertension, that's absence or visualization of portal vein. We should not be doing it after the occlusion test. If we don't see the portal vein, then the shunt closure should not be done. And if the gradient is more than 20, as I told you, after the balloon occlusion, then also we should not be doing it straight away. We should do it in a staged manner. And if the pressure is more than 30 millimeters of mercury. So this is the suggested approaches. It shows that in most of the cases of Abernathy, whenever we see a portal vein present, then in most of the cases, the endovascular method can be applied. The role of surgery only comes into play when the shunt size is very small. The length of the shunt is not the size, the length of the shunt is very small, where placement of the devices may be a challenge. So I'll just show a few cases done in my center. This is a 23-year-old male with previous history of venoseptal VSD, post-surgical correction, and he presented with dyspnea. The patient was orthopnic. He was not able to sleep, couldn't walk for more than 10-15 meters. He was very breathless, and echocardiography showed elevated pulmonary arterial pressures. CT thorax shows abnormal shunt between the renal vein and the main portal vein with grossly enlarged pulmonary arteries, indicating severe pulmonary arterial hypertension. So the pulmonary arterial pressure was 42 on the cath, and diagnostic venogram was done from femoral and jugular accesses, and balloon occlusion was done by Tyshek balloon. Baseline pressure in SMV was 18, and after balloon occlusion it was 28. So it was a case in which we can go for one-time shunt occlusion. So you can see this is the communication between the IVC and the portal vein, and we can see there are tiny size of portal vein can be seen. So this is a balloon occlusion test. So after balloon occlusion, we can clearly demonstrate that there are hypoplastic portal veins. The shunt size was very big. Shunt size was about 18 mm. I tried with a plug. So maximum size plug available in India is just 24 millimeter. That was insufficient for that. So I chose a muscular VSD closure device of 30 millimeter, which had a disc of 24 and the waist of 24 and the discs of 30 millimeter. So that did the job, and follow-up Doppler shows significant improvement. 3 months later, the patient underwent surgery, correction of the correction of the pulmonary vein and the pulmonary arteries. This is the pre-op CT, which shows dilated pulmonary artery. You can see there is aneurysmal dilatation of the pulmonary artery. This is after Abernathy closure and surgical correction of the pulmonary artery. And this is our device. Now the patient can walk 5 kilometers in one go. So from walking 10 meters to 5 kilometers, that much of difference it can make. So coming to the second intrahepatic shunt, it's a 3-year-old child who presented with cyanosis. On clinical examination, clubbing was there, respiratory rate was 40, room air saturation was 82%, and echocardiography shows features of pulmonary arterial hypertension. So ultrasound was done. You can see the length of the shunt was very small on the Doppler. This is the portal side circulation. It is going into the IVC. This is the CT scan. This is the portal vein, portal side. I mean hepatic portal side. There were tiny portal veins in the liver lobe, and this is the IVC. So the length in between the IVC and the portal vein was just 8 millimeter was the diameter, and the length was 6 millimeter, although it was very small. So all our plugs, they have a size of about 8 to 9 millimeters. So placing a normal routine vascular plug would have been disastrous, because it will pout inside either the portal vein or maybe inside the IVC. So that may not be good. So I just discussed with our pediatric cardiology guys, and there is this device which is called as Konar MFO. It is developed by an Indian cardiologist. His name is Nageshwar Konati, Dr. Nageshwar Reddy Konati. He is in Hyderabad. So what change he has made is, this is a regular PDA closure device. He has attached one additional disc on the other side, and he has devised this plug. This plug is named after him only, Konar MFO. This is Konar multifunctional occluder plug. So this is a very soft plug. The biggest advantage of this plug is that this can be attached to the cable on both the sides. Like if you want to push this disc first, or if you want to push the disc with the tapered end first, you can always choose this size. So this is a wonderful device and very soft. So we decided that we'll go with this. The length of this plug is just 4 millimeter. You can see there are various diameters given in this. So this waist is about 4 millimeters. So it suited our defect. So this is how we did. So I took one IJV access and femoral access, went inside the SMV, took the run. You can see the length of the length of the defect is very small. It was 6-7 millimeter only. So then place the Tyshek balloon and check the pressure. We can see the portal veins filling in after placing the Tyshek balloon. So that again suggested, reconfirmed our finding that portal veins are hypoplastic but patent. So went for deployment of the plug. I took this PDS style plug first and the disc on this side, because I wanted that to stay a little bit. It shouldn't pout out into the IVC. So that's why I wanted to deploy it like this. And this was deployed, and this is immediately on the table finding. So I could clearly see the portal vein visualization on table. I have this child with me, now it's more than 1 year, and this child is doing really well. His growth has started increasing. The child is showing growing, and the saturation in the room air has improved to 96%. This is another case where, like a 4-year-old child, I'm just skipping these clinical details because we are running out of the time. So this was the simplest Abernathy case or portosystemic shunt case. There's a simple vein which is draining into the IVC, and it is ultimately joining the portal vein. So this was a straightforward case, no big thing, just placed a regular vascular plug and occluded it. So here, rather than taking a balloon occlusion, I just took a modified occlusion test. Rather than inflating the balloon, I just deployed the plug and did not release it. I kept it there and I just waited for the pressure to rise, and then just check the pressures. So the pressure rose to 20 millimeter from 14. So both the limits were like within the range, just a 6 millimeter gradient. So decided to go for the plug. So this is plug deployment. I deployed the plug. After that, you can see the portal veins are filling nicely. This is the immediate post-procedure results. We can see the portal vein are showing nicely. So this is our vascular plug, and this is filling of the portal vein. This is just a series. Again, Dr. Nageshwar Rao Konati, he has published this series. There they have done almost 22 cases, and that has shown that saturation in all the patient has increased after placement of the Abernathy plug to almost more than 90%. And most of his cases showed a high clinical success, and there was just one mortality seen. This is another technique in the graded occlusion. I was saying that in certain patients, when the gradient is very high, you cannot go for a single stage closure of the Abernathy malformation. In those cases, what we do is we just put a wire across the closure device, and then over the wire we put serial dilatation we do, so that we make a hole inside the plug. So that allows little bit of blood flow, so that the device is not closing the shunt abruptly, then that doesn't lead to acute portal hypertension. So that's how it can be avoided, but I have not done any graded occlusion so far. There is a case in pipeline that might happen maybe in the coming month, then we may try this thing. So this has been taken from one of the journals.
So conclusion, image-guided percutaneous closure of the CPSS is safe, effective and less invasive. Careful patient selection, detailed imaging should be done, and interventional radiology should be integrated in the multidisciplinary management of the CPSS with advent of newer devices. Can trust most of the shunts can treat most of the shunts endovascularly. Thank you.
Thank you. Thank you, Dr. Dheeraj. We'll
Thank you,
again
sir.
take the
I know we are all hungry,
other
but
questions.
one more
Yeah.
session from Dr. Keith Pereira.
Sure.
It's on single session mechanical thrombus removal for DVT, evidence and real world experience. Over to you, sir. Thank you.
Thank you very much. I'm going to go through this very quickly because I know we're going into our lunchtime. So I'm going to present on evidence and real-world experience. So, I won't get into too much details, but why treat DVTs? Because we want to prevent post-thrombotic syndrome. We all know that. What you need to know is that the incidence of post-thrombotic syndrome is up to 50%. So that is important for you to know so that you can talk to your physicians and talk to your referring colleagues about why you need to treat these patients. The major bulk of this population is not treated because there's no awareness of post-thrombotic syndrome, right? So it's important to know these things. Why treat DVT is because we all know this. There's something called open vein hypothesis. I won't get into this, but if you see that graph on this side, the residual thrombus, as the residual thrombus increases, the Villalta score increases, right? So basically what we're trying to say is that if there's thrombus left behind, then PTS is going to develop and PTS is going to cause problems in the future. So clinical success really depends on improving vessel patency and reducing venous hypertension. So again, what do we have so far? I'm going to go to thrombectomy, but what do we have so far is heparin and TPA, right? These are two main things that we're currently using. Are they enough? Anticoagulation as standard of care, more than 50% still developed residual venous obstruction. And we know that residual venous obstruction leads to PTS, right? So this is not enough. What about TPA, right? We have major trials, and I won't go into details about these trials, but they're very conflicting, right? The KEVIN trial showed that it improves PTS, right? The KEVA trial said it does not improve PTS, right? And we won't get into details about this, but what we really need to know is the ATTRACT trial, right? The ATTRACT trial was sort of a big blow to all our attempts at doing DVT procedures, and even our referring physicians started saying, is this even needed for our patients? Because what you saw there was the post-thrombotic syndrome with TPA and without TPA remained the same. Now, in further studies, they found that iliofemoral DVT needs interventions versus not, but still, in the eyes of someone who is referring patients to us, it became an issue, right? Because they started saying, does this even need treatment or not? But you have to look into what was the negatives of this trial is they didn't look about the nature of the clot, right? Was this acute, chronic? We use only TPA. TPA works only in acute clot. What happens to the chronic clot? And also a lot of devices that were used at that time, and this was published in 2018, are not relevant now, right? We have a lot of other things that are going on, a lot of newer devices that are available. But again, this affects us because a lot of society positional guidelines still state, like for example, our referring physicians are all chest physicians and hematologists and stuff like that. And in their guidelines, AC is good enough, right? And even in SIR guidelines, they suggest against non-lytic mechanical thrombectomy. So there's actually a lot of things saying that you should not do anything beyond TPA and heparin. But we know that this is not good enough, right? It has not helped us with trials. So we're sort of challenging the status quo right now with new evidence and clinical outcomes. And this is what we have so far. The BOLD study, which is a comparison of the Penumbra thrombectomy device and anticoagulation, is still under review right now. Patients have been enrolled, but results are not declared yet. But what we do have right now is the CLOUT registry, which is the INARI registry, which is looking at the largest mechanical thrombectomy study in the field of DVT, right? And it's big because we have now about 285 patients which have completed the study, which is a big number. And I won't get into details about CLOUT, but this is what the highlights are. One is there was 91.2% removal or near complete removal of clot, which is a big advantage from what we knew in the past, right? We thought we were taking out clot, but we're not taking enough. Almost 50% of clot was still left behind. Now we're looking at 91%. What about PTS? What really matters to our referring clinicians? What do they see in their legs? And this is a complex graph, but I'll tell you, this is the number what you're looking at. There's 81% freedom from PTS and 94% freedom from moderate to severe PTS. So now we're looking from 48%, we've improved to almost 94% improvement of PTS, right? That's a big, big movement in this field of interventional radiology and the move in the field of removal of this clot. How does this compare to what is there? So now if you look at ATTRACT and look at KEVA, which you spoke about, you see that the PTS was moderate to severe PTS was 24%, and now we're looking at moderate to severe. This is not just all PTS, this is moderate to severe PTS, which really matters, is now down to 6.5%. So now we have really made huge strides in the field in respect to removal of this clot and improvement of these patients. But we need RCT evidence, right? This is what we need for guidelines to change. And until that happens, it's not going to happen. And so now we are enrolling in DEFAN study, which my institution is enrolling in. We just enrolled 2 patients 3 weeks ago. This is a randomized control trial, again, comparing mechanical thrombectomy with anticoagulation. We are looking at outcomes like treatment failure, therapy escalation. In fact, 2 of our last patients, one of them had to have therapy escalation from anticoagulation because they were not tolerating it well. There was still PTS in spite of that. And then PTS severity at 6 months. So this is where we are with the data. I think we should have these results in the next year or 2, and then we'll have much more evidence supporting the role of mechanical thrombectomy in our patients for DVT. What about real world? Again, I'm going to breeze across this very quickly. New tools, new advances. There are a lot of new devices. If you go to the booth section, you'll see a lot of new thrombectomy devices from Penumbra. There is Flash, there is Bolt. I think the Bolt just got approved in India about a few days ago. The guy from Penumbra just told me that it's a great technology for these things. They have 7 French sizes that actually you can insert into the posterior tibial vein and go up. There are 12 French devices that go up all the way into the common external iliac vein. So there's a lot of advances happening on that field from various device companies. And then Inari has a lot of more of mechanical / like the stent retrieval systems that we have in the brain. We have the ClotReaver, which is available in India. We have devices like Protrieve. I don't know if you guys have heard the Protrieve device, but that is a protection device which can be used in the IVC to prevent clot from migrating and getting a PE during the procedure. And then we have devices that save blood by the method of filtration, where you can take off clot, keep the clot, but put the blood back into the body. So a lot of new advances, a lot of other devices which are beyond the discussion in this particular presentation, which are there now in this space. I'll quickly go over how I do it, a single session mechanical thrombectomy. So by single section, you're avoiding 2 sessions, right? You're avoiding putting TPA, bring the patient back the next day, ICU stay, and getting rid of the clot. So this is a quick case. I won't get in details about this. Left side, obviously the Villalta. Villalta is what we use standard for these evaluations. Anything above 9 is moderate. That's where we intervene. So you see the Villalta in this case is 14. Excess, I've almost gone wholly on to supine access for these things. The advantage of supine access is you can do a lot of other things, right? You can get femoral access, you can get neck access. When you put a patient prone, yes, it's easy to get into the popliteal vein, but now you don't have much options. What if the patient develops PE during the procedure, right? You cannot put a device from the popliteal vein anymore. So we do supine accesses for all these things now, become a standard in the last 5 years. And then ultrasound guidance only. I cannot stress the importance of this. You guys are interventional radiologists, you know the importance. You should not do blind punctures for these things. First do a venogram, then cross with various devices. I won't get in details about this in the interest of time. And then IVUS is something that is really become an important part of our practice. In the arterial system, we have been using it, but now in the venous system, there's almost no case that I don't do without IVUS, and it's for the purpose of clot, right? You want to know whether this can be done as an acute clot, as a chronic clot, what type of device do you want to use, all depends on what is seen on IVUS. Thrombectomy time, again, I won't get in details about this, there's a lot of intricacy about this, but the Penumbra catheter, it's usually without a wire, so there's always a chance you may lose wire access, so that's a negative, but it allows for good aspiration because you don't have wire, right? Good aspiration power. There's a lot of advances in the computer-assisted vacuum aspiration technology, Bolt technology. The Inari system, ClotReaver, is over the wire, its advantages. The ClotReaver, which is, I'll show you in the next few slides, has got this availability to pull clot out mechanically versus just suctioning it out. And then you do 4 passes at different angles and you manage to get a lot of clot out. So that's what thrombectomy is about. Then you identify the culprit lesion. So once you get rid of the clot, you see that there's some clot left, but there was, again, IVUS is very important, right? It shows that there is stenosis there. You correlate with CAT scan, you find that there's May-Thurner syndrome, it identifies that, and then you go and do a definitive treatment with balloons and then with stent placements, right? Always get contralateral access so that you avoid jailing the IVC with the stent, so you have good apposition with the stent on this side. Final evaluation, you do post-angioplasty and you get good flow into the IVC. So this is what we call single session mechanical thrombectomy, where you do everything in one session. I'll show you 1 or 2 cases. 36-year-old female with postpartum cesarean section with extensive DVT. She wanted to get to a baby. She didn't want to go to the ICU. She didn't want lysis. Extensive DVT. You see a clot going all the way into the IVC, into the almost suprahepatic IVC there. This is what the clot river looks like. You place it just beyond the clot. How many of you have used clot river yet? None of you have used. Okay. So basically, you place it beyond, and then you see that coring element that comes down. That is the thing that pulls the clot out. So this is the sort of advantage over just suction devices, where some of the chronic clot will not come out, that I showed in the previous slides. So you see that very clearly, right? So this is what we never used to see as interventional radiologists before. We are like surgeons now. We see the clot, we see the chronic element versus the acute element here. This would be very difficult for just lysis to get rid of. So this is the advantage that we're having with this type of clot systems. Flow restored, and again, no TPA, less bleeding risk, no ICU stay, and DC home the next day. And I'm not advocating for no TPA use. I'm just saying that there is a very valuable. I was talking to Paresh, my colleague from Goa, in the last few minutes. There is a lot of advantage to TPA, but there are a few cases that you need that coring element devices. The removal that is not beneficial. So even sometimes I do a single session. I may divide it into 2 sessions. I may do a TPA in the first session. If it doesn't really work well, then I go to a mechanical thrombectomy in the interest of cost and a lot of things which are relevant to our population in India, right? So these are things you have to keep in mind when you're doing these procedures. Another quick one. This was a pretty dramatic case. This is what we call phlegmasia. I did an emergent mechanical thrombectomy. This is what it looked like. This is really to show you that it's important for IRs to just not participate in thrombectomy, but also participate in their wound care. I did wound care for this patient in the wound care clinic, and got this patient back to having normal feet. You cannot depend on a referring physician to that, right? That's where vascular surgery takes over all these procedures, because we are plumbers and we send it back to them. But it's important to take care of this patient from A to Z, so that we can get them on their feet. And this is what referring physicians want to see us doing. And then they send us more and more cases because they see our good results. Last case, this is an interesting case. This is a patient with an ECMO and had clot in the IVC. And we were fearful that he was bedridden and there was more clot formation chances. So they called us for a thrombectomy. And this case would have been impossible just doing lysis, right? And I'll show you in the next few slides why. Because this clot would not come out with lysis, right? There's no chance. So you want to do thrombectomy for this. We went from the IJ. Because there was a lot of chance of displacing the clot going up while doing thrombectomy, we placed this device, which is like an umbrella-shaped device on the top, which is a temporary IVC filter placement. It's almost temporary, which can be opened up and closed very quickly. This is IVUS, which, if you see in the previous slide, you didn't see the clot on venogram, right? That's the advantage of IVUS. You see the clot very clearly there. We went in with a thrombectomy device through this other device, and we managed to suck out a lot of this clot and really got good results. This is the IVUS picture, very clean veins at the end of it. And in fact, we found a lot more clot than we predicted. If you see, there is infrahepatic IVC clot there also, or infrarenal clot there also. And this is what the clot looked like. This is the device that was used. And if you see this very clearly, all chronic clot, you would not be able to take out this clot with any TPA or any other devices. So there is a role of mechanical thrombectomy in this setting. Again, just to make, this is not the end of the story. I think it's the beginning of a very exciting chapter for venous interventions. I think in India, we are just at the beginning of all these major devices and interventions coming through, and I hope we can serve our patients well in the future. Thank you. I tried to cut it down short, but I hope I managed to send it.
Are you worried that it will, over a period of time, it will cause some issue in the opposite wall and subsequent occlusion?
It
Would
does.
you like to place it like this or two steps?
Yeah.
It's always
It's always tricky. It's always tricky. I think, now in Europe, they have the obliquus stent. I don't know if it's available in India. You have it. Sinus obliquus.
But that doesn't show any improvement, the data doesn't support that.
I see. I've not used it in the US because we don't have it available.
The difficulty with obliquus is that actually at the top end, where the oblique bit is, it's actually not as strong as it should be, and that's also where the lesion is.
I see.
So it's one of those where it looks pretty.
It looks
good.
pretty but doesn't
Yeah.
help. Interesting. Yeah, we always have a difficulty.
Is
You
it a
know.
long stand or you would like to place it like that?
So this was truthfully I should have placed 100 stent here.
Yeah, that's what I was
I put an 80 stent because I didn't have 100 on the table, and I had to get rid of this patient because there are a lot of patients available. But yeah, I don't think any stent should be less than 14 and less than 100 millimeters in length. Like you have to go with 100, 120, 150. You should not go with less than
So
that.
you like to place straight in IVC and then, or like just oblique, just?
Yeah, yeah. Once you put it too much into IVC, you can have other side stenosis. So you want to, the advantage of this stents is, you know, once you start putting the stent, you can actually pull it back. Once you hit that
So
Mathan.
without IVUS, it becomes really
Very
difficult to place it exactly at where.
Correct. Even with IVUS, it's not easy.
Even with IVUS, it's not.
I've had my stents displaced a little bit. Last time I tried to take out a stent from the heart because the vascular surgeon put it, it went up. But I think, you know, that's the best we have right now, right? There's not.
In the end, we're talking about a difference of a few millimeters.
Correct.
You're
It
actually,
is.
no matter what, right? Finally, when you start placing it, if it moves a little bit,
Correct.
you've lost that.
Correct. The trick is to you know, I sort of, you know, this one, I don't know if you can.
If we, in the run, if you see, the struts are actually hitting the condylar wall.
Correct, yeah. But you see how, I don't know if it shows very well, but basically, once you open up a little bit of the stent and then you pull back, and in fact, somebody holds back tension while you pull the whole system back. I mean, that's the best technique we have. We don't have any better, right? So that's the best way. Again, it's not perfect. I've had my stents that have displaced and stuff like that, but anyway, thank you.
Thank you.
With the permission from the chair, we are closing the session. We'll move ahead for the lunch. Thank you all. Thank you, sir.
So we can take one.
The Puneet sir will be starting off with popliteal trifurcation disease. It's a case-based discussion. Sir, please.
So, good afternoon, everybody. So, the topic which was given to me was popliteal trifurcation disease. It's a difficult topic for me because it's a difficult territory, as you all know, because you all are stalwarts in this field. So, I'll try to show some cases and some theory about it also. So, we have different concepts for BTK revascularization. So, we have angiosome-based revascularization. And as we all know that foot and ankle is divided into 6 angiosomes, and angiosome directed angioplasty or revascularization, it basically helps to increase the arterial supply to the wound so that the wound heals faster. But it may be technically challenging because the diseased artery might not be amenable to, you know, revascularization if that artery is supplying that particular angiosome. And there are multiple angiosomes which are involved in that particular wound, so you know, you have to target different arteries. Then easiest first strategy. So that's the strategy that I normally follow in my practice, where if you see a robust artery below the knee, you try to target that, you try to connect that with the main vessel and try to get inline flow to the foot. Then as many as possible. So when that strategy fails, then you try to target another artery, maybe in the next sitting, or maybe in one sitting only, you try to revascularize the maximum arteries below the knee, tibial arteries, so as to give a good perfusion to the foot and the wound. And as far as possible, so that's not in my scope of lecture, so basically involving the pedal arch and the metatarsal angioplasty. So what are the challenges? Since this trifurcation is located just below the knee joint, so prone to external forces, angioplasty can cause occlusion of the fellow artery due to plaque shift, or due to subintimal wire tracking and subintimal angioplasty, there can be occlusion of the fellow artery. Calcium load is another problem, and these vessels are prone to recoil. So next day you do your follow-up Dopplers, you see that everything has been blocked again. And long-term follow-ups are not very encouraging. So personally in my practice also, I see that maybe in a month or two, they come back again, that the wound is not healing as it should be. So I read this article. So for percutaneous coronary interventions, they have some strategies for bifurcated lesions. Okay, so I'll tell you. So they use this Medina classification where they use a binary system of disease. So in this diagram, as you can see, so we basically divide the main branch proximal, the main branch distal, and the side branch. So any lesion which is involving the main branch distal and the side branch, it's a two bifurcated lesion. Or so basically 111, 101, and 011. So this first one is the true bifurcated lesion. Then this third one and 011. This one, the fourth one. So basically, what they say is that in true bifurcated lesions, we should use two stent technology. And in other lesions, you can go ahead with one stent, and if possible, plus minus, you can stent the side branch. So for non-true bifurcated lesions, single stent plus balloon to side branch, stent across the main branch, and recross the struts and balloon dilate the side branch. Or we can also use a gel balloon technique, and it is best used for only when the disease is only in the main branch and there is a healthy side branch. So it's a simple technique, minimal metal in the side branch is there, so the results are quite good. And overall, if we compare both the strategies, the outcomes are similar if the lesion is non-true bifurcated lesion. So that's the diagrammatic representation of gel balloon technique. And if stenting, bailout stenting is required, then we have T-stent technique and T-end protrusion technique called TAP. So in T-stent technique, some part of the ostium of the side branch, it remains uncovered. So there are chances that that ostial disease will remain. But in T and protrusion, that is TAP technique, a millimeter of stent in the side branch protrudes into the main stent, main branch stent. So that will take care of the ostium of the side branch. Then we have kissing stent technique, as we are doing routinely in iliacs like CRAB and in normal kissing stents along the both iliacs, which creates a neocarina. So that's one problem. And there is some dead space which is left behind in the main branch that can cause some later on problems. It's a fast procedure, and it is best suited for wide bifurcation angle lesions. But that discrepancy of the diameter of the main branch and the distal main branch and side branch should be quite comparative. It's the discrepancy is large, then there can be problems of fitting the distal stents into the main stent. So that's the diagrammatic representation. Here we can see the two stents in a kissing fashion. That's the stent in the main popliteal artery, and you inflate it simultaneously, and you get kissing stents. Then we have culotte technique and crush technique. Personally, I am not using these techniques. So in a culotte technique, you put a wire, then put a stent in the side branch. You deploy a balloon-mounted stent. Then from the strut of the side branch stent, you go into the main branch. You deploy that. So basically, both the stents are now jailed. So you pass your wires again through the struts, expand, break the struts, and do the angioplasty in a kissing fashion. So basically, you get two stents in the main branch, which are enveloped, and then and the parts of the stent in the distal main branch and side branch. So basically, but the metal load becomes higher. So that is one problem. Or there is crush technique, where the stent in the side branch, a small part in the proximal, arterial segment, you crush that part of the stent from the balloon of the main branch, main branch balloon. So that one part of the stent gets crushed. So you cross the strut again, and balloon dilate. So the ostium part gets covered, which was not seen in the T technique. So that's the conceptual parallel or analogy of infrapopliteal with PCI. So that this slide I have shown. So I'll be going to a few cases. Kissing balloon BTK angioplasty. So this is a CT angiogram. This patient had undergone some percutaneous coronary intervention. As you can see, there was a pseudoaneurysm in the femoral artery. So this patient presented late. All these cases which I'm showing are CLTI patients, which are the true indication for BTK interventions. So this patient had severe rest pain, and so we managed the pseudoaneurysm by normal conventional routine techniques. So we had to tackle this trifurcation disease. This is occlusive trifurcation disease, where the TP trunk and the proximal part of the ATA is occluded. So so I took the distal anterior tibial access. That's my catheter, and I'm trying to cross the wire using a knuckle wire technique. I could go into the femoral, popliteal and femoral artery. That's my catheter. That's a 5-French catheter. So I took the angiogram from above. So I had another axis, crossover axis, to take the check runs. So that's the first frame, which shows the popliteal artery, that P2 and P3 segment are occluded. You can see that trifurcation is not formed, and a delayed frame, you can see the true lesion which was seen on CT angiogram. So I took PTA axis also. As you can see here, the two wires are going, that's the O14 wire, and I used two balloons, 3 millimeter balloon, two balloons in a kissing fashion, and I did angioplasty, simultaneous angioplasty. So that's the result. After angioplasty, we could at least get the morphology of the trifurcation. So there was some dissection flaps, so we did low pressure balloon angioplasty, and we got a good lumen later on. So that's the 2 months follow-up of this patient. So we can see that a good spectral waveform is there. Second case, retrograde PTA axis and single vessel BTK angioplasty. So in this patient, as you can see on the left side, the trifurcation is not formed, the distal popliteal is occluded, and in fact, the proximal and mid part of the PTA and the peroneal artery is also occluded. So I took the PTA axis O14 with O14 wire and support catheter. I could pass my wire into the femoral artery, and I snared it from the femoral axis. I did my work from above, so that's the spasm that you are seeing. So I corrected this by NTG, then I did balloon angioplasty, and that's the result. That's a kind of TIMI1, TIMI2 type of flow, not a very good, robust forward flow. So I had to put a Supera stent across. Again, this patient had like Rutherford 6 category lesion, so something had to be done about him. So that's the angiogram, like initial angiogram from above. You can see that popliteal trifurcation is not formed, and there are collaterals. So I did angioplasty of the PTA, the distal one, and the proximal part. So that's the result after angioplasty. There is some perforation, which we corrected with low pressure balloon inflation, and that's the final angiogram. So the foot perfusion was good, as you can see here. Third case, antegrade single vessel peroneal artery angioplasty. So this was an interesting case. This patient had come, and the patient's family and the patient himself were very committed that they wanted to get treated. He had tried all sorts of things, like we had in fact did stem cell therapy when he arrived, because initial angiograms, it was a desert foot, nothing was there in the calf. So he had taken some consultation from other places also in Delhi. So they also advised him the same thing. So we did in a low cost, so we did stem cell, and after like 6 months, the wound healing was not that adequate, so we thought that we should try something. So that's the angiogram from above. You can see that nothing, a small collateral is there, tortuous collateral, no formed vessels are seen below the knee. That's the occlusion cap, proximal occlusion cap. I have a small video snippet, I'll show that. Sorry, video is not playing. So I tried to cross my wire here, and I could cross it into the distal peroneal artery. That's my support catheter. Distally, that was the perfusion at the level of ankle. I did angioplasty of the peroneal artery here with the 2.5 millimeter balloon, and with the 4 millimeter balloon in the popliteal. And that's the inline flow that I could achieve into the peroneal artery. And this is the peroneal artery, and that's the flow to the foot. So that was the status of the foot about 6 months back, and now he again came back to me for the follow-up. The wound has significantly healed, and the patient is able to sleep peacefully at night. So that was quite a relief to me. Last case. The videos are not playing. So that's the occlusive disease of the trifurcation. The only formed vessel is the anterior tibial artery. The PTA and the peroneal are not seen. So I crossed my wire, tried to cross my wire from the antegrade axis, but I could not. Basically, my intent was to go into the anterior tibial artery. So took the distal tibial axis, anterior tibial axis. That's my wire from the distal tibial access, and that's the 014 wire and the support catheter. So I could cross my wire, did my angioplasty for the distal femoral, the popliteal, the anterior tibial artery origin, and I had to put a supera stent also that is going beyond the joint line, and also bioabsorbable scaffold, drug-eluting scaffold for the AT origin, because the result was suboptimal for angioplasty. So that's the final result that I got after doing all these things, and that's the inline flow to the foot. So that's the initial angiogram, and that's the final angiogram. So having said that, these lesions are very difficult. I mean, when it involves trifurcation, you have to optimize your strategy, you have to optimize your access, and you have to have your hardware and bailout strategies also. And in below the knee, if you are able to help the patient in healing the wound, that is more than sufficient. I think that's the guideline. So I think you should aim for that. So that's all about it.
That transition phase, because I think invariably you might have an edge somewhere, because if you've done 2.53 mm and then in the popliteal artery you're doing 4.5, sometimes a little high pressure or a 5 mm balloon as well. So any comment on that?
I think I will use 2 separate balloons, if at all, then stent the popliteal. So not a single balloon, 2 balloons, yeah. Yeah.
You would use 4 and then you would have to use 2.5 or 3.
Yeah.
There's a transition zone where you have either then 3 only and then directly 4. So there's a space where it's undilated, entirely not expanded, you know.
So I would say that as on the angiogram, you would know where the anterior tibial or posterior tibial is starting. Up to that level, you take your smaller balloon, and above that, you take your 3.5, 4, whatever you want to take over there, you just take that. So that is how I look at it. If that answers your question. Do you have any other suggestion?
Yeah, no, I mean, especially, let's say the pop is 5 millimeter, and typically the ostia of the runoff vessels, or it's not going to jump directly to 2.5. There is, especially
Transition, yeah.
the first 5 millimeter up to a centimeter, it's going to be 3.5. Let's say you can put the 5 just at the ostium, low pressure inflation. Don't crank it up to nominal. Low pressure, it's still okay. And as sorry, I didn't catch your name, but
Vimal.
Yeah, as
Yeah.
I was suggesting, obviously you're going to have, where the transitions do the run, where the transition is. As long as you're careful in inflating just low pressure, 2 millimeter, 3 millimeter, you should be okay. Just at the ostium or past the ostium, you need to make a balloon.
And you've not put stents, as I saw it in all your cases. Were they stenting?
I have not used stent, like 2 stent technique I have not used in any of the cases. I am putting stents in below the knee. Like
Which stents are you using here? I mean,
so normal, like drug-eluting coronary stents.
coronary stents, yeah. So, and yeah, you have some.
You mentioned about stem cells, sort of like how's been your experience? I never
experienced it. I was probably one of the first few guys to do it. So we've done about 7 or 8 cases. What we've realized is that it has helped in 5 of the 7 cases. 1 case we did not succeed, where I was anticipating because it has already hit the bone. So once the bone is affected, then we don't use it in them. And in 1 patient, we did not succeed. Obviously, we need to do many more cases like this. But yeah, desert foot cases, we are not getting so frequently. But if I get, I would definitely continue to use it. Sorry? Stem cells.
The other thing is, I think for rest pain, desert foot, early DVA is one consideration, but also your foot and ankle surgeons, I don't know if they do a tibial bone transport. This is a newer thing that they're doing where they take out a section of the tibial bone, and somehow that relieves compression on the neurovasculature there, and actually has shown to increase ischemic perfusion in chronic desert foot patients. So keep that in mind, because you don't want to put all these stents for a rest pain patient or fix a 30 centimeter tibial occlusion. It's going to go down. So think about the stem cell, the tibial bone transport, DVA early in those patients.
Yep. So stem cells definitely. My only other question was, how was your experience with drug-coated balloons or drug-eluting balloons, as they call it now? Are you using in these tibial territories?
Drug-eluting balloons?
Drug-eluting balloons.
Actually, sir, like I'm working in a government setup, so like the patients who are affording or who come under Ayushman scheme, so we are able to, you know, get those drug-eluting balloons, and we are using it. Like for FEMPOPs, we are now routinely using it. But when the patient is poor and like nothing is there, and we have the limited, you know, inventory in a cath lab, then we just go with POBA.
Yeah, so majority is POBA only. Do we have data as well to support that? Not really at the present moment, because when we used the paclitaxel ones, we were not happy. I was kind of coming out of it. Now the sirolimus has come in, which is supposed to be more promising. So I'm looking up to that. I've used in few patients, and so far I think it's 6-8 months or something that we have used it. It's done well so far. We'll have to see further, I would say. It's too early to say, but I'm looking up to all these options to get little longer patencies in these patients. So that's the whole idea.
So,
sorry? Yeah, so you have to realize it here. Again, we were comparing various techniques in stenting and balloon and whatever, coronary versus tibials. Yes, they are a small diameter, that is the only common factor. The flow dynamics are different. The plaque burden is so much, calcification is so much. We don't see these 2 millimeters or 5 millimeter lesions. Within the coronary, you get 1 centimeter, 1.5 centimeter. We are getting 20, 30 centimeter disease. So our whole purpose is different, and then it is a limb. The perfusion is not as rapid as you have it in coronary. So all that comes into play. And therefore, diameter comparison, but otherwise I think it's a whole different morphology and flow dynamics.
So
there are
instances where that anybody from the house, are you using, you know, that all these techniques, two-stent strategy that the cardiologists are doing? So
yes,
if anybody...
Yes, yes.
Okay. Sometimes even to cannulate the ostium, we are inflating balloon in the side branch so that we can get across the ostial occlusion. That's also a useful technique.
Great. So thank you very much. It was a great presentation and good, I think, discussions that we are having. So continue with that. I think it's post-lunch. So
thank you, Dr. Puneet, sir. We'll continue with the pedal arch reconstruction by Dr. Taek Young.
Once again for the kind invitation. Really fantastic meeting. Really enjoyed the session. It's actually quite unusual in Asia, but in India, I guess it's different. I see so far a lot of audience participation for the discussion. Okay, today I've been tasked to talk about pedal arch reconstruction. 2 questions: is it essential or desirable, and about the technique? So just to get a few things out of the way, I think pedal arch reconstruction we are talking about for CLTI patients, and in fact, to be more specific, those with wounds. I think claudicants and rest pain, we shouldn't be touching the pedal arch because there are consequences that could be adverse. So as to whether it's essential or desirable, I think we need to first understand what the pedal arch anatomy is. By definition, the pedal arch is formed by the dorsalis pedis and then the lateral plantar artery, and they meet somewhere in the first metatarsal space. So the dorsalis is on top and the lateral plantar from below, they meet. So if the 2 arteries are patent, the arch is considered to be complete, and if only one of these vessels are patent, it is incomplete or partial, and if both are absent, then it is absent. So the other consideration is what are the desired endpoints of revascularization to effect wound healing and prevent major amputation. So we'll explore some data on that. And obviously with any procedure we do, the risk-benefit ratio should favor the benefits. And if the risk is too high, perhaps it should not be considered. So there has been few paradigm shifts in terms of what we consider adequate revascularization. So from the surgical literature, bypass, the surgeons will tell you, single straight line flow to the foot is good enough for limb salvage. But we all know this is not true. Then somewhere along the line, people are saying we should be creating direct flow to the dorsalis pedis or plantar artery, not the peroneal artery. And then there are also advocates of opening as many lines of flow into the foot as possible. And then about 10, 15 years ago, the angiosome concept came, and the paradigm then was we have to establish a straight line flow to the wound, the wound in the affected angiosome. And these are the famous pictures of the era. And more recently, we are talking about woundosome or angiographosome, essentially because it is not always possible to do angiosome-directed angioplasty. And as long as we can establish flow to the wound, the theory is that it should heal. So this is an example, a fourth toe wound. The angiosome is actually the lateral plantar artery, but in this case, the dorsalis pedis is an excellent wound blush. I think there is no need to waste time or risk reconstructing the lateral plantar artery. So back to angiosome-directed angioplasty, the evidence base actually is not strong. There hasn't been any randomized study. Most are case series. And in fact, there are studies who say that it is of no benefit. So a patient like this with no arch is actually very difficult to do angiosome-directed angioplasty as recent as 5 years ago. Nobody would try to reopen the occluded below the ankle vessel, so to speak. It's not always possible. In our own experience, only about half the time is possible. And often bigger wounds straddle two angiosomes. So if once it's straddle more than two, effectively you have to reconstruct the whole pedal arch. As I mentioned earlier, the aim currently, the concept is to restore flow to the wound. And also there's more to wound healing than just revascularization. Not infrequently, a successful angiographic procedure does not translate to wound healing because of infection that needed amputation. So about 5 years ago, we published our experience, more than 3,000 angioplasty in JVIR. And from that data set, we did a subgroup analysis. So we look at the number of tibial drum runoff with respect to limb salvage. And it was quite clear that we need at least one vessel runoff. So if you have a 0 vessel runoff, the limb salvage is dismal. We then look at the angiosome-directed angioplasty, and in our experience, it did make a difference in limb salvage. And then we look at the plantar arch integrity. And a complete plantar arch did better than a partial arch, which did even better than absent arch. I have to qualify that the plantar arch integrity is on the diagnostic angio, so it's not that we reconstructed the arch. So I guess it's more a reflection of the severity of the disease. So a complete arch, probably less severe disease, and hence better limb salvage. So the question is whether in the absent arch, when you reconstruct it, does it improve the limb salvage? So the other thing we look at is for patients with complete arch. We found that whether you do angiosome-directed or indirect plasty, it seems to be not so important. So the arch serves as like a distributor of the flow. So it doesn't matter whether it's direct or indirect. However, if you look at those with partial arch or absent arch, it was critical that you do angiosome-directed angioplasty. So these have guided more or less our approach for quite a number of years. So from our data, just to summarize, at least one vessel runoff is required for limb salvage. Recanalizing more doesn't seem to add significantly to limb salvage. The plantar arch is a strong predictor of limb salvage. So for patients with complete plantar arch, probably do not need to be so aggressive in the revascularization. Whereas if the arch is absent or partial, it's crucial that you get enough flow to the wound through direct angiosomal angioplasty. And if that fails, it may be a better strategy to try to reconstruct the arch rather than trying to open up more tibial vessels. So this is a publication in KJR, a similar kind of study with ours. Basically, they looked at the completion angios and divided them into complete, partial, and absent arches. And those with absent arches, the limb salvage is not as good. Again, this is based on completion angio, not pedal arch reconstruction. This is the only paper I could find on pedal arch reconstruction. So they intentionally reconstructed the pedal arch if it's partial or complete. But having said that, they were only successful in 25% of the time to reconstruct a complete arch. So most of the time it's a partial arch, and not insignificant, about a third of them, they are not able to reconstruct the arch at all. And based on that categorization of patient, it was clear that the more complete the arch, the better the wound healing, and also the better the limb salvage. And from the limb salvage data, it is interesting to see that the complete arch and the partial arch are fairly similar. So perhaps a complete arch is not really absolutely necessary for limb salvage. So back to the question, is it essential or desirable? I think we need at least a partial arch, because lucky or not, the arch is like a blood distribution system. You need to have a bit of it. If it's not there, there is just no blood to the foot. So I think it's essential to have at least a partial arch. I don't think we always need to reconstruct a complete arch if we are able to establish flow directly to the wound. Just in this case, wound in the wound blush area, this is already quite nice. So there's no need to stress over reconstructing the posterior tibial and the lateral plantar. However, if we are not able to do direct angioplasty, in this case a heel wound, we were not able to reconstruct the posterior tibial. So we reconstruct the arch completely so that there is a retrograde flow, so to speak, to the heel area. Next, moving on to the technique, I think the critical thing is we have to be familiar with the pedal arch anatomy. As I mentioned earlier, it's basically a continuation of the dorsalis pedis through the first metatarsal space and then through the connecting to the lateral plantar artery. However, there are a lot of variation in anatomy. So we need to be familiar with those. And one of the reasons is because, especially in totally occluded vessel, basically you're surfing blind, right? You're trying to find the path. So if you're not familiar with the roadmap, it is very difficult. We always come downhill. We like to use a long sheath all the way to the popliteal artery to save contrast and get better pictures. I think it's mandatory to use the 014 platform. The 018, I think, is too rough. You tend to injure the vessel. These are my go-to wires. The coronary wire, for period, I'm using Sion Blue, but now they have a dedicated wire called the Gladius. Both are from the Asahi brand. We need some form of support. Personally, I like to use a low-profile balloon so that, if necessary, I can inflate the balloon along the way to help advance the wire. Mandatory to have an AP foot projection in addition to a lateral foot to figure out a way. Stay intraluminal as far as possible, and oftentimes we need quite a lot of GTN because of spasm and all that. So this is a publication by Manzi more than 10 years ago, and still very relevant. Inside there, you detail all the detailed anatomy of the foot, including variants. So I think those of you interested to do this procedure should at least read this article. This I already mentioned before. So just one or two examples. So fairly typical patients, usually very bad BTK disease, and you look at the foot. In this case, I would categorize this as an absent arch. The dorsalis pedis distally is occluded. The lateral plantar is hardly visible. So typically, we need good angiogram. This is a selective injection from the dorsalis pedis in the lateral and AP projection. I hope this projects well. Oh dear. Yeah, I hope you all can see it's a bit dark. So basically, this is a Gladius wire supported by a Amara XT balloon. So you could see that we have to, based on where we think the lateral plantar is, we have to move the wire back and forth. It could go into branches. So this take a bit of getting used to. But I have to say that the wire technology now enable us to do this sort of thing. Okay, so basically from a picture like this, oftentimes once we cross, I don't like to push the wire all the way up to exteriorize. I would use this as basically a reference so that I could come from above to re-enter. And so in this case, I use another gladius wire from the posterior tibial to re-enter, and then confirm that I'm intraluminal, and then do the usual balloon, and you can get a nice picture like this. And you could see now the wound blush in the left, third, and fifth toe. Sorry, I didn't have the AP view to show it better. This is another case, heel gangrene. So based on angiosomal directed angioplasty, we should be opening up the posterior tibial and the common plantar. But oftentimes, we need the plantar arch, not so much to reconstruct it, but use it to help us to recanalize, the bidirectional crossing. So this is a more selective injection. Already we have wound blast, but obviously not good enough to heal. That's why we are doing this. Again, it's a bit dark. So we came from the top, we couldn't cross. The bunch of clips over there is due to the skin graft that they tried to slap on, but it's still not healing well. So essentially, you just have to probe from the top, from below, sometimes a bit of angioplasty to create a channel, and hopefully one of the wire will break through like this. And then again, as usual, I do not like to push all the wire up to the femoral. I'll rather bring my catheter down, capture the wire, and inside my forefrange, I will have the CXI inside to make sure my wire go into the CXI, and then I drive the CXI down from the above. Because exteriorizing all the way to the femoral will injure the plantar loop. It's a lot of force and friction. So re-enter and the usual balloon. And the completion, you could see the wound blush is a lot better. So this is the so-called direct angiosomal reconstruction. As I mentioned earlier, there is some risk for this because of spasm, dissection, and stripping of branches from subintimal angioplasty. So in this particular example, it's a heel wound. We managed to reconstruct the arch, but you look, all the collaterals have been stripped off. So in this particular patient, the wound actually worsened despite a successful pedal arch reconstruction. This is another case, essentially a desert foot. Managed to reconstruct the arch. This picture was taken with an injection in the dorsalis pedis, so it looks quite nice, but if you inject from the groin, it's not going anywhere because we have stripped off all the outflow. So in conclusion, pedal arch reconstruction is for selected patients only due to the potential risk that we could worsen things. The main consideration is to establish adequate flow to the wound area. Complete pedal arch reconstruction is desirable if you only have one single vessel runoff and you are not able to establish a direct endosomal revascularization, and meticulous technique and patience is needed for a good outcome. Thank you very much for your attention.
We manage the wire, which wire, and how difficult often it is. So anybody wants to ask question?
Yeah, I think personally for all this wire escalation, in my mind, it's a lot of hype. For myself, I only stick with 1 or 2 wires. If those doesn't work, normally I would stop. So for the below the ankle, my first wire I go to is the Command ES. It's a 014 wire. And if I need to cross occluded loop like that case I show, I would switch to the Gladius wire. For some reason, it is a very nice wire that sticks and it keeps intraluminal. So as soon as the wire start to deform, and you don't let it form a loop and then you will dissect. You just have to move back and try it again. And a lot of times, of course, that video was accelerated, but more often than not, it's not always possible, but more often than not, I'm able to find my way to the opposite side. And once I reach the opposite side, I do not like to push all the way up. I would then try to come from the top and recapture the wire and complete. Because the pushing, it really injured the arch a lot. Yeah. So there are very few wires. I personally don't use the CTO wires below. I think it's too aggressive. And if it doesn't cross, it also is a sign to me that the disease is very advanced. It may not be worthwhile reopening. Yeah.
I think from his talk, one thing you realize that he's insisting on an AP projection. I think that absolutely is a must for all the youngsters. When we earlier on did, even I did it, we just took the lateral view and we said that was enough. But again, that did not, actually showed the wound, and the whole area was not clarified. So that was one important learning that we got from here. His wiring technique, we highly appreciate the way you managed all these patients and did that. So 1.5 balloon is what your choice is in the...
Is the Amara XT, in my mind, is currently the lowest profile balloon we can get. So the pain with that balloon is that the balloon length is only about 1 cm. So, if you really need to inflate multiple times. But I like that because of the roll profile. And sometimes you can't push further because of the occlusion. You can do a gentle inflation to, and it's only 1.5. So you are basically creating a small space. So it doesn't really harm, too much harm. Yeah.
You have a question, please?
There are obviously a lot of procedures, and these people have rest pain, and it becomes worse when you have the balloons environment. So how do you do them under general anesthetic, or
Yeah.
keep the pain under control?
I think most patients, if they are cooperative, we can get away with local with some sedation. Those who are not cooperative, is counterproductive. We will not waste too much time and arrange for a general anesthesia session. It really makes quite a lot of difference. Yeah.
We've started using femoral and sciatic nerve blocks. That is anyway, I don't have experience in arch reconstruction, but for long procedures, we tend to use the sciatic and femoral nerve blocks.
Yeah, I think that's a good point. Some of my colleagues are doing that routinely. Yeah.
Yeah, even the local blocks around the ankle, people are doing it. If you have a good, and I think now, I think Bhavish or somebody has presented somewhere that they're just doing under ultrasound guided and then blocking it. So that could, reduce the pain and movement and all that, which can make the procedure difficult and long. So, yeah.
That's great presentation. One thing I found in the pedal arch that you get difficulty in the support. Even coming antegrade, you sometimes don't have enough. So what I started doing is just a sheathless direct stick of the tibial coming down. You reduce your distance by just sticking, let's say, the AT or PT somewhere here, and bareback just a 018 support catheter, and you find so much more support. And you can still do your rendezvous and come around, but a lot of these pedal arches get very difficult with the small arcuate artery branches and all that, but just direct sticking it, putting an 018 support, you suddenly get so much more pushability than coming even antegrade. It's just another thing if you're struggling to find your pathway.
Okay. Yeah, Bob.
Do you give importance to the velocities, and then does that alter your plan of doing a pedal arch at all?
Sorry, velocity of what?
The distal dorsalis pedis or digital
I don't think we do that in our center. So we rely, or I rely a lot on the wound blush and that sort of thing. Yeah.
I think that brings us to the question which all of us should think. You have done your intervention. Will the wound heal or not? Various criteria, or how do you assess it? And I personally feel if the patient's pain has gone down and post-procedure patient is sleeping, you've done a good job. Yeah, and obviously your blush is an important thing that you do, or if you have your Doppler, handheld Doppler or something, I usually auscultate the digital branch close to the wound. Just try and hear what is happening in that territory, both lateral and medial to the toe. And these are some of the things that we do. And I think Bhavesh once described your machine has that perfusion mapping there. So some of these.
Fetal acceleration time.
So, yeah.
That's actually been validated more than the perfusion.
Yes.
I think fetal
Yeah.
acceleration time is something everyone, you can do it yourself, we're all ultrasound trained. That's actually been validated with wound healing at the moment. So it's a lot.
I was talking about that.
Yeah.
Yeah.
Right. Wonderful. Yeah.
Question slash comment, but as far as the indications are concerned, I mean, obviously if there's a wound, it's a no-brainer to go into the pedal loop. However, in patients with just breast pain, just personal experience, I know that your first slide said no for breast pain, but personal experience is that, I mean, I've done many patients with pedal loop reconstruction, even if it's not completely occluded, but just stenosis. These patients are typically diabetic patients and slash or older patients with significant rest pain, nighttime pain, cramping, they wake up every night or every other night, and their lifestyle is because of lack of sleep. In such patients, doing the pedal loop plasty, I mean, obviously you have to be really careful, seems to give significant relief to the rest pain and the typical, when you see the patient in the clinic 2 weeks post procedure, they've been sleeping much better.
Right.
And obviously the results, even if you follow out till say a year or so, in many patients it's a sustained relief with the rest pain. So
Maybe I will qualify that. So typically our patients, usually they do not only have pedal arch disease. Typically they would have below the knee or even FEMPOP. So the thing is that if we manage to reopen some of these severe stenosis, our approach is to wait and see first. Maybe that is good enough because we have already improved the pressure head. So for rest pain, in my practice, typically they would improve. And we always can come back if it doesn't improve, the rest pain persists. But it's uncommon in my practice for rest pain to...
Even I would be a little skeptical in doing that because one side is a success, the other side is complications, and you may actually end up patients with a wound or something like that in future. So technically, if you're really good, you may attempt that, but if there is any doubt, I would be little in rest pain patients. Yeah, maybe just tissue loss patients will probably be more encouraged to do such a thing. So I think we go ahead with the next. We can keep on discussing. These are topics which I think I can spend 2 nights here and 2 days with that. Yeah. So yeah.
Thank you, Dr. Tay, sir.
Yeah, please. That's wonderful.
Next up, we have Dr. Ganesh, who will speak to us on deep venous arterialization, customized for India.
Hi, afternoon, everyone. It's coming through. So I got no relevant conflict of interest in here, and I must admit, I have no first-hand experience in India when I'm talking about customized for India. So I'm gonna try and talk about, how we do it, and obviously I've had discussions in chats and tried to share my experience with whoever was attempting it in India, and I'm gonna, I have some idea of the limitations of equipments that we have in India. I'm just gonna try and, customize it to those limitations rather than anything else. So I'm gonna try and keep the first and the last bit quite brief and just gonna talk about technical because I think most of the people here are more interested in that. But we're gonna start off with patient selection first. And so who is it really for? Percutaneous deep venous arterialization. Now this is a study from 2006. And as you see, this is the pre-Dr. Madhusari, Dr. Fadi Saab, Dr. Ira, where they just thought that, okay, venous rearterialization in patients with CLTI is not it is for basically patients who don't have a bypass option in brief. And since then, obviously, we've had more data, and the terms like no option CLTI and desert foot have been coined. And this is more of an experience. This is from our center, or more from the UK, but I think we've been the biggest center in the UK basically doing this, the PROMISE UK study. But I'm gonna try and, I don't think sorry. So who is it really for? Obviously, we're talking about the CLTI patients. I'm gonna try and briefly mention what a desert foot is. Obviously, these patients have had attempts at revascularization previously, and they don't really have any venous conduits for a bypass, any which way there's no distal targets for them. So these are really what you would call as no option CLTI patients, and you can, divide them as per anatomical, clinical, or technical features. So what is no option CLTI? Obviously, there's no reconstructible pedal arch, and I'm not going to go into the SAD and the MAC bits here, but I'm pretty sure most of you are well aware of the concepts of small artery disease and what is the MAC score. But for very heavily calcified diseases, basically with no pedal bypass targets, when you have tibial occlusive diseases which are recalcitrant to treatment, and I think this is what someone just previously mentioned, why drugs don't work in BTK. I think the issue with BTK is not really that you're looking at longevity to begin with. I think the primary issue is initial recoil. So unless you prep the vessels, the drug's really not going to do much. So I think that's kind of like, I think that is being tackled at the moment, and we'll hopefully have more data once we have more devices to support that. So yeah, I mean, if there's a GSV, obviously we'll try and consider ultradistal bypass, but if not, then obviously we'll consider a deep venous arterialization. And then any patient with deterioration despite having straight line flow to the lateral plantar artery or the DP with the absence of infection, we would consider DVA. And I think rest pain, as Kumar has already mentioned, is kind of like, we're not saying no to those patients anymore. I think something very important that we need to consider is about patient fitness. And this is not just a procedure, it's a process, it's a long process. It can be quite painful for the patient. So when you're actually suggesting this particular step to any patient, I think we need to be mindful that the patient may have to go through multiple re-interventions. There'll be ongoing wound care. I mean, healing for these patients normally takes around 6 odd months, 4 to 6 months. So patients should be aware. It's not like you do the angioplasty and most of the other patients, you would, in a couple of weeks, you would already start seeing wound healing good amount. But in these patients, it's probably going to take much longer. You're going to need more, amputations and stuff. So you really need the patient to be on board. I think physical fitness, psychological fitness, whether the patient has social supports, all of these things do matter before you actually do decide to offer a deep venous arterialization for this patient. So this is basically from our data. So ATOMY is basically patient with CLTI with failed endovascular revascularization attempt. We'll assess the angiograms. We'll try and see if we can find any vein maps to have conduits. And then provided none of these are feasible options, basically, we'll then consider a DVA after discussing the things I mentioned previously with the patient. If the patient has active infection, or we'll offer some antimicrobial therapy, make sure that he's going in the right direction before we actually offer the DVA. And obviously the lifespan and all of the other things need to be considered for these patients before offering something which is gonna probably be quite bad for them for the coming 6 odd months. So I'm gonna go through the procedure, as I said, the technical aspects of the procedure step by step here. So this is really where we get our venous access. So this is pretty much our first step. What we do is we put a BP cuff around the calf area just to distend the veins. The vein mapping is done previously to assess that we have good veins around the lateral plantar veins are good enough in size and they're patent. And then this is kind of like almost at the base of the metatarsals where we really access the lateral plantar vein. And then we'll do a venogram just to understand the anatomy, just to pass the wire in the right vein. You can probably see some wires in there from the previous angioplasty attempt. So you can imagine that these patients have had extensive revascularization attempt before they made it to the table, basically, for a DVA. And then obviously you're doing the proximal angiograms to try and figure out where exactly you want to do the DVA. And then the last run on that the last image is basically angiograms from the venous side and the antegrade angiograms from the arterial side. And we'll just try and mark the point where we want to do the crossover based on all of these pictures. So there are certain devices that can be used. This is the LimFlow device. I don't know whether the angio is running. Is it running? No, it's the fluoro. Yeah, I think now you can see the needle moving. So this is the V-Seaver. And then you push the needle through. I'm just going to play it back again. Sorry. So the needle's coming through now. I'm sorry about the poor quality of the dark image. And then, as you can see, the wire's now gone into the V-Seaver there. So that's the standard lymph flow, that's how we do the crossover. However, I understand lymph flow is not available, so we do some over-the-shelf things. These are basically devices which are used for re-entry. The one on your left side is the Outback device, which we used multiple times for this now because lymph flow wasn't available in Europe for a while. So this is kind of like, you saw the needle and you saw the wire basically getting into the balloon. So the balloons come up from the venous side, the Outback is from the arterial side, and you puncture the balloon and you push the wire through, and the other device is B-Back. I thought B-Back is available in India, I'm not very sure, is it? No? Not yet? No, okay. And then this obviously is the third thing where, you know, you use the gun sight technique, and I'm just gonna quickly, I hope this plays, but I think this, so this is the needle that I had put in. You can see one snare and the other snare, this one's coming from the top, this one's from the bottom. You put the needle through and through, and you can see gradually the wire from the venous side is being accessed there. Then you can see the snare from the arterial side is being tightened around, and we're sure now that the wire's through both the snares. Once that's done, then you just, you know, pull the wire down the venous side, externalize it with a CXI, and then just pull it out from the arterial side as you would see in the last run, and that's kind of like how you would do it basically probably in India if we don't have re-entry devices here. Once you got through and through wire, one from the venous side, one from the groin incision, then this is what we would do. We would generally just balloon the crossover point. We would put a balloon, this is I think 5 mm sterling balloon all the way around. We'll try and see where the valves are, and then you would use a cutting balloon to try and open the valves up. I mean, the lymph flow does come with the valvulotome, but obviously that's not here. We use cutting balloons quite extensively as well. And then the last image is basically with the sterling at nominal pressure again, and now you can see that it's opening up nicely, meaning that the valve's been taken care of. So obviously we put the stents in, and then this is just the ballooning, crossover stent and stuff. So the other bit I just wanted to very quickly mention is we don't really do distal DVAs where I work, but I think distal DVAs are, you know, I think Kumar is here and he's done loads of these. And for distal DVAs, the main difference would be you won't need these stents. So I think it may be a bit more suitable for the Indian scenario. You may still use some stents on the venous side, but for the crossover, more often than not, you could get away by not putting a stent across. Important bit is about treating the valves, and we'll come to that. I'll probably show you a case why that's important. But you can see we still got the access from the foot side, and this is the cutting balloon that we placed. There is quite a tight valve in the midfoot as well. So there's one just around the ankle that you shouldn't forget. There's one around there that you shouldn't forget. And then there would be others that you would see on the balloon. And once that's done, basically hemostasis is important. So we'll pass the wire around all the way, as you can see on the loop. We'll plasty the lateral plantar vein, and then obviously external pressure. If you let it bleed, it can become a problem because veins can get compressed really easily. If you get a hematoma over there, the moment the procedure is done, everything's going to go down. So it's very important that you achieve good hemostasis with the balloon in the vein itself and some external pressure right away before you kind of like get the balloon down completely. And yeah, so this is how it will look at the end. So you saw the rapid flow in there, and that's the foot run basically. That's the DVA done to you. So I guess it's easy enough, sort of like should be very doable. I'm going to briefly talk about the re-interventions, mindful of the time that we have. And a couple of things which are important to know and to consider are, firstly, I'll talk about venoplasties and embolizations. And you can see this is a recent case that we have done. I don't know whether it's playing. And you can see that this is just post-procedure. There's not much flow going into the lateral plantar, and you can see there is extensive steal from the short saphenous vein. And this is despite the ballooning of the plantar arch and despite the valvulotomy and everything. So we weren't sure whether this was venous spasm. We obviously gave lots of GTN and stuff. Veins don't really respond as well, but we'll still try it. And we thought we'll leave it at that for the moment and see how it goes. Got the patient down after, almost a week's time, and you can see that this is the first one, just the picture. You can still see it's all being stolen by the short saphenous vein. There's not much flow going distally. And you can probably just see there's a tight valve in there. So use the cutting balloon again in that mid portion, coil the short saphenous vein, and sorry, is it coming? Oh yeah. So that's the that's how it looked at the start, and that should be the last after the cutting balloon and embolization of the short saphenous vein. So you can see we can focalize that, and that's very important as well. But we also need to be mindful of, I don't know, I think Kumar has a low threshold to embolize at the same sitting, is it?
No.
You don't? No. Okay, it's the same for us. So we let it flow, because if you don't have a good outflow to begin with, it tends to go down. So I think focalization or localization can be pushed back a little bit. So that's why interventions in this procedure are a bit on the higher side. But if you take off the outflow, the whole system may go down really quickly. So you just have to be mindful of that. The other bit is obviously these are long grafts. What I was talking about is basically a proximal DV, and because there's just so much of stent material and fabric in there, they tend to go down. And this is what you can see. Basically, this thing I think has gone down after a month and a half. So we managed to cross across. The foot venous arches does look, they do look to be okay. So, sorry, I'm not too sure what I'm seeing here. This looks like angiojet. And so we just did an angiojet for this thing. Did a post run. Is it playing? Yeah, it looks okay, but you can see there's something tight at the top there. So just put a Xience at the top just to cover the site up. Looked a lot better. Then this is the distal run. I'm sorry, it's playing a little slower than I was anticipating. It's slightly magged up. You can see that valve over there again. So we did use the cutting balloon. Sorry, I haven't got that image here. And then just did a coyote after that. And this looked like it's flowing back again much better. So these things are important. The other bits, obviously, that you need to be aware of are the immediate issues which these patients will have, which is mainly going to be with the pain. Now, there's going to be an arterial steal because you're diverting the flow into a low flow system or a low resistance system. So whatever blood was going into whatever remaining quite crappy arteries, to be honest, that's all going to be stolen away. Also, venous hypertension does tend to cause a lot of periosteal pain. And this is where these patients kind of like, whenever we do these procedures, just before the procedure, the patient has kind of like a perineural catheter and we start them on PCA pumps. We'll probably leave them on till a week's time and then take off and then just start them on analgesics and stuff. Other bits are about venous hypertension, and it's something that will settle, so it generally just needs reassurance. You obviously are fighting two things here, where if you put the foot up too much, there's already arterial steal, and you're probably going to make things worse that way. But with distal DVAs, I don't think venous hypertension is too big an issue now, and so we're not having to fight that as much. Amputation and wound care is very important, and I'll mention this, but this is like really a team sport. DVA is probably just one small step of the procedure, but the patient really needs extensive care for another 6 odd months before you really get him to where him or her to get to where you want them to be. So important bits to get your podiatrist or your foot surgeons on board. It needs to be a team basically thinking in the same way, acting together. Stage amputation, avoid sharp debridements, especially initially. Definitely amputation needs to wait for at least 6 to 8 weeks, I would say. Longer the better, but just around 6 to 8 weeks is when we would get good sort of maturation where there's enough blood flow and oxygenation going. Sorry, I'm just done here. And wound care wise, again, I'm not going to go into the details, but it's important basically that the wound's taken care of well. Just showing a couple of images. So this is kind of like one patient. This is how they normally progress. So that's a TMA. You can see there's good blood flow, and then this is over a period of time. I think this was closer to 7 months that the patient did get good flow. Also, how does the DVA really change things? And this is kind of like in the case that I would just like to share with you. So this patient had a DVA, I think, 2022, and his foot did manage to heal. You can see this is the starting post-DVA. You can see that arterialization, nice arterialization on the last one. This was around 3 months post-DVA, 2 to 3 months. And then 3 years later, he came back with some minor injury again. We did an angio. Obviously, the DVA was all gone by the time. But we did open up his ATA, and you can see beautifully there's still blush there. So there's those vessels which have arterialized which can now actually provide an outflow to the ATA. Otherwise, it would have been impossible for us to do anything with the ATA. As the AP projection, and you can see very nicely how the DVA arterialization looks. This is 3 years post sort of like the initial DVA. And you can see the ATA is running really well, and there's an outflow. It's not staying stagnant. So it's magic basically. So as I said, DVA is a team sport. I mean, that's our team essentially. It's surgeons, IRs, podiatrists, sonographers, nurses, and everyone. And yeah, that's my details. If you need any help or want to discuss anything, just give me a call. So LimFlow, I think, is not available in India. Is it available in India now?
21,000 USD.
Yeah. So in UK, obviously, they provide it as as a package. So UK is slightly different. But having said that, I think we kind of because we were part of the trial and everything, it worked slightly differently for us. So we were part of the Promise UK trial. And yeah, the devices do cost a bit, but it is available in UK. It wouldn't make sense for me to use something else unless the device is not available. So it was off the European shelves for just around 15 odd months, and that's when we tried all the other techniques. But we would still try and stick to LimFlow just because it's built for purpose. It just makes things easier for us. For India, I would probably not worry. As I said, I mean, so most of the steps that I've gone through, procedure-wise, it will be the same thing. You would try and do a distal DVA if you can, because in Indian scenario, you want to try and save on the stent cost as much as you can. Also, when you have long stents, they tend to rethrombose. There's sort of the need for reintervention slightly higher. So if you can, I would do a distal DVA. That's one thing, and I would use the gun-side technique if you don't have the B back in here as yet.
I was going to ask about that. So for proximal DVA, you said that you could do without the stent.
No, for proximal, you definitely need the stent. For distal, you could do without the stents. We don't do distal DVA, so I think Kumar can probably answer that a bit better.
So is it similar to AVF creation?
So ellipsis is being used. I think his part of the trial is what he was mentioning.
Distal DVA, you can do double gun sight, distal tibial, and the reason it's better because you're avoiding all the venous valves. You're skipping all that, but you need a tibial artery that's open all the way to above the ankle. And then you can do balloon angioplasty or a coronary drug-eluting stent just for the anastomosis. And if you have to, you can use supera and things in the distal veins. The endo-AVF, ellipsis, that's part of a trial now that we're part of, where we're using that to create the anastomosis distally, so you don't have to put anything there. So I've done 2 patients so far. We'll see, I think you still need stents in the plantar veins, but the anastomosis, you don't need a stent. The problem with the distal DVA is we don't have stents that are covered, that are self-expanding, that small, so you need either this ellipsis fusion or you need to use a bare metal, something to keep it open if you don't have a fusion. That's the problem with distal DVA. So distal DVA is nice because you have less venous hypertension. It's just, you can do proximal distal with off-the-shelf any day. That's what we've done 80% before using LimFlow. You don't have to.
The final question is, this can't surrogate for lack of skill. I've seen, sorry, I don't know surgeons here, I've seen some surgeons doing it. I could say, I can open this. It's, you can't open it, but I can open it. But there's nothing for DVA. So this cannot be surrogate for lack of skill or poor skill.
There's definite kind of I think we defined which patients really need it. If you got a good plantar arch, if you got a distal target, I mean, obviously you should try and revascularize. DVA is being offered to patients who have, failed revascularization, and because we are one of the hubs, it's hub and spoke in UK, obviously. So because these patients would normally have at least one attempt elsewhere, then they'll have another attempt with us before we even, proceed to DVA. So I think it's kind of like a mute sort of I don't think it's because of lack of skill or anything.
Okay.
I'm just
No, no, I mean, I'm just saying, so how it should be is, or how our this thing is. The other thing, obviously, is if you don't really have an outflow, doesn't matter whatever you do, you're never gonna, I mean, even if you do a brilliant job, if you've got a DPA running, and I got lots of those images, but I don't have them here, where you got a good single line flow, you can see the vessel till the DPA, and you don't see nothing in the foot. And there's nothing much you can do, to be honest. You can try and do, and I might open up a metatarsal artery or digital artery as well at times. It'll go down because there's kind of like nowhere for it to go. So with the DVA, what you're really doing is you're replumbing the whole thing, and you're actually diverting it from the venous side. So it's mainly the arterioles, which is the issue. So you're going from the arteries to the venous side and then going back through that to the capillaries. So it's slightly different, but as the valves go away and everything, I think the pathophysiology is kind of like being taken care of, where, you know, it's really, really small artery disease, as we call it.
I think we'll have to cut it here.
Can I ask one question, I both to Ganesh and Kumar? With this proximal DVA, how often are you seeing the patients going into failure?
So that is what? Cardiac.
Yes, none.
So there's a Mexican study, and they showed a lot of patients going into cardiac failure because of the proximal DVA.
If you have severe heart failure, less than 20% EF, you have to worry. I did a couple studies where I had the cardiologist do a right heart cath at the time of DVA, and then after follow-up. If it was above 30%, we didn't see anybody go into symptomatic failure.
Yeah, I mean, we wouldn't be offering DVA for a patient who's really ill. As I said, this would have been excluded beforehand. So I think patient selection's where it comes in, but we haven't had any issues just because of the rigorous process.
I think we'll have to cut it here. Sorry for that, but yeah, the next talk is. Thank you, Ganesh. That was really nice and introducing a new thing for us.
And for our next talk, we have something from the surgeon's perspective. Basics of wound care and a view on revascularization.
Good evening, all of you. I'm really privileged to be part of this brilliant conference and this group of lovely ISVRs. I must confess that there are two warnings in this presentation. One is some of the slides might be too graphic. Second one is there is no angiography films in this. So whoever is already disappointed, you are free to leave this room. Okay, so this is the greetings from Aster Medcity, Cochin. All of you are, of course, you're on the other side. You will be seeing all the types of wounds. I'll just show some of the wounds which you people or we are commonly seeing in our department. But always remember, of course, that no wound heals without adequate blood flow. And early wound care referral, it improves outcomes. It has been shown in many studies. And there are many other beware issues where you need to be developing your, pulling up your socks to decide on how you have to deal with these patients. And of course, one of the beware categories is non-healing despite a good angiogram. Now, why wound healing matters in your perspective, I felt was, as our guest speaker from the international, he has very rightly said that patency is not equal to healing. Straight line flow is not equal to functional limb. And a technically successful revascularization can still fail clinically. So it is not to discourage all of you. I'm sure this is just to know that this can happen in some of the situations. So these are the various types of wounds and gangrenes and CLTIs you commonly come across in practice. I'm not going to elaborate on that. You are also familiar with all the Wi-Fi categorization of SPS. But more important to know the red categories where it makes a difference, where the estimate risk of amputation as well as the chances of a better revascularization requirement happens in the higher grades. And most of my lecture talk will be more on the stage 3 and 4, obviously. The basics of wound care, many of my slides may be too many text matter. You don't bother about that. I just want to just highlight and make it into a short paper. But pre-procedure, what are we trying to do? We are trying to optimize the foot and prepare the wound and surrounding tissues and maximize the success of revascularization. So how do we do that? One is infection control. We need to do the prompt initiation of targeted antibiotics. Debridement, which we have, it's a podiatry procedure. The dressing selection, of course, again, it is in my categorization where I have to select the dressing depending on the individual wounds which we see. And another important aspect is the offloading and pressure relief, which is very often neglected in even a simple ward, where we often see that these people, they develop, during hospitalization, they develop a heel ulcer or a heel pre-ischemia. And patient always says that they come with this and then they ended up with another heel gangrene, because there's an active ischemic process going on when they get admitted. So it is important to relieve pressure. And vascular assessment, of course, sharing, very important is the sharing the wound details to both of us between departments. The next, once the procedure is done, immediate care is to ensure the wound environment is optimized for healing once blood flow is restored. So we need to do the wound monitoring, as someone rightly pointed out. We need to look for how the success is, the blush and other things are. The next morning, patient is obviously having no pain. All of us are happy. So it's very often a good angioplasty, you ask the next day, there is no pain. So that's, I agree with that. Surgery, of course, that is done again to the immediate procedure. Dressing selection, again, I'm not going to tell the details of that. It's just to know that we need to have a very important dressing selection, and offloading, again, the same thing. Now, the long-term maintenance is equally important for any wound, as you know. It's not just the revascularization, the procedures. You need to do the regular debridement. Footwear is important, again, in my realm. And patient education, extremely important, just to tell them what is the expectations and outcomes, and also it empowers the patients to detect the problems, and the surveillance, which our follow-up we need to do. So in CLT, as I said, that the durable wound healing and maintaining a functional status and preventing future limb loss, these are all possible by a successful revascularization. Wound care, again, I have just put it in a sequential form where we inspect, document, we identify the infection risk. Sequence of the care, I'll just come to the debridement and angioplasty a little later, and verify the perfusion and integrate the wound care strategies with all the other post-procedure issues, and reassess, record, and re-intervene if necessary by especially looking for occlusions or restenosis. So this is just a comprehensive of what we need to do regarding the wound, setting apart all the other general issues, other issues. Purely on a wound classification or a wound basis, I will just put this into the perspective, wound care. So this is again just to show how wound healing can, wound dressing or wound care can matter in these patients, which comes with only a conservative dressing and a proper wound dressing. Some of the patients might refuse a skin graft. We need to select the appropriate dressing, and some of them heal after revascularization primarily. And of course, this is a large area of necrotizing fasciitis, a graft is done. The lucky aspect of these patients, or lucky for my side, is these are all patients with normal vascularity. But the problem comes with, this is again another patient where a complex debridement and a skin graft. All these patients had good vascularity. So wound care is, I don't say it is outstanding, but definitely a routine wound care will definitely get across these results. But in cases of ischemia, wound care is you need to be extremely careful that whatever we do should not aggravate the insult. So this is an important slide where just saying what are the 5 factors of delayed high wound healing. 5, all of them are important. The one interesting aspect of this circle is what I say is, which you also commonly, you have done good revascularization, everything is fine, you feel like God next day that you have done superb, but still patient is not becoming better. I am not happy. I call back and say, think boss. So you just omit that you have done the job there, then you'll have to revisit all these problems. Whether there is a problem with the fundamental problem with the patient, nutrition, or he's having renal failure or diabetes not under control. Infection, relook at the infection, look at the cultures. Tissue defect factors, basically, fundamentally, the Wi-Fi itself might be a problem. So that also you need to communicate with the patient. And of course, inadequate wound management like improper offloading or all these things. So it is important slide where you need to have a good idea about what is the way forward in ulcer healing. This is my perspective. Once I've done through the wound, this is my perspective where I look at it from a total point of view, including your specialty also. That is identification, strategy, vascular intervention, integration, and recovery and rehabilitation. Everything has got its clinical focus, where we need to go through in this pattern systematically, regularly, daily, routinely in most of our patients. If you do that, then only you will be able to talk about good results. So IR, you people talk patency, I talk healing, and patient wants function. So it is a shared language. Never should that language or protocol be missed in any of these patients. Not a single patient should go without sharing a common language. This is just a huge slide, but I'll just put these things into my case discussions just to say how the shared language goes through in between the surgeon and the physician or the interventional radiologist. Just to give you a total idea, I will discuss some of the green highlights I will discuss in the slides to come. This is again because I took the advantage of ChatGPT. Just 2 days back, I thought, let me task ChatGPT how the interplay. I never found any major slide in the net. So ChatGPT gave me a good day-to-day functioning of what is the daily problems between interventional radiologists. We are talking about perfusion versus surgery. Interventional radiologist and patient are looking at procedural risks and outcome hopes. And me and the patient, I am looking at limb salvage patients is asking for amputation. So it is a shared decision zone. But why you see the overflow there is because whatever we do, ultimately the patient's priorities always gives, you have to give importance. That's why you see the routine circle is always, there is a leak on the lower circle. Because that is what is the preparation, that is the priority for all of us. Once we go to that, then I'm sure all of us will succeed. So balancing what can be revascularized, what must heal, and what the patient values most. So this is all basically a coordination, a communication with the patient and with ourselves and the patient's bystanders. So this is again a routine slide I put in most of my diabetic foot conferences or talks. It is just to give you a flow. Here the primary issue is about the criticality of limb and life. Then you go across according to how it occurs. The limb aspect, whether it is critical, if it is yes, then you go for surgery. If it is no, then you go for assessing the vascular status and going for revascularization. The one on the left side is mainly the reconstruction limb. This is another aspect of the ischemic part, whether there is infection ischemia or it is a dry ischemia. If dry ischemia, dry gangrene, you can directly go for revascularization. Otherwise, you can go for the surgical aspect and then treat that and go for revascularization. The right extreme is totally redundant in this meeting, but anyway, just to complete that, I have given that here. So again, this is again the constant battle between the argument between debridement first and angioplasty first. In the practice as well as in repeated and many of our discussions, it has always been there, but through experience and whatever I have shared, it is only that it is not, the decision is not about debridement versus angioplasty, but identifying which problem threatens life first and which threatens lifelong. So identify these and go accordingly. But just to give you a highlight about the debridement versus angioplasty, in my practice, almost you can say around 30%, around 20% also goes for debridement, but maximum 80% I go for angioplasty first, which it gives really excellent results. Of course, it has got its advantages and disadvantages, but it's important to do the revascularization. So at least 80 to 90% of patients will require revascularization at some time. 10%, of course, it can be either so many issues, sometimes mortality also can be there. So this is just to highlight the debridement first versus angioplasty first. It has got clean, you have a clear mind, then you can go forward. And of course, through the Wi-Fi, as you see here, most of everything is covered by angioplasty somewhere or the other. Debridement, of course, in Wi-Fi 4, stage 4, it doesn't really, revascularization really doesn't change. But I'll get to the discussion a little later. So this is just to highlight that again, I will always, in my practice, always I will look for angioplasty first. Debridement first has got its definite role, but definitely I will just discuss in the next slide. This is again just to give you the various combinations, just to put it up as a paper, that some situations where we do only revascularization, only surgery, no revascularization, surgery along with revascularization, and no surgery, no revascularization. Everything has got its role. So basically, you put all these patients into any of these categories in the beginning itself. Then there is no problem regarding clarity of the result. Now, I hope all of you have noticed is just dedicating this slide to the ISVR conference. Whatever slides I have put in the last few minutes is all a mnemonic for, I love acronyms. And Dr. Shoro also showed me an acronym about AVF while we were having lunch. So this is another acronym which I dedicate to ISVR. Again, as I said, I love acronyms. So you just, if you feel that you're not good in CLTI management, just revise all your acronyms. You are able to manage CLTI. This is how it is done. All the acronyms are in place. You just highlight all these acronyms and your practice is done. So this is how CLI management goes with all the acronymic. I think most of you are familiar with this. I just want to put it as on record. Again, I finally say that it is the ISVR acronymic journey of CLTI management. Whatever I have said in the last 2 slides, I have put it in ISVR. So this is just to highlight and tell the ISVR, the top people management concerned, that don't need to use this as a, but any of the other things, if you want to really be visible, probably you can use ISVR in some other type of management in any of your interventions and put it across the international stage. Probably it will last generations to come. It's just to give you an idea. So I can just go through a few cases just to show you what's happening. In sepsis, as I said, debridement first. Debridement first to stabilize the patient and the wound, revascularize. This is, I've just put the dates, don't concentrate on the dates, but why I put the dates is to make it a little more authentic. At the same time, every date, I just want to highlight that for the patient, the date is important. The clock starts from the time you see him. So it's important to verify the dates and tell him, look, you are this, you have documented this photo, you show him, not to terrify him, but to convince him that we are doing the best for him and that he is going to do better definitely with our combined approach. So this is sepsis, of course, debridement. Then infection behaves very quickly in ischemic tissue. And so very bad it is. Infection is so familiar and it does so well in so many, but ischemic tissues, it's really, it goes crazy and haywire. So you really cannot predict the result, but you need to have a tight control of the wound and the patient and the vascularity. Once you get a grip of it, then you'll be able to do the, get the healing at 1 year's time. This is again infection behaving differently. And you are all familiar, this 2-3 others are all angiographic or your zone where you say ulcer location dictates the target vessel. You already had the lectures here. But again here it is important, the patient refused any form of surgery, so only dressing, and she did get the healing of this deep wound with angioplasty. This again, pedal arch, our faculty had nicely discussed about the completeness. It is important, especially in a minor amputation, bang on, it will heal. And very important is to have a flap survival, and also the risk of re-escalation, ulceration is not there. So that is very important to have a long-term follow-up there after pedal arch reconstruction. Angiosome, again, it was discussed, the inline and angiosome directed flow is extremely important. Again, patient refused a skin graft. So we need to go for dressing and conservative vacuum, so many other wound healing technologies. But ultimately, this just summarizes that the angiogram directed and inflow is improving wound healing definitely. This is a very important slide. Operate, I always explain, this I takes time, explain to the patient about operating within the perfusion window. Very, very important, because once I get hold, you get the revascularization onto my hand, I will just hold that, and within that window I need to finish. So my window is usually, I tell them, around 2 to 3 months. But I don't go before that. For example, here I have done the amputation after 1 month, and then 1.5 months, that is the picture. And I do the skin graft probably after 2.5 months. Usually I will like to finish it off within 1.5 months. But so many as economic issues, patient hesitancy, cost, so many things, they are so hesitant about these things. But one good thing about doing the debridement and doing that is you do the repeat angio, the Doppler, tell them, look boss, we have put your blood supply okay, things are okay, now we are going to do it. He's extremely confident of your management. He puts your full belief in you because he has seen the revascularization result, he has seen the wound healing result, then he takes his own time, he takes his own time to agree for amputation. It gives him time, you give him some time, he will come through that. That is the only way, because it's a shock for his life. So you need to give some time. But in that meantime, we'll have to control the infection, do the offloading, do the proper dressing. Everything has to be controlled. Then I think the patient is always thankful to you. So this perfusion window, again, later on it can be a restenosis or a failure. So that window is important to finish, and then you can get the result after 3 years. This is last year. Minor amputation is limb salvage. No, I'm sure all of you know it is limb salvage, it is not failure. You have to tell the patient, small wound, small, we need to, your function will be retained, your outcome will be better, you'll be able to walk, follow us, do this, we'll do the revascularization. He will be able to definitely get a good result after a few months. The versatility, now this, I'll just take a few more minutes, is it okay?
Yeah, I think
yes,
so.
yeah, okay. Yeah, there's another 3 or 4 slides. 3 or 4 slides. The versatility, so don't, of course, you are an interventional radiologist, but with full marks to the vascular surgeon, bypass revascularization is really versatile. Even luckily, when I was just finalizing my slide, this patient came to me 3 days back, and I just quickly included that date in my slide. fantastic by this. And the one important aspect again to highlight that what you guys and we people are doing will definitely have a lasting effect. This patient, his family, they pleaded with the surgeon and myself to do a below knee amputation, extreme pain. They pleaded with us, please amputate this. We have gone to many hospitals, they have refused this, but we took it as a challenge, or rather put the onus on God probably. And then probably he is still coming till today. There are almost 3.5 years. He keeps visiting regularly. Follow-up is important, definitely. So this is just to show you the X-ray of how it was at that time. It was an infective fracture, and then we did a debridement to 1 or 2 sittings. And this is just taken a few, I think last month, 4th of December, I took it. So that is the healing which happens in this patient. This is another Indian I don't know how it is in other countries. In India, always people say you lose your tender Achilles, you're gone, you're doomed for life, you end up in a below knee amputation. Take it from me, I have removed, not unnecessarily of course, routinely I have been taking, unless indicated, lot of tender Achilles, everybody is walking. But of course, you have to follow the wound healing principles. That's all I can say. This is just to have an idea. It is not that you just write off. Of course, revascularization does help in these patients also. Probably the combination where you're not able to revascularize, wound care is bad, debridement is bad, then probably they'll end up in an amputation because the extent of wound is very bad. Revascularization, then our important thing is never give up on revascularization just because the wound is bad. Still, I advise my IR to do revascularization, whatever, because whatever I do at the below knee level, definitely it is going to be helping the wound at least at this level. So that is also important. Partial success is still success. No blood, some revascularization is better than no blood. Give me blood. So at least partial. You do something, you get some blood, I think for a small wound, for example, get it done, it reduces pain, enables healing and prevents major amputation. And then what else? These 3 are done with a partial revascularization, and better do it, that's all. And failure of revascularization is not failure of care. We have to try, not within our limits, and so many other issues. I'm just giving you a lot of good slides, but we have gone through all this process where we have lost a lot of limbs and patients, some of them, not lots rather. And definitely we need to, but at least we are convinced that we have done the revascularization. It can be so many issues, so I'm not discussing the theory behind that. And so what are the meaning of outcomes? Whatever we say, ultimately, you talk about patency, flow, and target lesion. I will talk about healing, limb salvage, durable wound. But patient will always say function, ambulation, quality of life. I dedicated this lecture to this patient till almost till last year. This is 24. He was walking and then he passed away last year. So whatever 2-3 years he was living from the date of, the date is there, 2 years. He was living, the family was extremely thankful to us because he was able to have a dignity of life and walking. Of course, he died of MAC. So that is how it is regarding this. And finally, and encouraging all of you to do revascularization as much as possible is a game changer. It's a game changer in CLTI. So I think in my practice for so many years, I have seen earlier days a lot of bypass, other things. But right now, as I said, I have just reviewed a few of my 35, 40 patients where we have done the combined approach. Probably around 2 or 3 have undergone bypass. Almost 30 have undergone revascularization. So means endovascular revascularization. So it's a game changer. So continue doing a good work and all the best. Thank you.
Agree that combination of interventional radiologist and a podiatrist definitely makes a world of difference. My only question is, in our practice, which everybody will agree, most of the time the patient has come without evaluating even the blood vessel. No, I think the surgeon or the orthopedic or whosoever has not even palpated the pulses. And then they just open up the wound and then you have major or limb loss or tissue loss. So that's one thing I think someone like you has to kind of popularize the whole idea that, okay, look for vessels and then decide what to do with the wound. So I think that would be one thing that I would suggest. But anybody else wants to say something quick before we get on to the last lecture of this session? I think that was really brilliant work that you've done, and we all know that we've just done 10% of the work, the 90% of the work is done by him.
No, I disagree.
I think so.
Because I look forward to your work because that is the very crucial aspect on which I can do that. So there is no question of allotting percentage here.
No, I know, but you know, from the patient's point of view,
no.
you know, the care that is given by you all is totally different from then what we see
Let
here.
us not affix percentages, we will take a combined responsibility.
Yeah, that remains, but
Yeah.
our job is little easy than yours.
No, I don't
Thank
think
you
so.
so much.
Thank you.
Lovely this was.
Thank you.
Really lovely.
Thank you, Dr. Anandakrishna Bhatt. Especially the slide with all the acronyms, my God. Right. For the next one, regarding the complications, I call upon Dr. Bhavesh sir.
Whenever we go for such meetings and 2 or 3 of these talks, when you see this limb, we are used to watching or, looking at these. But if there are lay people sitting, the guys who are doing audiovisual, they just get psyched out. And the other law talk on breast imaging, they again get psyched out. So what these doctors are discussing openly.
So good afternoon. I think it's Dr. Anand, I think it's a dream surgeon where who understands the value of IR, pushes them to do more, and then does not look at a partial failure as a failure altogether. So I think that's something which is interesting. I think none of us are immune to this complications in PAD, and it's a very broad topic. I hope I'll try to do justice to this, but I think this quote Antariksh gave me, and I felt this sums up almost everything that all of us go through every now and then. We need to go and keep on looking at what our mistakes were and where we went wrong, and how do we deep dive into try to understand and explain how complications could be avoided in the next particular setting. I think what I would try to cover up is show you a spectrum of complications, probably how to pick up angiographically and clinically, stepwise and bailout strategies, probably preventive principles as well. I think why does it matter? Because most of these patients have multiple comorbidities. They endovascular first is becoming the approach now day by day, and then we do have a lot of complications associated with these comorbidities as well. Some of these are preventable and salvageable complications, so I think that's important to note that. And unfortunately, complications are sometimes not avoidable, but if you manage it poorly, then these lead to limb loss, and eventually they lead to sometimes medico-legal suits as well. So it's important to note them and then evaluate them. I think broadly, if I have to look at them, I would look at them as access site related issues, and all of us are aware of it, right from hematomas to hemorrhages to the fistulas or the pseudoaneurysms of these access vessels. You have hardware related complications like your guide wire catheter, your stent related, your balloon related device related complications. You have complications which are systemic, something like a reperfusion injury or a compartment syndrome, or you're looking of contrast-induced nephropathies, and these are a different set of complications that we all have seen sometime or the other. And lastly, I think miscellaneous ones, where now because of a lot of TAVIs been offered, and we've been called upon at a lot of these places for large bore access-related issues and alternate site-related issues, we need to be oriented to these problems, and how do we take care of these as well. I think this is a picture that sums up everything. Your groin can be your graveyard. Most of the, I remember one of my patients back there in our KM days, we did an angioplasty, lovely procedure done. Next day morning, got a call from a fellow that patient is no more. And we started realizing what happened, and by the time we realized patient had collapsed, a quick CT was done, and by the time patient would shift out of CT, a massive retroperitoneal hematoma, we lost the patient. I think that was the only patient we've had so far, and since then onwards, there's a huge red flag always and always when you're looking for any hypovolemia happening to these patients. So once you get this, you will never forget retroperitoneal hemorrhage can cause havoc. The incidences are increasing, largely the access site related, because most of these procedures are now going to convert into therapeutic ones rather than the diagnostic ones. Typically, what are the risk factors? Calcified vessels, high bifurcations. You have sheath to femoral artery ratios being altered, sometimes in female patients because of the small size of the vessel, and all of these tend to cause more of complications. How do you prevent them? You make sure that you have ultrasound guidance. That's most important. People are converting them. Most of their accesses, all our accesses in all our interventions are now ultrasound guided. We never take blind accesses at all. Obviously, surgical cut downs if at all required. And this is a beautiful paper and publication, 2 studies done from a coronary procedure perspective. So if you imagine the cardiologists who are not used to doing ultrasound guided accesses, there's a FOST trial and a universal trial, both done by them. And what they demonstrated in that is that in patients where they started using ultrasound access, and when they've started doing ultrasound, the vascular complication dramatically dropped in these patients as compared to where they were not using ultrasound guidance. At the same time, what they also demonstrated is that in patients, the yellow one is where they've done more than 20 ultrasound accesses. So where they've done more ultrasound accesses, the chances of complications, vascular complications, also dramatically reduced. So to that extent that even cardiologists now have to move to ultrasound guide accesses for most of their coronary procedures. And that's the kind of trial data that you're talking of. In terms of retroperitoneal hematoma, I think it's relatively rare. It's less than 0.5%. One of the most common causes would be a high arterial puncture, I think with good ultrasound access, with bifurcation very well seen, plus the femoral head clearly seen on ultrasound. This is dramatically low. The blind punctures do still cause some of these. How do you realize, I think hemodynamic signs, most important, hypotension, tachycardia, shock, severe perspiration. I think some of our draping materials that we get these days, you have a small hole which is open at the level of the groin. I remember one of my patients when I did angioplasty, this was way back, around 10 years back, and we would introduce a Balkin sheet to crossover. Everything is going well, and then suddenly patient is developing hypotension, and we are looking at the fluoroscopic image of the bladder wall, and bladder is not shifted, or there's nothing seen, nothing happening in the groin area, and then suddenly we lifted the drape and we realized that the entire hematoma is tracking along the abdominal wall. So sometimes because of these drapes you may miss, so it's important to keep note of that. Obviously severe ones would require the surgical repair as well. How do you manage that? Obviously talking about basic stabilization with fluids, maintaining MAC of 70 to 90, sometimes transfusions, hemaxils. In terms of endovascular, I mean, these are the first things that's required, and you have to have an anesthetist with you most of the times when you're doing complex procedures. A low pressure balloon tamponade, I think that's the first step that you do. We have a very clear plan whenever we do the angioplasty and we come out. We never remove the balloon off the wire. We take the chutes to make sure that in case if you push the balloon back up, you always have an option of doing that. Obviously, sometimes if it's required, you might have to go for a CT angio. If you find a small vessel which is bleeding, you might have to embolize using coils. Most of us in our cath labs would have the coils, the gel foams, the glues available to us to do that. And in rare instances, you might have to put a covered graft as well, in case if you don't have time and patient is hemodynamically not stable. So you always have fluencies and the Kaviras or the other currently available newer grafts available on your shelf. We always have an 8 mm graft and a 6 mm graft available in our cath lab at all point in time. Yes, to understand that if you have time and your patient is hemodynamically stable, you always have an option of going for a surgical option, because under local anesthesia, locally you can open up and a good purse string suture could do most of your job instead of doing all these expensive procedures. Pseudoaneurysms, and I think pseudoaneurysms is quite rare these days, but yes, good 1% of the patients may have it. Ultrasound access has dramatically reducing, but yes, you still do get them. How do you manage them? If you have a small neck, less than 2 mm neck, sometimes observing and mechanical compression with an ultrasound probe itself would do your job. Wide necks, sometimes you might require a balloon protection, and then you might have to inject a thrombin or a glue in these patients, like how I've shown in these couple of cases. Though our preferred choice always is that if the neck is not very wide, we directly inject the thrombin without using the balloon. We believe that it alters the dynamics of the flow within the pseudoaneurysm, and you end up causing occlusion of the thrombin remains within a focal area of the aneurysm. It does not go into the entire one. Like I just mentioned, thrombin injection, ultrasound guidance is something which is, all of us are aware of it. It's quite straightforward as well. The risk of embolic phenomenon there is dramatically low. It's hardly ever seen, unless you're really shabby and you push large volumes without understanding the effects. I think lastly, obviously, as I mentioned, surgery is the choice, and if required, grafts always have to be ready. Now, some of the novel techniques for managing pseudoaneurysms is the ultrasound guided angioseals, or the closure devices, the suture based devices that we have. I'm sure all of us are aware. We would take an ultrasound guidance, use a wire like a micropuncture wire, and pass through that neck, enter into the main artery, use a plug like a angioceal kind of a plate or a suture days device, and you can always do the occlusions like that. Now, rare instances, obviously you will have to put a graft. These are some of the common situations when you have large bore accesses. Yeah, suture-mediated devices itself can cause some sort of narrowing at the area when you've used a couple of them. And that might require a low pressure balloon sometimes to make sure that you have adequate inflow into the limb as well. AV fistulas. Now, AV fistulas, though not very common, it's a known phenomenon. Typically what you would get it is either if you've taken a puncture at SFA origin where the artery and the vein are anterior and posterior orientation, and that's where you can get it. How do you look for it? Clinically, sometimes it may be asymptomatic. It might lead to severe limb pain as well as swelling sometimes. Obviously, on angiogram, you may be able to demonstrate the fistula very well. Now, typically when you have these kind of situations, I think first, and this is one such patient where we the angio was done and we realized that there was active fistula and the entire flow was stolen from the lower limb. You can make out the limb swelling that has happened. This patient was done elsewhere and this was referred back to us at a later date. And you see the kind of swelling that's already led to sometimes a simple balloon tamponade, or sometimes if required you might have to end up putting a graft as well. Like in this patient, we did attempt a balloon tamponade for a short period of time. Unfortunately, that didn't solve our problem, and we had to end up putting a covered graft to make sure that the fistula is taken care of. Yes, surgery is an option for these patients, especially when you have young patients or when you have to put the graft which is coming all the way into the common femoral artery, and you would compromise the profunda origin as well. So in those scenarios, surgery seems to be a more logical option to go for as well. I think perforations in terms of having an actual arterial perforations, if you have very narrow artery or arteries are in spasm, or if you're using a very forceful manipulation or sometimes stiff fires, you might get it. I think most good hands with a gentle maneuvering, the perforations are unlikely to happen, and what you end up invariably being called for is when some of your other cardiological colleagues have taken care, have an access, and then you might have to go ahead and help bail them out in such scenarios where your entire radial artery is ruptured here because of the forceful manipulation. Typically they don't use a Teramo glide wire, they use a J wire directly, and they tend to force that, and probably that is one of the reasons. Sometimes, like in this patient, when you have postplasty, you can have a injury like that. This is one place where balloon was done inadvertently in a smaller branch, okay, and we were called in to help out, and then obviously this is something which is managed either by balloon dilatation, or if at all required, you might have to end up putting a graft as well. In this patient, only balloon dilatation did the job. Some of the hardware related, and I think dissections are something which are known in these patients, where you have complex disease with heavy calcium in these patients. So oversizing of the balloon, heavy calcium, smaller vessel size, or sometimes when you have long segment balloon dilatations to be done, I think these are the patients where you have dissections as well. Sometimes these are just seen on angiography and they may not be flow limiting, and you might not have to do anything. IVUS does help in locating these dissections, and they may sometimes help make out if you have a spiral or a circumferential extent involved, where you might have to go ahead and then intervene in these patients. Non-flow limiting, obviously you're not going to do anything. Sometimes, again, a prolonged balloon dilatation would do most of the times the job of making sure that the dissections don't cause any flow limitations. There is one such classification. Obviously, we don't entirely go by that, but I think when you have spiral dissections, or you have persistent filling defects, or you have total occlusion when you remove the wire, I think these are the situations where you might have to intervene. Otherwise, most of the cases when you have minimal dissections with no flow limitation, you may get away by just prolonged balloon dilatation and doing nothing beyond that. But mind you, when you do, and this has happened in one of our patients some time back, antegrade access taken, when the J wire of the sheath was introduced, the wire got stuck in one of the calcified plaques distally in the origin, and the enthusiastic fellow pushed the wire very nicely, and with that the sheath as well, and then sheath entirely dissected into the false lumen, and then we had the entire proximal 2/3 of SFA, the dissection flap going on. And by the time I reached, what he had done is to make sure what is happening, he started injecting and demonstrating also. So now the sheath is in subepidermal plane, and now with injections, now it's extended even beyond. And obviously, we did pull the sheath back. We made sure that, on Doppler the velocities were good. This patient fortunately didn't complain of any rest pain during that period, and we made sure that we put this patient on anticoagulation for around 4 weeks, and post that we did pick up this patient and we ended up stenting the same SFA to get the final result. But yeah, something which looks like a simple sheath placement can itself cause a massive problem as well. So again, sometimes you have dissections like this, where you have very distal dissections happening because of oversizing of the balloon or heavy calcium. Sometimes you have to just let go. You can't always offer something, therapy. You might end up putting a coronary stent here. That's a possibility, but such a superficial coronary stents may not last long as well. It can get compressed, and you may not be able to get a good result there as well. So in terms of hardware related, and some of these I've taken from some of the articles, and I'll show you what options you have. Commonly, these hardware-related complications are seen in subintimal angioplasties, or when you have excessive rotation of these wires, or if these wires get trapped in calcified plaques as well. How do you manage that? Now, like in this patient, now you have a small wire which was broken in one of the branches of the peroneal artery, and obviously in this case what we ended up doing is just ballooning the entire the main peroneal artery and leaving the wire back in the branch, and it didn't have any effect at all. It was a very small branch, so you can always do that as an option. This again is taken from one of the publications which I had come across, though we've not seen that. When you have a wire which is entrapped and broken down, and a snare was used to remove that. So I think having a snare in your kitty is almost a must in most of the cath labs. And lastly, I came across this paper where they used a solitaire device to remove a broken J-tip wire. Now, we are fortunate so far we've not got it, and I'm sure most of us would not have got this kind of complications. But yes, having a device like this could always come in handy to get rid of these kind of complications as well. This we've seen, not sometimes you do reuse catheters, and sometimes overzealous maneuvering of the catheter within a tortuous vessel can cause a knot formation. Obviously it can lead to spasms, and this is one such example where then we had to come from, this was a brachial access, and we had come from the femoral side, hold with a snare, and then do a torsion. So when you have knots like this, you have to have 2 accesses, hold the catheter from both sides, and then do a torsion and then remove the catheter. So yes, these catheters sometimes in an Indian scenario when it's reused can have issues as well. Tortuosity sometimes can lead to these knot formations as well. So yeah, I think balloon rupture rarely you see nowadays. I think most of us are using the inflation devices, and we are aware of the rated burst pressures as well, so we don't overdo it as well. But yes, if you have a circumferential balloon rupture like this, and the entire balloon is which is left behind in the catheter in the artery, and this is again taken from a paper. We've not yet to seen this kind of a complication, but again you could cut the hub and introduce a guiding catheter over that, and make sure you snare and remove the entire balloon with that. So yeah, I think talking about the fistulas post-plasty, we've already discussed about the prolonged balloon dilatations as well. In terms of acute vessel thrombosis, and I think this is one thing when we are doing long segment diseases, or sometimes acute on chronic lesions where we have done the plasty, embolic phenomenons happening, and the clot flowing down, you would have to be prepared with mechanical thrombectomy devices or a simple guiding catheters to aspirate the clot, and you have to be prepared with Actylase and infusion catheters available in your cath lab as well. So I think distal embolic phenomenon, like in this patient, again post angioplasty, a good result, but an entire thrombus has gone down and blocked the bifurcation. again, we used a guiding catheter in this case, which was immediately available and aspirated. And if you can see, some of these are white plaques. It's not even literally a fresh clot, which is white thrombus, which is coming out in this. It's not a fresh clot which is developing. So yes, and then obviously this patient eventually was put on Actylase, and finally the entire rest pain as well as the wound. Obviously this patient had rest pain and no wound. We could salvage the limb rarely, and I think this is only one case we've got iliac vein, iliac artery, bilateral iliac artery stenting, a beautiful result post that. But if you see here, there is a embolic clot which has gone down, and the entire femoral artery on that side is occluded, and the entire outflow from the right limb is gone. Now, this is one place where you have to be careful. We saw a beautiful result, but a clot going down. Now, here if you would remove the sheath, there is a risk of this entire clot going all the way down. So here in this scenario, you always take a help of your surgeon. If you can see the angio here, the clot is being trapped at the level of the sheath. We took a help of our surgeon, did a local embolectomy, and the entire clot was removed from there. So yes, you do have to involve your surgical colleagues as well. I think rarely you do get external iliac artery ruptures, and as I mentioned, you have to be prepared with your hardware. I think for the want of time, I'm going to skip all this, and I'm going to show you lastly, when you have accesses like this, because of now TAVI has been offered and you've been called to take axillary accesses, and when you have large accesses like that, and when you have large devices going through these arteries, some of these arteries actually may get dissected and completely occluded. And this is one place where you should be ready with another access in the femoral, in the groin area, cross through, and then again be ready with sometimes aspiration of the clot, or sometimes just placing a graft like in this patient. This is how the pre and post picture looks post graft. So yes, you have to be, and typically these are patients who have severe aortic stenosis, and TAVI has been offered for them, so they're not at all good for taking up for surgery in these scenarios, and you have to be ready for that. I think lastly, systemic, we all know the reperfusion injury as well as the compartment syndrome. You would require a proper alkalization, diuresis, correction of hyperkalemia, and most importantly, have your anesthetists as well as the surgeons in sync with that. I would end my talk by saying that emergency hardware, and what are the most important emergency hardwares you need to have in your cath lab. A large bore sheaths. When you're doing a peripheral plasties, you still need 8 and 10 French sheaths. If you have to put your grafts or a covered graft, you should have it ready. You should have your crossover sheaths, including 8 French crossover sheath. Some of these large diameter Coveras or the Fluencies would go through an 8 French sheath. Obviously, those who are doing aorta in your labs, you would have a CODA balloon or another semi-compliant or a compliant balloon, so that if you have an aortic rupture or a dissection, you could be able to inflate that and make sure you have enough devices or a surgeon available. Lastly, the covered devices, the embolectomy catheters, surgical colleague, and anesthetists. I think that's most important. Thank you.
I think very nicely put and discussed extensively various things that can go wrong and that we got to be ready. I think a good discussion, Bhavesh. I'm sure that was a lot of effort that you guys have put it. Thank you very much for that. Yeah. And we'll take some complication which you had that we can all discuss. Something exotic, something which actually got you sleepless for 2 nights or something like that. Nahin? Aisa nahi hua hai? I think one of the commonest thing that we do is the rupture of the iliac vessel. And that, as he said rightly, we know the external iliac is very, very fragile, does not have too much of media, and trying to do balloon dilatation, then often your wire has gone in the subintimal plate, and there you have dilated it, you'll rupture it. So having a stent graft at that point of time, and balloon tamponade probably is the best thing, and looking for it, watching that the bladder is shifting, should tell you that this is what is happening. So, yeah, quick.
If you want to not sleep ever, if you ever get something stuck up and over, a device, balloon, something, our natural reaction is pull harder, pin and pull, keep pulling. We had one where we had a device stuck, pin and pull, not too hard. And then we transferred to surgery saying the device is stuck, why don't you help us out? Turned out that just from the lightest pinning and pulling with a fixed point ruptured the entire iliac bifurcation. And we did not know because the systemic response wasn't immediate under anesthesia. So we always think pull harder, balloon is stuck, device is stuck, something is stuck. Don't pull that hard because if it's a weak calcified aortic bifurcation, you can create a lever point and it basically string cheeses the aortic bifurcation. So that'll make you not sleep.
Kind of abolished it completely, so that's what happens. Even, especially with the AAAs or big devices that you put in, you know if the vessel is not good, you may just tear it open and could be a disaster for all of you. Yeah. So thanks again, all of you. I think this was a wonderful session, well attended and well discussed. Thank you again.
Thank you, Dr. Bhavesh, for putting an end to this peripheral vascular disease session. We'll continue with the visceral arterial session. And for visceral aneurysms, principles and techniques in management, I invite Dr. Rangarajan Rajagopal. And for chairing the session, I call upon Dr. Mansi Verma, Dr. Priya Jagia, and Dr. Azam Kankan.
For inviting me. So I'll be talking about visceral artery aneurysms.
So it seems everyone does PAD, but very few people do visceral. Is that so?
Visceral.
Huh? Okay, it's my pleasure to introduce Dr. Rangarajan Rajagopal, who is at AIIMS Madurai and was formerly at AIIMS Jodhpur, and he'll be talking about visceral artery aneurysms.
Thank you for the organizing team, and I would like to thank ma'am for the introduction. So I am currently affiliated to AIIMS Madurai, but the cases I'm going to show are done in AIIMS Jodhpur when we did it as an IR team. So I'll try to keep it as short as possible so that I'm not between you and the T. So the learning objectives will be to briefly look at the etiology, the treatment guidelines. If there is one document that you have to read, it is the CIRSE Guideline 2023, and how decision making is done, and the treatment strategies that are being discussed in the CIRSE Guideline and a few of the cases. So the incidence is fairly quite rare, about 0.1 to 0.2% in the general population. But if you look at autopsy studies, it has a higher incidence because these tend to rupture, and those patients in which it ruptures, they mostly end up with severe morbidity or mortality. And nowadays we are seeing an increasing detection due to cross-sectional imaging that is performed very commonly. And the mean age at diagnosis is about 65. These can be true aneurysms or pseudoaneurysms. So true aneurysms contain all three layers of the wall, and they have to be treated in a different manner as compared to pseudoaneurysms, which do not contain all three layers and which often require an emergent or an urgent management. So the commonest sites for visceral aneurysms are, in all of these studies, the splenic artery is the most common site, followed by hepatic and renal. Different studies quote different incidence rates, with renal being a commoner or hepatic being commoner, followed by the other vessels like the SMA, celiac, and the smaller vessels. So as I said previously, the mortality when it ruptures is quite high, and the QR code is there, that is there for the CIRSE guideline document. So the etiopathogenesis of true aneurysms or pseudoaneurysms are different. So in true aneurysms, most of them are due to atherosclerosis or FMD, and it can be syndromic like Ehlers-Danlos syndrome or Marfan syndrome, and some of the splenic aneurysms are secondary to portal hypertension. You could also see the pancreatic or duodenal true aneurysms, which are secondary to MALS or celiac stenosis. On the opposite side, the pseudoaneurysms are most commonly due to infective post-pancreatitis and trauma or iatrogenic. So this is again a table which I picked up from the CIRSE document. Again, the QR code will take you there. So splenic is the most commonest, followed by hepatic here in the European population, followed by renal, superior mesenteric, celiac, pancreatic or duodenal, and less commonly in jejunal, iliac, and colic. So the splenic aneurysms, they are more predominant among females, whereas most of the other aneurysms are commoner in males. And again, if we just look at the specific predisposing causes, we see that in splenic it's most common pregnancy, portal hypertension. Pancreatitis related pseudoaneurysms is one other common cause. And in renal, it's mostly fibromuscular dysplasia or atherosclerosis. And gastroepiploic or pancreaticoduodenal aneurysms is secondary to celiac stenosis. And if we just look at the last column, the risk of rupture and the risk of mortality in these patients is quite high. Symptomatology, the patients, they follow into two categories. Some of them can be asymptomatic, where the aneurysms are found incidentally on imaging, and the others, they present with abdominal pain and symptoms of bleeding. Depending on the space in which they bleed, the symptoms can be there. It can rupture into the peritoneal cavity, retroperitoneal space, into the GI tract or into the biliary tract. And if it does rupture into the pancreatic duct and in the biliary tract, you can see the classic hemosuccus pancreaticus. And large aneurysms, giant aneurysms, they can also present with compressive syndromes. This is the main crux of the talk, the treatment indications. So this slide shows the indication with respect to the vascular surgery guidelines of ESVS and SPS. So according to them, all visceral artery pseudoaneurysms should be treated. The thing that we have to get to our mind is all pseudoaneurysms should be treated. And all symptomatic visceral artery aneurysms, if they are asymptomatic, then they have said as a size 3 centimeter for splenic artery and renal arteries, whereas 2 centimeter for celiac, hepatic, and ileal aneurysms. No, the main thing with the SPS guideline is there is no clear-cut logic behind how they have chosen this 3 centimeter for the splenic and renal artery aneurysms and 2 centimeter for the celiac and hepatic and ileal aneurysms. All visceral artery aneurysms of the PDA, GDA, gastric artery, SMA, and colic artery, irrespective of size, should be treated. And any of the aneurysms, if they show a demonstrable increase in size, which is more than 5 mm in 1 year, or in women of childbearing age, or in patients who have received orthotropic liver transplant, should be treated. On the other side, if we just look at the CIRSE document, it's mostly the same. So all VAPAs, that is visceral artery pseudoaneurysms, should be treated. And if visceral artery aneurysms are symptomatic, they should be treated. But here we have a unified size criteria of 2 centimeters for all aneurysms, basically, hepatic, celiac, jejunal, splenic, all of them asymptomatic, 2 centimeter we treat. This is much more easier for us to remember. Any asymptomatic VAs with increase in size of more than 5 mm per year should again be treated. And in women of childbearing age, this should again be treated. So what is the pre-procedure imaging that we do in these patients? In Indian setting, CTA is the most easiest thing that we can do. And what are the things that we should look for in the pre-procedure imaging is look for the location and size of the aneurysms or pseudoaneurysm, the number and size of feeding branches, the degree of calcification of the feeding vessel, the degree of intramural thrombus, because that is going to help us decide the access route and the device that we are going to use, and the territory that is vascularized by the aneurysmal vessel. And again, we should keep in mind about the workup that needs to be done. So whether we need a sedation or general anesthesia, and the patient is cooperative, and what is the requirement for admission, most important, informed consent. And some of these patients might be receiving anticoagulation for their related heart issues if they are predominantly atherosclerotic. So then again, we should keep in mind whether we should stop the anticoagulation before doing a procedure. And if you're contemplating a stent graft or a stent in, as a therapy, do we require a loading dose of antiplatelet agents, and prophylactic antibiotic therapy, and the requirement of postoperative intensive care. So the treatment majorly, both with the SPS, ESVS guidelines as well as the CIRSE guideline, is mainly endovascular. Fares much better as compared to that of surgery. Surgery is quite a morbid surgery in the abdomen. And there are only a few indications where endovascular is unsuccessful and surgery can be preferred. One is when the vessel is occluded or inaccessible main feeding vessel. In some of the sessions yesterday, we saw that some innovative access routes were used. We could also try innovative access routes in these aneurysms. And giant VAs when there is an immediate relief of mass effect is required. So these are the only two situations where we would be contemplating surgery as compared to that of endovascular. So once we have decided it's endovascular, we should look at the easiest access route, whether it's an acute angulation from the feeding vessel or aorta, where we would like to have a brachial or a radial route, and whether we need to preserve the parent artery or not need to preserve the parent artery, and then look at the shape, size, and type of aneurysm, and whether it's a proximally located aneurysm or distal located aneurysm, and as I said, clinical presentations. Most of the pseudoaneurysms are acute, so then we would need to do an emergent or an urgent procedure, where then we would think of sacrificing the parent vessel rather than preserving it. So again, the treatment strategy, endovasculars, two broad categories. One is the occlusion of the pathological vessel. The second is you're excluding only the aneurysm with preserving the vessel. So these are the common techniques that are used. So these two are the occlusion of the pathological vessel, where you could just do an isolated occlusion of the front door, or this is the front door, back door, which is also called as the sandwich technique. And these are usually narrow-necked aneurysms. Otherwise, you could just put in a microcatheter or access the aneurysm directly percutaneously also, and inject an embolic agent or put coils into them. The other thing is preserving the artery while just treating the aneurysm, where you could just use a covered stent graft or just use a stent and put in a microcatheter and coil the aneurysms. So as I said, the agents that we can use are coils, liquid embolics, and stent grafts. The commonly used agent is a coil. It could just be a pushable coil or a detachable coil. Liquid embolic agents are very less commonly used in our practice, but there are several papers which suggest that for emergency procedures, liquid embolic agents could be used, and stent grafts. Usually in the Indian settings, there are the vessels are a little bit smaller in size, because the patient height is also not as compared to the Western population. So we would require a smaller caliber stent grafts, which are not readily available. So we generally tend towards occlusion of the pathological vessel rather than preserving the vessel. And the second thing is the cost is also inhibitory in the Indian settings. So I'll just go ahead with the cases. So this is a 16-year-old male with a history of RTA and blunt abdominal trauma. EVAST was positive, and he underwent a CT torso, where we do a CT arterial phase of the abdomen followed by a venous phase. Here you see the pseudoaneurysm there, that is arising from the splenic artery. So this is the angiogram that was done. So you see here the pseudoaneurysm, which is one of the branches, post-hilar branches of the splenic artery. Here, preserving the artery is not going to be of much use, so we went ahead with coiling the pseudoaneurysm. As according to the guidelines, all pseudoaneurysm should be treated, and again here the patient was again symptomatic hypotensive cardiac with vasospasm. So we use a microcatheter to cannulate and then put in a coil. For these distal vessels, we can make away with pushable coils. You do not require dedicated detachable coils. Here you see the perfusion deficit in the spleen post-coiling, but this is a good technical and clinical result, and it's not going to result in much of splenic infarction, because there are usually capsular collaterals which take up the blood supply. So this was another patient with who was a 20-year-old with pancreatitis. These patients also present with pseudoaneurysms related to the splenic arteries as well as the PDA arcade. Here you're seeing a large pseudoaneurysm that is arising from the splenic artery. Sorry. Again, you cannulate it using a vessel, and again sacrifice the vessel. So the main vessels that we would like to preserve are the renal arteries in case of visceral pseudoaneurysms. So there we would tend to use stent graft, but the last few months we have rarely seen any renal pseudoaneurysms or aneurysms. Most of them are iatrogenic, where we tend to sacrifice the vessel. So this is again where we have used a microcatheter and coiled you take sufficient angulations to profile the proper neck and decide where you put in the coil. I'm not able to use the pointer actually. I'm not seeing. No, it's not moving here. Okay. The arrow is not seen here. The next case was a 50-year-old male who was a status post-People's procedure, and these two are also videos, who presented with bleeding from the post-operative drain. Here again on the celiac angiogram, you're seeing a pseudoaneurysm at the drain site where they had put the drain cholecystectomy as part of the Whipple's procedure. Here you're seeing it. So again, there was a discussion. This is a small caliber vessel, 2 mm, and preserving it is quite difficult. You don't have a stent graft that is available on the shelf. So again, we discussed with the surgical team and went ahead with coiling of the vessel. So here again, you're seeing that we put in 2 coils and sacrifice the vessel. The fourth patient is a 29-year-old male, again with polytrauma bowel injury, who underwent an ileal resection and ileostomy and also had a right femur fracture fixation. Here you're seeing a pseudoaneurysm that has developed from the inferior mesenteric artery again. So on the angiograms. So important thing with the SMA and celiac aneurysms, pseudoaneurysms and the branch aneurysms is basically that you have to look at the collateral circulation. So you always cannulate the SMA in patients with IMA aneurysms, and in IMA has to be cannulated again with the SMA aneurysm. Same goes with celiac aneurysms. So you cannulate this again. And here we did a front door, back door coiling because there is a rich collateral network. We also filled the sac with coils. So this is once again after the aneurysm has been excluded, pseudoaneurysm has been excluded. So how do we follow up these patients? So technical success is basically abatement of the symptoms, and clinical success is basically abatement of the symptoms, and technical success is the successful exclusion of the aneurysm or pseudoaneurysms. There can be complications such as end organ ischemia, is very quite rare. We have not seen one, touch wood, and infections, target artery dissection or non-target embolization. If you are using a stent or a stent graft, then there is a possibility of in-stent stenosis and access site complications, and we should keep all of these things in our mind. And how do we follow up these patients? We follow up our patients in peri-procedural period at 1 month, 3 months, and 12 months, and yearly follow-up imaging. And CT angiography is the preferred mode for follow-up imaging. And if we do see sac regrowth, we might require urgent procedures, which can be a direct percutaneous procedure or again a transarterial procedure. So in summarizing, the common etiologies for visceral artery aneurysms and pseudoaneurysms that we should keep in mind are atherosclerosis, trauma, infection, and the indication for therapy. All pseudoaneurysms should be treated, and all symptomatic aneurysms should be treated. And the size criteria, if we remember it, for EC remembrance, 2 centimeter for asymptomatic VAS for all territories, and in pregnancy, women of childbearing age, and liver transplant. So there are different techniques. Each one has its own advantages and disadvantages. Most commonly used techniques are front door, back door techniques, stent assisted coiling, and stent grafts, and we do follow-up imaging at 3 months and 12 months. So with that, I'd like to end the lecture. Thank you.
Sir, that was a very nice talk. We can just have some discussion about the types of renal aneurysms, like type 1, type 2, and type 3, and like the growing role of the flow diverters in type 2.
So one
that's
thing
an
I just
important topic, I
didn't
think.
concentrate on was the role of flow diverters. So with our setting, the cost becomes a major issue, and we generally we have not used flow diverters at all. And there are some centers which do use flow diverters. And generally we would see if it is a large aneurysm which is causing a lot of compressive symptoms, we have a good urology team, we would send for a partial nephrectomy or something like that. If it is something that can be done endovascular, then we would do with sacrifice of the vessel, because in these aneurysms, the amount of renal parenchyma that is going to be infarcted is quite less, and the functional status of that part of the parenchyma is also quite less. We haven't used stent grafts or flow diverters, so I put that disclaimer before because of the restrictive costs.
Another thing is combined remodeling techniques can also be used, like combined coiling plus the stent grafts, especially for the type 2 aneurysms which are involving the renal hilum.
The hilar aneurysms are the latest. The Japanese model is basically use a lot of stents to remodel the main vessels and then coil the entire sac that is there. For us, most of the category of patients that we see are mostly pseudoaneurysms, and you need to deal it emergency, so we go ahead with this.
So the basic premise for the renal artery, because it's an end
structure. Yeah.
renal vessel, vessel, is to preserve as much as possible
parenchyma as
and
possible.
sacrifice only when. Whereas for the visceral arteries, you already described, so all of you who are doing visceral artery embolization, you should be aware about the possible collateral routes. And once you finish your embolization, make sure you also, for example, if you have done a SMA pseudoaneurysm embolization, do an IMA injection or a celiac injection to make sure that now the aneurysm is not filling via a collateral. So that also a completion angiogram is also something which should be stressed upon in these patients. And front and back door entry would be required if there is a lot of collateral flow. Any questions from the audience?
No. Pushable coils, yeah. So neurocoils and detachable coil, against the cost becomes most of these patients who visit our center, we say, they are quite poor patients. So we can get away with using 2 or 3 pushable coils rather than putting in detachable coils or some neurocoils. Yeah.
But looking at the net, it was difficult.
Yeah.
Placing
the good thing that happened with that patient was we had 2 coils at that point of time. Usually the 2 coils are not available off the shelf. Usually we have 3-4 sizes. By grace, he had that advantage at that point.
Any other questions from the audience? Okay, thank you, Dr. Rangarajan. We'll just close the session. Thank you very much.
Thank you, sir.
इधर आएगा So good evening, everyone. It's an sponsored talk on role of intravascular lithotripsy in management of heavily calcified lesions. So when I say calcified lesions, it's from aorta, iliac, CFA downwards. So the challenges with the calcification, we all know when we do a routine plasty, there is a bad dissection that can happen. The vessel doesn't open up, and when you do a balloon which is compliant or semi-compliant, the area where the balloon inflates most, where the weak point of the vessel is, so the perforation rate is pretty high when you do a ballooning in a dissection. And once you're happy with your angioplasty, once the balloon is taken out, again there is a high recoil. So calcium has real challenges, and then there could be an embolization, and if you have not opened up your vessel or prepared it well, there could be a stent crush. Also, with lot of large bore procedures like TAVR, TEVAR, thoracoabdominal cases, we need vessels which are at least, I would say, 7 mm plus, because most of these bigger devices, thoracoabdominal will go from 7 mm to 8 mm, except the TAVI has come down, but still we need a good ILX for those devices to go up. So coming to Merrill, which has a great product, it's called as Meson, and they have two variants in that, Meson P and Pro. So the only difference is the number of pulses are double in Pro. So they have 300 pulses in Pro and 150 pulses in P. Otherwise, it's same. They have 5 emitters, and they are working up with more sizes now. So as of now, the largest size available is 7 mm, which is good for most of the iliac cases in India. So let me go over. I think this is not the slide I was looking for. Just give me. So it is indented for lithotripsy enhanced. So what happens is it's basically the sonic waves which is meant to fracture the calcium, which is close to the intima as well as it is at the level. So it does not work. It is soft for softer lesions and hard for hard. So basically it is for calcified lesion. Great tool, it's not on-label use for, I would say, cerebral circulation, mainly the carotids, but people have used it because baroreceptors are there. But time when it will get a IFU for that. But as of now, for the peripheral, it's a great device. It's a over the wire, and as I told, there are 5 emitters, 1 in center and 2 at the periphery. So you'll have to, when you do the lithotripsy, you have to make sure that there is an overlapping zone, otherwise you'll miss some segment. So the maximum pulse is at the center most, and then the pulse, the strength of the pulse decreases as you go towards the periphery. As I told you, the balloon diameters are up to 7 mm, and the length is up to 60, which is 6 centimeter. So the advantage is control expansion. So one thing that has to be put in mind is it is not a balloon, it is a device. So balloon is, it's just going to inflate and touch the wall. The rest, let the shock wave or the wave or the sonic wave do the work, not the balloon. So that should be something which should be inside our mind, because we think that it's a balloon and we inflate it and then there is a rupture of the vessel. And one more thing which is very important is it should be at least 20% oversize. If you have an SFA which is close to 6, take a 7 mm. For a CFA, take always a bigger size balloon so that the wall is really opposed, so that you get the maximum result. So this is just a diagram which shows, like in the first image, the balloon is opposed and there is a micro fractures of the calcium, and this is how the luminal gain happens, and there is a change in the compliance of the vessel. It does not mean that you may not need stent. Sometimes you may have to put, if you're doing for a CTO and you think that the flow there is a limitation, then please go ahead and put a spot stenting, which is required. So just few examples. So this is a case where the sheath is not going in. So as soon as you encounter such lesion, you're doing a percutaneous case with a large bore device, go with a lithotripsy. Now, I think in a year or so, we will have good sizes available up to, I'm guessing, 12 mm for aorta, and for iliacs up to 10. And then you look at the device, how it goes. So the compliance changes. There is microcalcification, there's a luminal gain, and then you can put your big bore device. So great tool for iliac access for bigger procedures. Now coming to CFA, which is again a no stent zone, and lot of patients are obese, maybe on dual antiplatelets, hostile groin. Patient doesn't want to have a surgery, so it's a great tool for heavily calcified lesion. Patient presenting with CLTI or maybe a diffuse disabling claudication. All you have to do is cross the lesion, go with your balloon, keep a low pressure, and do lithotripsy, and then you can see the final images doesn't look bad, so with a very less minimal residual stenosis. So there are different areas where you can treat it, right from, as I told, aorta to below knee vessels. So this is our case, whereas I had shown it earlier also. Honestly, when I did a single vessel runoff, no other runoff, patient came with a non-healing wound, CLTI, and initially at the look I thought, oh, it's a simple lesion, I'll just cross it, do a POBA, maybe a DCB and come out. So when, and it was a downstake, good support, but still the wire was not crossing, so I had to take a CTO wire, and then finally it was really a concentric lesion. So wire went in, now balloon is not going. So let's look at how that calcium is moving, and this is something we encounter every day, whoever does a below knee work. So we had no other choice than to do a cracking of the calcium from outside, basically for at least a small size balloon to go in, because lithotripsy balloon is little bit bulkier. So that is for sure. When the normal balloon or 1 mm balloon is not going, then it won't go. So after PS technique, we were able to push the normal balloon in, and it helps. And then we pre-dilated with 1 or 2 mm, and then finally we went ahead with a lithotripsy balloon. The coronary lithotripsy, the disadvantage is they only have 60 pulses, and they are shorter in length. We could have used here, but finally I decided after so many usage that I can even, so the only device which was available was 4 mm, I didn't have a 3. I thought it's a single vessel, but I inflated half and slowly went to 1 and just did a good, there is no, there are studies that how much pulses you can give, but now they have come up that you can go up to 300 pulses at the single segment as well. So we went ahead, we gave the pulse, and it opened up quite well, and the DP is palpable. So it's almost 3 months now, and the patient, this was day 2, we removed the toe, and it's almost healed by now. So such a beauty of the device that you can go ahead and use lithotripsy. Now it's indigenous, Merrill has it, so that's another advantage. So another case, aortoiliac occlusion. I mean, it's not that we cannot do with our routine angioplasty, but you're looking at so much of calcification, we would be worried that this may rupture, we may have to put a covered stent. So that's the advantage of the, I would say, this balloon. So you go in, we know as of now we don't have a big size balloon, but then you can go ahead and do a buddy balloon technique. So you keep a normal balloon on one side, do a lithotripsy, so it won't have an effect on the side which there is balloon, but the other side it will work, and then similarly you can repeat from the other side and do, or you can take 2 balloons if cost is not an issue. So it gained, I think a good amount was gained, there was no dissection, and finally we thought whether to stent or not, but the right side osteo of the rod common iliac was not looking great, patient was really claudicant, so we didn't took a chance and we went ahead and did a kissing angioplasty. Good result, palpable DPs. So again, that was the advantage of using lithotripsy here. Another case with bad CFA, heavily calcified. You can see on the DSA image still. So sometimes we also wonder that how will wire cross. You can even see there is filling of the profunda through collaterals. So we knew that we may kill one vessel if we are not lucky. So we went ahead from antegrade approach. The wire didn't go into the lumen. You can see we struggled, and then we went ahead and came from below. So you can see the below wire is going into profunda but not into the CFA. And so we dilated that space because we were intraluminal. And then finally the 014 wire we could manipulate, and it went into the CFA. So you can see it was redirected and the wire found the path, and then we had a through and through wire now. So the another advantage with lithotripsy is it goes through 6 French, so you can even come from retrograde approach. We have done many cases with retrograde as well. Now we had access from below and above, and then after this was normal dilatation followed by, so normal balloon we know it's not going to open, but we made a way so that we can put our 7 mm balloon here, and then the lithotripsy was done. Sometimes the result won't be very optimal, but with so much calcification, you'll have to take a call that how much is too much. And you can see the profunda is feeling nice now. And then finally we decided there was some dissection in the proximal SFA. We went ahead and we placed a vasculomimetic stent, and the flow was great in both the vessels, and patient is doing fine. But this would have not been possible without lithotripsy. So I would end my talk here, that it's a great device, indigenously available, multiple uses, safe. The chances of distal trash is almost nil, and a great tool to have. Thank you. Thank you. Yes, sir. Yes, sir.
Agree that
yeah.
you would require to prepare the blood. I mean, you'll have to pre-dilate it because this is not high pressure.
Yeah.
I think it takes what, 4 atmosphere?
Max 6.
Maximum 4.
Max 6.
6.
Max 6, but they say the treatment is 4.
4.
But the new guidelines are coming, so they are saying like 2 is enough. 2 is
And you need to remove the air and all that. Preparation is very
yeah,
important.
I didn't tell the preparation is very important. Even a single bubble of air can cause the sonic waves not to transmit. So you have
Yes.
to really, really prepare it with 50% diluted contrast. That is a very important step. Yeah.
So now, sometimes people do ask, if you have these kind of calcification, is it atherectomy or IVL?
Yeah, yeah.
What would be your choice, and how do you kind of make a decision on that?
Sir, I think the way to go is, if it's a short lesion, a single kind of size of balloon where you don't have to open 2 balloons, I would go with IVL. It's a pretty safe thing, unless and until I know on ultrasound or CT it's like a thrombotic occlusion. So a lot of calcium causing occlusion, I would go with lithotripsy. But if I see like a cigar-like filling inside the lumen on a CT, probably I may debulk it. And then you can use, I mean, I know cost will increase, but ideal way I'm talking about is you can debulk, because this is not a debulking device. And then you can, to change the compliance, you can go with this. That's the way I think.
And drug-coated...
So again, sir, for aortoiliac, multiple studies are coming where they say like there's no need. So the Italian group is publishing lithotripsy right, left, center, and I have read their article where they are saying now they have stopped putting stents in common iliacs after using that. So what they are doing is they do a plasty on EVAS on groin. They see the waveforms are really, really great, because on angio still, because of calcium, they don't see properly and they are not using IVAS. So they just do EVAS because IVAS is not reimbursed. And they are publishing a study that initially they were really afraid that if they don't put a stent, it will occlude. Now, as the data is coming, they are saying that they are very confident to just do a lithotripsy in aortoiliac, and it's giving a fantastic
Let's
result.
pulverize the calcium,
Yes.
and
Yes.
long term is good.
So I don't know, still it's a gray zone, but as we all are used to in SFA and maybe in popliteal, we are using DCB. So no harm in using if patient can pay. But aortoiliac, honestly, I don't know the answer.
Yeah,
but
good high flow system and
yeah, so
take care of the calcium.
When we do
and
our aortas, we don't even give ecosprin. So that's the reason I think, yeah, it's working fine.
So yeah, a good device in the horizon, and we are using
And
it
it's
now.
indigenous, so that's
Yeah.
the advantage. Sir. Now we have,
Yep.
they're pretty, they'll come up with bigger sizes. That will be really good for us. Iliacs, and because 7, the most important thing is don't use an undersized balloon, even the same size
Yes.
vessel balloon. So
That's
go and
right.
oversize, because it's actually not a balloon, and just inflate it so that it touches. Doesn't matter even it's a 1 atmospheric pressure. It does a fantastic job. Yeah.
Great.
What is the cost per patient, sir?
So device is 3 lakhs. So in India, just remember that number. All the atherectomy devices, lithotripsy, excimer, they are close to 3 lakhs MRP, close to 2.9, 3. So, but still, I think without this, lot of procedures we won't be able to do. So don't use it for every case, but where it is required, it is required. No, no, you cannot. So once you open and connect, so there are pulses. So it gives 300 pulses. But once you disconnect and reconnect, I doubt you'll be able to use it.
So you want to reuse it in various patients, I mean 2 or 3 patients?
No, I was thinking that once we purchase, we can...
No, so there is a,
No.
there is something into that. We'll have to do a jugaad, because so it's a balloon with energy inside. How they charge it, there is a simple box like a battery. You put it in and press it, it recharges. So we don't have that. So you need that battery to recharge it. It's basically nothing. Energy is inside it. So that energy goes down after 300 pulses. So same balloon and energy can be put back, but I mean, ideally, it's not recommended, and we don't have that. We cannot. So the answer is we cannot. Thank you.
Not there, and probably end of the second day where a lot of things happened. So the attendance has been tremendous and good. But yes, at least it gave us a chance to know more about this therapy that we are doing. So can you just load it up? It's on? Great. So this is another new device which is up in the horizon, and we are looking at its benefits in patients with vascular disease. And this is a latest clinical study, and we have collected some data regarding solution SLR peripheral angioplasty balloon, which is drug-eluting balloon, and its use in peripheral vascular disease. Now, the regular life that we have gone through doing revascularization in peripheral arteries, we started off with plain balloon. Then we said, no, there are recoils and dissections. So we got in stents, and we felt stents were good in the acute phase, but in the later stage, it led to some stent fractures and restenosis. So to counter that, we said, okay, let us have drug-eluting stents, especially making the advantage of these anti-proliferative drug to prevent restenosis or delay restenosis. And then we said, okay, when the drug is on, things are good, but when the drug is gone in the late stage, you would again get restenosis. And that's where we started thinking that can we have drug-eluting balloons where we get the advantage of drug in the acute stage and there is no metal, so that in the long standing there is no problem with this. So basically the logic is leave nothing behind, no metal behind, no metal jacket is what the philosophy is in making these drug-eluting balloon. We have two types of balloons, paclitaxel and limbus based. Both sirolimus and everolimus are now in the market. So that is what we need to do. What are the indications for drug-eluting balloons? Well, a native de novo lesions, you don't want to put any jacket. It's not a bad idea, long, short, whatever it is, we can use this. Across the joint, which is again a challenging area for stents, one can use a drug-eluting balloon. Instant restenosis. Today, it is the most useful device in instant restenosis where nothing has worked. Small arterial disease, tibial vessels and things like that, we know we want to do something different and more effective. I think this could be a good choice there. Subintimal plasty, where again these atherectomy and debulking devices are challenged. You don't want to use it. We can use a DEB. Post-IVL, I will try and show you a case where we did IVL or an atherectomy, and then we have pulverized the segment and used an DEB. In future, people are also looking at its use in fistuloplasty, and if larger diameter balloons come in, we may use it in the venous system, is another thing that we are looking at. So the present era, as you saw, we had a discussion on Basel III, where we said that, oh, these drug devices are not of much use, and there's no difference between bare metal and POBA as compared to these devices. But we all discussed, there were a lot of shortcomings, limitation of that study, and therefore, I think this statement which is there by Semeneski, who said that because drug therapy has little risk to the patient and only can benefit, even if that means reducing the time to needing another intervention, is still a benefit in these class of patients. So there is a role for drug-eluting devices in the peripheral territory. The other counter regarding the same was that these drug devices were mainly, majority I would say, maybe 4 or 5 of these patients where sirolimus was used, otherwise they have all used paclitaxel-based devices. And even the sirolimus devices which were used were the old type, not the latest variety, and I'll show you the change between the two devices. There is no mention of latest vessel preparation techniques especially these IVLs and atherectomies, and where these drug-eluting balloons can play a good role and can give you a good long-term outcome in these patients. Now, as I said, there were two of them, paclitaxel and sirolimus. Paclitaxel is what came in first because it was easy to prepare those balloons, and it was found that it is easy to transfer this paclitaxel onto the vessel wall, and it retained in the vessel wall much longer because it was hydrophobic, lipophilic, and therefore it was much better. The important thing that you have to understand is that paclitaxel is a cytotoxic drug. I will show you what it means, and as again that sirolimus is a cytostatic drug, and that made the difference. And because paclitaxel gets washed out during the procedure, they need to put in larger dose, and therefore there is more toxicity and more distal embolization, and therefore paclitaxel versus sirolimus, there is a comparison which is going on, which we will discuss. Now, to load the drug onto the balloon, as I said, paclitaxel is much easier to load, but there is higher drug loss during manipulation, whether you are handling the catheter, you are introducing the sheath, blood flow, or balloon dilatation, the drug loss is plenty, and therefore what they do is, there is more than 2 or 3 times the drug that is required is loaded onto the balloon to compensate for the drug loss. And that's the reason these paclitaxel-based therapies are a little more toxic. Since extra paclitaxel is loaded onto the balloon, and often we would require large diameter balloons, we will require higher dose of drug. Therefore, this risk of cancer, which was discussed sometime back in 2018 by Castanos, it was a highly advertised paper, and which said to withdraw paclitaxel drug balloons was based on this particular phenomena. And even today, in 2019, the US FDA put it that, okay, you don't stop using it, but the patient should be informed, and that a consent has to be taken that in your case, we are using a paclitaxel-based device. Are you ready for this? So this has to be done. Now, what are the lessons that we have learned looking at various animal studies is that with paclitaxel drug-coated balloons, the muscle loss, the smooth muscle loss is much more. At the same time, because it is amorphous and crystalline form, it can get dislodged during the process, and you can get distal embolization, and therefore at a point of time, paclitaxel-based techniques were not used in patients who had underlying ulcers. If you use that and there was a deposition or embolization of this drug, the ulcer healing was a challenge in these patients. And most of these balloons that we have used, we have regularly used these balloons in the past. There was a high percentage of distal embolization and related inflammation in the territory. And if you see various studies that were conducted, all of them showed that there was actually a negative effect, and therefore probably Basel trial was right to say that these drug-coated balloons were not good and not effective, and one could do without them. But again, it was paclitaxel which was the problem. Now, because of it being a cytotoxic, paclitaxel being a cytotoxic, there were patients where post usage of paclitaxel in 6 months to 1 year time, there was a challenge where these blood vessels became aneurysmal. So this was another problem that was there with paclitaxel, and hence there's a question mark on that. And now this diagram is very interesting. This is the diagram or the way the cell division takes place. And when you see this, there are basically various phases that are there. And the cytotoxic drug, that is the paclitaxel-based drugs, you will see that it causes cytotoxicity and can cause actual muscle loss and smooth muscle loss, and that is what is the reason why you get aneurysm formation. Whereas when you see the cytostatic drug, that is the sirolimus, this is not there, and the drug will act and prevent proliferation of the cells but not cause any destruction of the cell. And therefore, it is a potent anti-proliferative, prevent activation of smooth muscle cells after vascular injury. It is a powerful immunosuppressant, and also it prevents cell anti-migratory agent and prevents apoptosis, and therefore this aneurysm formation is much less likely with sirolimus as against paclitaxel. These are the direct comparison that is there. They are similar. They both help to, as an anti-proliferative agent, inhibiting smooth muscle cell and endothelial cell proliferation, but there are certain things which are different. The anti-restenotic, yes, both are anti-restenotic. It is cytostatic, it is cytotoxic. The safety margin is 10,000-fold, whereas there is a 100-fold safety margin here. The therapeutic range is much wider, here the therapeutic range is much lower. The sirolimus is anti-inflammatory, whereas paclitaxel is not. The tissue absorption is low. Yes, that is the shortcoming of that, but the latest therapy or the latest design or the device that has been developed, all these areas where there was a shortcoming have been taken care of. Short tissue retention as against paclitaxel. So therefore, as you see, because of a fast tissue absorption and tissue retention, the paclitaxel was promoted, but there were a lot of other problems related to it. And if you designed or developed a good cytostatic sirolimus-based balloon, I'm sure the outcomes could be better. This is the picture that you see when you inflate a paclitaxel base. Because it is amorphous and crystalline, you will get this flaking that is taking place, and that is what gets thrown out. We see these patients, when you see if your drapes are dark, you will see white powder in the groin, which you have not seen. I've actually taken pictures when you use a sirolimus-based device, because the technology that is used to do the procedure, to do the bonding onto the balloon is different. Now, what is the new sirolimus-based solution SLR drug-eluting balloon? What exactly it is? It is a sirolimus which is in a micro reservoir form. You will see this micro reservoir like this, and it is a kind of probably compounded with a biodegradable polymer. So both of them together form a micro reservoir, and then that is loaded onto the balloon. And to maintain this into this balloon, they have a phospholipid coating to it. So this is the thing which prevents it from getting distal embolization or loss during the passage. So this combination of micro reservoir with phospholipid coating is the proprietary of the solution SLR, which is doing the trick and keeping the drug bonded onto the balloon till the time you actually deliver it into the vessel wall. This is a good this thing that how the phospholipid coating enhances the drug transfer efficiency. And there you can see that this is a solution SLR. More than nearly 40% of it gets transferred. Very little is lost during the whole process. Vis-a-vis, if you see the paclitaxel based, there is extensive loss that takes place both with the Lutonix as well as the Medtronics impact balloon, and that is where the whole challenge is, that majority of the drug is lost and the effect is much less. What is this change that the new balloon has brought in compared to the previous sirolimus ones? The older ones had a high coating complex procedure. It was a slower tissue absorption, shorter tissue retention, and it was less lipophilic. You needed a lipophilic to get it absorbed. What they have done, they have added the coating, which is a durable coating, as I told you. There is an efficient tissue transfer. There's sustained tissue retention inside the vessel wall, and homogeneous distribution takes place, and therefore the effect is much better. And you can see that the smooth muscle loss and endothelial damage because of paclitaxel versus sirolimus, the sirolimus, both the cytotoxicity and apoptosis is much less, both at the level of the smooth muscle as well as at the endothelial level was much less, and therefore the damage to the vessel wall is much less with this drug. These are the porcine models which we clearly shows that the smooth muscle loss is much less, and what you need is maybe a 1 microgram per millimeter square to be loaded onto the balloon to prevent any of this problem. And even when they have seen the distal muscle finding downstream, the embolic effect was much less compared to the paclitaxel. Again, inflammatory markers, whether you looked at interleukin, you looked at homocysteine, you look at CRP, leukocytosis, everything clearly demonstrated that with sirolimus, there was a decreased inflammation, and therefore it was much better to use a sirolimus in these patients. This is what happened because of its anti-inflammatory and because of its cytotoxicity. These are the cases where you can see pseudoaneurysm formation with paclitaxel. What are the latest devices? These are all OTW 135 centimeter, ideal for our peripheral work. It requires a 0.018 or a 0.14 wire. You cannot use it on a 3.5. That is one little deficiency, but this is what you'll have to see, that this wire is there inside. 2 mm to 7 mm diameter, lengths from 40 to 150. I would request the company to come up with more than 200, so that in one balloon, majority of our cases are done. Most often the SFA, we require 2 balloons, so that adds up to the cost, and therefore there is a cost issue. The total sirolimus that is loaded is smaller balloon 251, and the largest balloon is 3,300 micrograms, again within the limits which is recommended. And the only thing that comes up is when there is a longer length, you may require 2 balloons, and that adds to the cost there. The technique, again, all these devices, pre-dilatation, handle it carefully, don't just wash it, take a wet gauze and clean up the balloon. Don't do that. Just flush the inside lumen, handle it precisely, load it on your wire, and then protect it at the sheath, fast transfer to the disease site, balloon inflation for 2 minutes. In these patients, compared to paclitaxel, you may require a little longer dilatation. I normally keep it for 2 minutes, but I think recommendation is about 1 minute or 90 seconds. But I keep it for 2 minutes. Nominal 6 atmosphere, there is no need to a high pressure balloon. This is, as I said, you pre-dilate it, take a balloon which is little larger size and just inflate it for 90 seconds and you will get your drug loaded. Proof of the pudding is in the eating, and there you can see that clinical data that is available. Various studies that have come up have shown that the primary patency as well as clinically driven TLR is much better with solution SLR, and now we are looking at 36-month data that is available with a patency of 90%. So that is what is being looked at, and we are definitely looking forward to using these devices, and I have used quite a few of them now, and though it is a short period that I've used, so my data is still not available to tell you it is long-term what I've got, but I'm surely looking up to using this more in a lot number of cases. Now what does happen? What happens in a large vessel disease? Drug-eluting balloon reduces late lumen loss as compared to drug-eluting stents. It modifies the plaque, and there is remodeling of the vessel wall, and therefore, compared to DES, DCB is being looked at in the peripheral territory. I'm sure coronary, you go to these coronary guys and they would say that they are also looking up to using drug-eluting balloons vis-a-vis the stent. There's a famous Japan study which was there, which validates the safety and efficacy. As you see that the patient characteristic and the lesion characteristics are more or less what we see in our daily practice, long lesions, diabetic patients, and when you see the data that there's a strong patency outcome in 36 months, here you can see 81.5%, long lesions these are, And if you look at the clinically driven TLR at 36 months were 93%. So very good results. And if that is what it is, I'm sure this is a therapy that we would like to use it. And you can see that when you look at the Rutherford category, how these balloons have worked, that over the years, you would see that majority of the patients have definitely dropped the Rutherford characteristics from nearly 2, 3, and 4, coming down to 0 and 1 in majority of these cases. BTK, does it work? You know, complex problem over there, BTK. But in the small vessel also, various trials have shown that DEB is superior to DES. We rarely use DES in any of these BTK territory, but if you have to use it, DEB is the choice to use. 2 trials, Prestige and Pristine trials, again together these results have built momentum in treating BTK disease, an area of significant unmet need. This was the area that we wanted, something which will give longer patency, and that is where we are looking at. And there are a couple of more good trials coming out in US, solution for BTK pivotal trial, and we will get the data soon in a couple of years, and that will confirm how good it is. So both these solution, SFA Japan trial and the success PTA studies are proving that this particular device is definitely worth it, and it is being successfully used both in Europe and in Japan. These are some of the wide safety margin and anti-inflammatory benefit, sirolimus versus paclitaxel. And what was the shortcoming in the earlier days? The new devices which have come in with a micro reservoir and phospholipid coating has helped to take care of all that. So finally, if I have to tell you, it is a safe, durable vessel healing foundation solution SLR device. It protects the endothelium and smooth muscles, minimal risk such as aneurysmal change. It has an anti-inflammatory effect, and the Limus flow study shows that it shows reduced inflammation and preserve endothelial functions, and therefore this therapy is probably what will be the course in the future, and I'm going to definitely use it on a regular basis. Drug release, it takes about 90 days. This is an important question, how long the drug stays within. Because of the micro reservoir, it is gone up to 90 days now. Drug dose required is 1 microgram per millimeter squared. There is not much loss, so that is a good idea. And resulting in absence. So distal embolization is also less with this. It has a promising result. New data are coming out with new, both for SFA and BTK. The solution for BTK and SFA is what we are looking forward to in future. Specialized areas, Dr. Virendra just showed us use of IVL, and we have done few cases doing IVL with a drug-coated balloon, and we have seen that the technique is called crack and drug, and that has been proving to be good in these areas, some of these areas. I'll quickly show a couple of cases. He showed us one common femoral, again, extremely obese patients, and there was a tight occlusions at the common femoral. Profunda was the only collateral, which was a nice big collateral reforming distally. We didn't want to do the whole of SFA. It was just a claudicant. We opened up this and put a drug-coated balloon here, post-IVL, and you can see that now it is nearly 2.5 years. At that time, we didn't use a solution SLR, but we used a drug-coated balloon here and got a good result. Here is across the joint, another good case for using a drug-coated. A POBA and a stent was done, and there in a year and a half, there was a restenosis, and we again used solution SLR that you can see here, and we got a good result here in this patient, and we are waiting for a long-term outcome in this patient and see what happens. A third case of a tibial vessel, can we use it? Yes, there was a great toe wound, and at that point of time, PTA was done in 2018, and we used a bioresorbable stent, which worked very well for nearly 5 years, and there was a research, 6 years nearly now, 2018 to 24, 25, and then this time we went and we used a 3.5 into 80 solution SLR drug-eluting balloon, and we are again happy with the outcome as of now, but in the long run we'll have to see. Once we dilated that, you can see there is hypercirculation at the site of the wound, and we are hoping this is one of the indicators that probably the wound will heal better. One of the last case, 64-year-old diabetic smoker, non-healing ulcer, pain, extensive PVD with calcium. As you can see that over here, extensive tibial vessel disease, the SFA popliteal was okay, and in this patient, the arch was forming, but the circulation was low. You can see long segment PTA and proximal ATA block, and we went ahead, retrograde puncture, went up there, did balloon dilatation, and did a drug-coated balloon here, as you can see that. Post-balloon plasty, this was the outcome. And then finally, we used multiple SLR. There you can see that one over here. We went into the posterior tibial also and opened up both the segments and formed a good flow, 2-vessel runoff in this patient, and this was a good outcome in this patient. This patient I have just done, before coming here, there is a tight, complete occlusion at the common femoral, profunda good. This is an osteal lesion. You don't want to put a stent there. You don't want to jail the profunda. So, so we went ahead, recanalized it. Retrograde approach was necessary. There was a stenosis in the anterior tibial single vessel runoff, and here again we used pre-dilated it, and we used 2 balloons in the SFA and 1 balloon in the anterior tibial, and this was the result post. You can see that very good outcome. I'm sure we were through the lumen. This is not subintimal plane. You can see clean wall that is there over here, and anterior tibial flow is good, and the flow to the foot has improved. I'm sure the ulcer will heal. So thank you very much. Future technology, we all should keep our eyes, ears, and mind open. Thank you.
Agreed, sir. I think the world is moving from paclitaxel to sirolimus. And as they say, Japanese are very stringent. And when they have come up with a study, I think there is something in the balloon.
Yes.
They don't accept, unless they do their own, so they don't even accept FDA.
Yes.
So I'm hoping it will change.
So that was the reason we thought we just present both SFA and BTK study has been done in Japan, and they have given good outcomes. So, and I think it's on a regular use now over there. It's a good device that we are looking forward to.
Thank you, sir.
Thank you very much. Yeah.
The drug is lasting for 90 days, as you said. So does it change the management by antiplatelet doses?
No, no, the antiplatelet therapy remains the same. This remains in the wall, and that when it remains or retained in the wall, it is anti-proliferative. So the smooth muscle cell and endothelial overgrowth does not take place, which is the cause for intimal hyperplasia that we call it. So it prevents that.
Thank you, sir.
Great. Thank you.